AIIMS ऋषिकेश हम हैं AIIMS ऋषिकेश विश्वरोग्यं हि धर्मणः विश्वरोग्यं हि धर्मणः विश्वरोग्यं हि धर्मणः विश्वरोग्यं हि धर्मणः AIIMS ऋषिकेश हम हैं AIIMS ऋषिकेश विश्वरोग्यं हि धर्मणः विश्वरोग्यं हि धर्मणः AIIMS ऋषिकेश हम हैं AIIMS ऋषिकेश विश्वरोग्यं हि धर्मणः विश्वरोग्यं हि धर्मणः विश्वरोग्यं हि धर्मणः विश्वरोग्यं हि धर्मणः AIIMS ऋषिकेश हम हैं AIIMS ऋषिकेश विश्वरोग्यं हि धर्मणः विश्वरोग्यं हि धर्मणः
medications like methotrexate, hydroxychloroquine, folic acid, steroids and all. It is will be harmful for the patient like in long term. So using FFP, we can use it as a dose reduction technology till HSCT, the medicines of transplant. Till then it can be used.
Cross match in which we are to address both the typing screen and type pen cross matching. Typing screen we are doing for each and every request of the home scan or other departments. We are doing typing screen for all the patients. The issuance, the cross match are the ones which we see the clinical analysis, the medical parameters of the patient. Cross match to transfusion issues and match type of
इधर आज पिक्चर क्लिक करा
टाइम लेके चल रहा है आफ्टर द CME कुछ नहीं है हेलो सर कैसे हैं
रोशन है academic celebration, the CME on Patient Blood Management, Advancing from Product to Patient, which is being organized by Department of Transfusion Medicine, AIIMS Rishikesh, in collaboration with International Society of Blood Transfusion, Amsterdam, the Netherlands. We just had a day packed with learning, sharing, innovation, and we started it on just the right note with this spectacular walk and talk poster presentation. The energy, the curiosity, and the scientific brilliance we witnessed was nothing short of inspiring. Let me also take a moment to stay tuned till the evening, because more exciting prizes waits for the evening for our best poster presentations. So yes, the celebration is both academic as well as inspiring. So now let's dive into our first scientific session of the day, which is learning basics to usher into the world of patient blood management. This session will focus on the core principles, practical applications, global perspectives of the patient blood management, which is the very foundations of today's discussion. Now I would like to invite our esteemed chairpersons for the session 1. First, I'd like to introduce Professor Preeti Ilhans ma'am. Professor Dr. Preeti Ilhans ma'am, she is the head of the department at SGPGI Lucknow. She has been the founder and the ex-HOD of the Department of Transfusion Medicine at Ram Manohar Lohia Hospital, Lucknow. And she has been serving as the head of the department at SGPGI since 2000. Ma'am has been awarded as the Princess of Wales Award by British Blood Transfusion Society, and her area of interest are immunohematology, transfusion safety, patient blood management, cold store platelets, and various other aspects of the transfusion medicine. Now I would like to invite our second chairperson for the session, Professor Dr. Ratiram Sharma sir. Sir is the professor and the head of the department of PGIMR Chandigarh, and sir has a vast experience in the transfusion medicine field. Sir has been serving since last 28 years, and sir has been the key development of the curriculum of the MD program of transfusion medicine at the institute. Sir has been a recipient of the prestigious J.G. Jolly Award and the H.D. Shorey Award by the Indian Society of Blood Transfusion. Sir has various research papers, and sir has been members of various national as well as in the international societies. Now I would like to welcome I would like to invite our chairpersons for our first speakers of the session.
Good morning. It's my pleasure to introduce Professor Ravi Kaur. He is Professor at the Department of Transfusion Medicine at GMCH Chandigarh. He has been the member core committee of Immunovigilance Program in India, member technical resources and BBC, editor of the Asian Journal of Transfusion Science from 2012 to 17. He also has, to her credit, Award of Excellence by UT Government Chandigarh in 2023. He has been awarded Lifetime Achievement Award in 2022. He has been awarded J.R. Jolly Award in 2012 for her vital contribution in the field of transfusion medicine, and she has, to her credit, 70 publications in national and international journals. It is a real pleasure to hear you. Welcome, Dr. Ravi.
Thank you, ma'am. Thank you for the kind introduction. And good morning to all. First of all, I'd like to thank Dr. Geeta Negi and her team for giving me this opportunity, and also congratulate Dr. Geeta and Dr. Daljit and their team, I think, for this organizing this CME. We have been really enjoying their hospitality since late evening, and also when we came to this venue, it was really very good to see the outside and everything. Everything is very well organized. Congratulations to you. So I'll be talking about patient blood management concepts and attainable gains. Well, we all know that blood is a scarce and precious resource. A very high cost is involved in this. And of course, there is very high demand for this because of many patients, they require this blood. And supply is always a challenge. To provide safe blood at the right time is always a challenge. And above and all, we know that inappropriate transfusion practices are followed. And transfusion is associated with risk, both infectious and non-infectious. And these transfusion reactions, they can be either asymptomatic, mild, or they can be potentially fatal. So keeping all this in mind, there came a concept of optimal utilization of blood and blood component, which said right blood or blood component to the right patient at the right time and in the right dose. So this was what we call as blood-centered approach. Here, the main concern, the main stress is on your blood or blood component. It was further expanded and people started talking about appropriate transfusion of blood and blood component. It was said that give the transfusion whenever it is required. If a patient has anemia, look at the signs and symptoms or look at the hemoglobin threshold and then give the transfusion. So all this emphasized on corrective measures, that is giving transfusion either preoperatively or postoperatively, focusing on treatment of symptoms rather than preventing occurrence or managing the underlying condition. But it was realized that even this appropriate red cell transfusion, they are avoidable through patient blood management. So this is one of the study which I am quoting, in which two set of colorectal surgery patients, they were enrolled. One was given treatment for iron deficiency and they were infused iron, and the second group was not treated for anemia. So what the authors observed, that the group which was treated for anemia, only their 9 patients required transfusion, while the other group, 29 patients, they required the transfusion. And overall, in treated group, 149 RBCs were transfused per 1,000 admissions, while in another group, which was not treated for anemia, 402 RBC units were transfused. So this all happened with patient blood management. Now let's try to understand what is this patient blood management. Patient blood management is basically your patient-centered approach. It concentrates on the patient. So what basically drove to the transfusion medicine people started talking about this patient blood management, and what drove them towards this was to develop the techniques wherever the transfusion was not possible, like in war situation or any other situation where we could not get good supply of blood and blood components, to develop those techniques, or to have blood conservation program for Jehovah's Witness. We all know that this class particularly, they don't accept transfusion. And the third was the concern for transfusion associated complications. Now, this is some very busy table which I have taken from one of the articles, but I just want to show this table because the concept of PBM is dynamic and has been evolving continuously. So the first definition, one of the first definitions, they were given by Society for Advanced Blood Management, which said that appropriate, they talked about appropriate provision of blood and blood components. So this subsequently it kept on evolving, the definitions were being revised, and WHO gave this definition in 2020, which said that a set of evidence-based practices to optimize medical and surgical patient outcome through preservation of patient's own blood. But here again there was an issue that one of the things which came was evidence-based transfusion. So here people started talking about that giving transfusion following the clinical evidence which is possible. But here the patient was not talked about. Subsequently, one of the definition, it talked about multidisciplinary approach. But let's look at what is the latest PBM definition, the global definition. It says patient blood management is patient-centered, systematic evidence-based approach to improve patient outcome by managing and preserving patient's own blood while promoting patient safety and empowerment. So let's understand few of these words. Patient center means care that is respectful and responsible to individual patient preferences, needs and values. Systematic is an organized, uniform approach. Evidence-based, it is integration of best available research evidence with clinical expertise and patient values and preferences. Look at here, they have also in evidence-based, they are saying that we have to consider patient values and preferences. Managing means it includes the diagnosis, treatment and follow-up. Then preserving patient's own blood. Measures to preserve patient's blood should be applied, which include surgical procedures, iatrogenic and coagulopathy blood losses, and patient-specific anemia treatment. Then patient empowerment. Patient should be preemptively informed of their diagnosis, prognosis, treatment option and alternatives. So this is what is patient blood management. It has to be patient-centered and it involves the patient also. Now, if you look at this diagram, again, I have taken it from one of the manuscript and it says that the concept of patient blood management has evolved to the prevention model of the healthcare system, where they have said that the various interventions should be such that it affects the prevention, it leads to the prevention of the healthcare system. And like the first stage, they have said, they are divided into 4 categories, and the first one is primordial, where they have said that you have to focus at the societal factors which can lead to ill health. You have to control those factors. And the second, primary prevention, that is, you have to prevent the disease. You have to treat the anemia right before it starts. So that is the place, is your primary intervention. And then is your secondary prevention, that is you prevent, you diagnose the disease well in time. You do the testing, you do those diseases, you look for those diseases well in time, you diagnose them so that you can prevent the further complications which can lead to the extreme end, that is your blood transfusion. And the tertiary prevention is actively treat and you have to prevent the, I think the light effect is so much that you cannot read your slide anyway. And the last is your quantity. So this is what it has, the concept has involved into the prevention model of the healthcare system. So to summarize, it is a proactive care aiming to improve blood health of the population. So we are aiming to improve the blood health of the population with the patient in the center, protecting and preserving the patient's own unique blood. So this is what is your patient blood management. So it has 3 pillars. For the patients who have to undergo surgery. So it has 3 pillars. Pillar 1 is optimize patient's own blood cells, that is you manage the anemia. Second is you minimize the blood loss, you prevent bleeding, and third is you optimize patient's physiological reserve in relation to anemia, and you try to avoid unnecessary transfusions. So these are the strategies. I think a lot of people and the subsequent talks, they'll be talking about this, but just a glimpse of it, that in pre-operative phase, we have to manage anemia and diagnose treatment. Then we have to optimize coagulation, and we have to, we can give even pre-operatively, we can think of autologous blood donation. In the intraoperative, we target to reduce the intraoperative blood loss, which could be by meticulous surgical techniques, maintaining normothermia, or many other things which a lot of surgical and people may be talking about. Then acute normophilic hemodilution. Then we can use point of care testing and antifibrinolytic medications. And in the post-operative, we have to adhere to single unit transfusion concept. We have to follow restrictive thresholds, reduce phlebotomy, frequent phlebotomy to avoid blood loss, and we can even think of post-operative blood recovery. So just a few, I'm taking it with the two examples, trying to explain it. Like we have a 68-year-old woman with osteoarthritis. She's scheduled for elective total hip replacement. She has a history of hypertension. She's a patient of chronic kidney disease, stage 3. Her hemoglobin is 9.5 gram per deciliter. MCV is low, ferritin is low. She has an iron deficiency, and creatinine is at towards the higher side. So the pillar 1 will be, we'll try in this patient, we should try to identify and treat anemia as early as possible. We can, if we have a little short time, we can give oral, we can start with oral therapy. If very short, then can give IV iron therapy. We can consider giving ESAs, and we can postpone surgery if required. Doesn't mean that we have to give transfusion and go ahead with the surgery. Second will be, during the surgery, we'll try to minimize the blood loss by using these various interventions, like we can use tranexamic acid, apply meticulous surgical techniques, we can consider cell salvage if it is present, and we should avoid unnecessary phlebotomies during that period for blood sampling. Then pillar 3 is tolerate anemia. If the hemoglobin is, like in this case, if it is 8.2 gram per deciliter and patient is stable, so we have to consider whether ideally we should avoid transfusion at this hemoglobin. We should try to monitor and support and use restrictive transfusion models. Second case, 32-year-old, gravida 3, para 2 female, 24 weeks. She has a placenta previa major, which is confirmed by ultrasound. She has 2 previous C-sections. She has mild anemia. She doesn't have any coagulopathy, and she's planned for elective cesarean section. So again, in this case, we can have these pre-operative, intraoperative, and post-operative interventions. We should try to, in the pre-op, again, anemia should be diagnosed at the earliest. We should start with the therapy. At 32 weeks, we can think of shifting to IV therapy. Vitamin B12 and folic acid levels should also be monitored. Intraoperatively, it would be a multidisciplinary approach. Everybody should be informed, well informed. The obstetrician should inform anesthetist, hematologist, blood transfusion services. And since it is a scheduled elective cesarean section, we can think of giving tranexamic acid, cell salvage if it is present, and other measures which we can do to prevent the blood loss. Then again, post-operatively, we should think of restrictive transfusion thresholds. We should have a close hemodynamic monitoring of the patient. Start post-operative iron supplementation if required at the earliest, and give psychological support and counseling to the patients. Now coming to the second aspect of what are the attainable goals of this PBM? I've already talked about, it would lead to improvement in global health. It will improve patient safety. It will reduce the unnecessary transfusion, and because of which we can have improved inventory of allogenic blood available for the patient with clinical need, and again it will lead to reduced healthcare cost. So again regarding this, lot of literature is available, and one of the study in which they try to assess the effect of PBM. So they reviewed their records before implementation and after implementation of the PBM, and they found that the red cell transfusions, they've decreased. People started following their guidelines, and even the cost was reduced. And of course, we all know that PBM can play a good role during the time of pandemics. During COVID-19, lot of things were talked about COVID, this patient blood management. And if you look at the literature, lot of evidence, lot of review articles are available which people they wrote out during that period, and they called everyone to follow this patient blood management strategies. So to conclude, PBM is a multidisciplinary concept of care where all members of the healthcare team, including the patient, is involved, and it aims to preserve patients' own blood and enhance patient outcome. Thank you.
Thank you very much, Dr. I think we can take questions at the end of the first session.
Yeah, thank you. Now, I think we call upon the next speaker for this session. I have the slide, please. First of all, I would like to congratulate Professor Geeta Negi and her entire team for making this a great event, and her thoughtful, basically, arrangements actually. So I think if we want to organize any CME, we must take advice from Dr. Geeta, or we need to include her in the organizing team. So I think regarding the speaker, I think I am delighted that today we have Gopal Pattidhar, and I am very happy that he is my own student from my institute. He is additional professor at All India Institute of Medical Sciences, New Delhi, and he has a lot of achievements. Presently, I think recently he has been elected as the chairperson of Vigilance Working Party, ISBT, and chairperson of many other groups of ISBT, and he has good number of publications and awards to his credit, like Harold Benson Fellowship, Award of Excellence from ISBTI in 2020, and Young Scientist Award from Indian Society of Transfusion Medicine. So I think Dr. Gopal shall be enlightening us on gathering insights through data-driven PBM decision making. Over to you, Gopal.
Thank you so much, sir, for the kind introductions. And thank you, Dr. Geeta ma'am and Dr. Daljit ma'am and Dr. Ashish for inviting me and giving this opportunity. So today I will tell about the data-driven PBM decision making. As madam already mentioned about the basic concept of the PBM. And so first of all, I have no conflict of interest. And I will conclude my talk in the way why data is important in the healthcare, what data is important for PBM, then PBM on anemia management, blood conservation, post-procedural prevention of blood loss, and overall cost effective. First of all, why we are reading the data. In healthcare, data first of all providing us a evidence-based decision. Like there are so much publications related to many healthcare diseases, even as well as the PBM. So by this publication, by this data, we can finally make an evidence-based guideline that how we can use and how we can further improve our healthcare services. Then we can identify the practice variations between different institutions, between different nations, internationals. Then drive the resource optimization, how we can reduce or optimize use our resources in the healthcare services. Then improve overall, our aim is to improve patient safety, then facilitate cost saving, and finally innovation and research. So this concept we also apply in our patient blood management. So for patient blood management, what kind of the data is important, or what are the indicators of patient blood management? First of all, how much we are adherence to the transfusion guidelines. Then preservation of the blood supply, how we can preserve our blood supply or resources through the patient blood management. Then what are the rate of blood component transfusion as well as the wastage. Then rate of adverse transfusion reactions, how much number of the adverse transfusion reaction we can prevent from the patient blood management. Then patient outcome assessment such as mortality, length of hospital stay, ICU, and etc. And finally, the blood cost saving. So, as madam also mentioned that there are so much data, so much publications is available, so it's difficult to cover all the data. But I basically took the three objectives from the all three pillars. First one is anemia management, then blood conservation and post-procedural prevention of blood loss. And I will explain how the PBM data can fulfill these indicators like blood component usage, how they can reduce the improve the patient outcomes, and how they can provide us the cost benefit. Then start with the preoperative anemia management. So this one is the nice publications which were published in 2012 about the effect of PBM program on preoperative anemia, transfusion rate and outcomes. So in these publications, Korze et al., they used the cutoffs for the surgeries, like knee surgery and the hip surgery they used for that things. And for the knee surgery, they decide their hemoglobin cutoff, that at what hemoglobin cutoff they want to do the surgery. And to get their absolute hemoglobin, they provide the iron to the patients. If they have the time, sufficient time to provide the iron, then they provide the oral iron. If they have not that much sufficient time, then they provide the IV iron. Similarly, they use decide the cutoff for the hip surgery, and similarly they provide the IV iron and the oral iron. So in their study, out of 72 patients, 52 were treated with the irons, and similarly anemic patient and non-anemic patient also treated with the iron if they required. What they found in that one? They found that out of before PBM and after PBM, the receiving of the allogenic blood transfusion is so much reduced in both the surgeries, hip replacement as well as total knee replacement. There is significant reductions in the hip replacement, and even in knee replacement, almost zero patients require the blood transfusion after PBM implementations. Similarly, in terms of the patient outcomes, they found that length of the hospital stay is also decreased in both the surgery, as well as readmission within 30 days and 90 days also reduced because of the PBM effects. Similarly, another study in which they have very short term times, like in previous study they have sufficient time, they provided the oral iron and they improve the hemoglobin. But here we have very, very short times, so they provided only IV iron to the patients. And with IV iron also they found significant improvement in the patient transfusions as well as the transfusion index. In this in control group, there almost 48% of the patient received transfusion, while in PBM group, iron and erythropoietin, only 32% received the transfusions. Similarly, in patient outcomes, they also found a significant improvement. In post-operative infections, they found only 10.7% have the post-operative infection compared to the 26% there. Then similarly, 30 days mortality almost reduced by the 50%, and the length of hospital stay also reduced in the PBM group. Now, what's the effect of the PBM on the overall cost? In this study, they compared the dose of the PBM iron and compared with the blood cost, and they found as much as they improve the dose and they improve the patient outcome, patient hemoglobin, the cost is also reduced. Almost 60 to 70% cost reduced with the oral iron. Similarly, almost 60 to 65% cost is reduced with the IV iron as compared to the blood transfusion in that way. So, preoperative anemia management with the iron, it reduced the transfusion rate and index, as well as it have almost similar HB at the time of the discharge of the patient, and ultimately it improved the patient outcome by reduced complications, reduced length of hospital stay, reduced mortality, length of ICU stay, and the readmissions. So in this, this is for the preoperative anemia. Then in second, blood conservations. The blood conservation is primarily use the appropriate transfusion indications as well as the conserve the blood intraoperatively. So how we can conserve the blood? The first, we can conserve or we can prevent inappropriate transfusion by the adherence of the transfusion guidelines. There are so much transfusion guidelines published related to the plasma, platelet, and RBCs. So if we adhere to these guidelines, we can save so much of the blood transfusion in the patients. The very famous ONTRAT trial is there in the Canada Blood Transfusion Services. They longitudinally trace their transfusions with the adherence to the transfusion guidelines from 2002 to 2020. In this, they primarily took the two surgeries, the single knee arthroplasty and CABG surgery. So you can see in single knee arthroplasty, almost transfusion reduced to the zero only with the adherence to the transfusion guidelines. While in CABG surgery, also the requirement of the blood transfusion is so much reduced compared to the pre-era. Similarly, another very nice article published in the Nature. In this, they compared both the groups with the appropriate transfusion and inappropriate transfusions. With the consecutively comparison of the different months, they found that at that point, they already met before the COVID evolved. Before COVID evolved, they reduced the inappropriate transfusion and increased the appropriate transfusion by the just adherence of the guidelines in these things. Similarly, they evaluated in the different kind of the departments like surgery, ICU, oncology, and medicine, and everywhere they found a significant results by the just adherence to the transfusion guidelines. In our institution also, at the time of the COVID, we try to preserve or conserve our blood resources, so we can reduce the transfusion index in the platelet as well as the RBC at the time of the COVID lockdowns, and so much preserve our blood stocks we can maintain over there. The third point is the patient outcomes. In patient outcomes, these JAMA publications, they have systematically reviewed so much publication previously published related to the transfusion guidelines adherence. In this, they found that in many of the publications, they found the improved patient mortality with 30 days mortality as well as the in-hospital mortality, then 45 days mortality, and the thrombotic events or other complications related to the transfusions. Now it comes towards the cost effectiveness. The cost effectiveness and budget impact analysis, this publication recent publication in 2024. In this, they reduced their transfusion index with the application of the PBM, the erythrocyte transfusion by the 20%, platelet FFP transfusion by 38%, then platelet transfusion reduced by 37%, and total 23% transfusion was reduced. By this reduced transfusion, first of all, they found the improve in the complication or reduce complications there. The sepsis is also reduced so much, almost 40%, then renal failure is reduced, myocardial infarction and stroke is reduced. With that, they found that so much cost they are saving with the PBM implication is there. In this, by the only transfusion cost is saved by the 43% in that country. While overall cost they have reduced by the 17% overall cost of the related to the complication saving and the patient admissions and patient mortality, they reduce almost 17% saving of the cost. So in another studies, that was study of the single hospital in the single department, this is study of the overall Swiss study of their country, and they saved almost crores of the rupees with the just implementation of the PBM program over there, 28 to 40 crores rupees with the consecutive years they save with the PBM implications. Similarly, I thought that why I can try in my institution that how much I could save if I implement PBM during these years. So these are data from the 2021 to 24. The transfusion is, only PRBC transfusion is almost 41,000, 47,000 in all 3 years. If I applied PBM, I can reduce by the 20% reduction is I thought. So by this, I can also save the crores of the rupees in my institution if I implement the PBM. But hopefully, I will do in the future, so I can save this thing. So the third point is the post-procedural prevention blood loss. In this, like we all know, we are getting the blood from the patients at the time of the ICU admission because of the so much samplings. So we can reduce over the sample vial. We are not vampire, we can take the blood only till a mosquito is required and we can do all the tests over there. So how much we can save in that way. So these publications is there in the 2021 by the iatrogenic blood loss per day blood loss was almost 21.7 ml blood loss overall, and it is higher in the transfused patients as compared to the non-transfused patients. There is higher amount of the blood they take in from the transfused patient as compared to the non-transfused patient. And they evaluated in the multiple patients admitted since long times, and they found that almost 1 unit of the PRBC blood they are taking just for the sampling, just for the testings. If they reduce their standard tube size to the low volume tube size, they can save almost 200 ml of the blood over there. That is equal to almost over 1 unit of the PRBC is there. Similarly, the another publications recently Strauss randomized control trial published in the JAMA, and they also found that with the help of the decrease after transition from the standard volume to the small volume tube, 9.84 RBC units per 100 patient per ICU stay they can save. So much amount of the RBC you are taking from the patient just for the sampling with the large vials in over there. So you can save with these things. The another nice publication in which they use the blood saving bundles. In blood saving bundles, they combined the closed loop arterial blood sampling system, smaller sampling tubes, then reduce frequency of blood drawings and reduce samples number. By this, they save, like in control group, the arithmetic mean of the ICU day blood loss is almost 43 ml, compared to the in blood saving bundle it is just 15 ml. Similarly, per ventilation day is 48 ml to 16 ml, and non-ventilation 35 ml to the 11 ml is there. So by that, they also found the improvement in the patient outcome over here. In ICU days, there is so much reduced in the significant reduction in the ICU days from the 13 days to the 9.9 days. Similarly, ventilation days also reduced, non-ventilation days and total hospital stays also reduced in these things. Now, little bit more about the cost saving, because cost is most important nowadays. So one very nice study is published, activity-based cost of the blood transfusion in surgical patient at 4 hospitals. In this, they took all the activities involved in the transfusion process, start from the donation or blood retrieval to the final transfusion outcomes. And in this, all 4 hospitals, they found that most of their cost is going to the indirect order use. The direct cost is so much less as compared to the indirect. Almost 30 to 40% cost is in the indirect activities related to the transfusion. Then second group is the product acquisition cost. As in the Western countries, they are getting blood from the centralized blood, and then the pre-transfusion testing, patient blood testing process and administration. And so much cost we are giving into the indirect as compared to the direct in these things. So in the last, there is the publication in the Anesthesia. In this, they are mentioning that why we are reluctant to the patient blood management, what are the primary reasons that we are reluctant to the patient blood management. So in this they identify 3 domains primarily as a waste domain, which we can use better, and 2 domain is the improvement domain, which we can improve in their one. In waste domain, the first one is the failure of the case delivery, like in this the under recognitions or under treatment of the anemia and blood loss, inadequate educations, lack of formal PBM programs in the various levels. If we improve here, we can easily get the PBM over there. Then second one is the failure in the cost definitions, like despite institutional capability and capacity, no assigned responsibility over there, and no reimbursement of the PBM. If someone is leading to the PBM, there is no reimbursement over there. The third one is the over-treatment, like avoidable transfusions is persist still after so much effort, and inappropriate transfusion is persist over there. And then the 2 are the improvement domain, where ignoring the impact of the mild or moderate anemia over there, ignorance of the consequences, diseases or patient outcome over there, depending budgetary also is within the organizations. And finally, the optimal blood use and the blood view about the unrealized potential for the PBM is there. To overcome this, they provide a concept of the 3E, which if we follow, we can easily improve in the PBM field. First one is the ethics, then evidence, then economic. Ethics, which stakeholders are obliged to add, they have to do in that way. Evidence, that stakeholders are alerted to add with getting the evidences of the previous publications. And finally, the economics, through which we can save the blood cost over there. In ethics, the self-evident ethical objectives like clinician should adopt the PBM is with respect to the patient autonomy. Then clinician should manage to the patient on blood with same respect. Then health administration is health authorities can help in the improving the PBM, and blood providers also should show the respect to the donor as well as the PBM. Then there are so much evidences are available, the sufficient peer-reviewed evidences are available. Clinicians should adopt this PBM through these evidences. And finally, in economics, the saving potentials of the macroeconomic magnitude, like we saw in our data, there's so much cost we can save through implementation of the PBM. So with the 3E principle, we can easily implement in PBM in our institution or the country. So thank you so much. So we can start with evidences like inappropriate transfusion is injurious to patient, as just similar to the secret. Thank you so much.
Thank you, Dr. Gopal. I think you have very nicely covered the insights and given a nice overview that how we can decrease the patient care cost by implementing when we wisely implement various PBM principles. Now I think in continuity, the next talk in this session would be by Dr. Ajay Gandhi on world panorama on PBM perspectives. I think Dr. Ajay Gandhi is a very well-known figure as far as PBM is concerned. I think he is the one who has been pursuing this for last more than a decade or so in the country, and he has started many courses through Varfan. And as you see, although he requires no introduction on this, but as customary to this event, he is Director of Clinical Affairs of Varfan. His introduction slide, please. Yeah. So, Director of Clinical Affairs, Clinical and Medical Affairs from Varfan, and he has. Anyway, I think he has been credited to taking this initiative, as I already mentioned, has been taking courses, regular courses on PBM, and I think I had an opportunity to be a part of this. And he is adjunct faculty in hemostasis, thrombosis, ELK Max Super Specialty Hospital, New Delhi, and recipient of many gold medals. I think since his medical school, he has been a gold medal recipient, and then his areas of expertise primarily on hemostasis and diagnostics, hemostasiology, anticoagulation, antiplatelet drugs, and I think primarily encompassing the whole spectrum of coagulation. So we welcome you, Dr. Gandhi. The floor is yours.
Thank you, sir.
Thanks for coming.
Thank you, sir, for the introduction. Namaste, everyone. Thank you, Geeta ma'am, Dr. Daljit, and AIIMS Rishikesh, and of course ISBT for organizing this wonderful symposium. Thank you, Ravneet ma'am, for making it so easy to start with the concept. So I can look at ma'am, yes. And thank you, Dr. Gopal, for taking us through the data. I would like to contribute a little bit on my perspective on the topic today, which is global panorama of patient bed management. Yes, this is something which I can start with. There's a lot that we have done in the last decades, and I think there is still a lot that has to be done, and that is the reason why we continue to have this endeavor of education and awareness creation, sharing amongst ourselves. The more we do it, the more we discover that we have a lot more that can be done. Anyways, going back to the early days, I think all of you now know that this is a gentleman responsible, Professor James Isbister, who started all this. The only thing I would like to add, I'm not giving you the definitions of patient bed management. It all starts with blood conservation. I think that is the first principle we have to keep in mind when we're talking about patient bed management. Blood is something which has to be conserved, and where it can be best conserved is within the patient itself, and that is how the overall idea originated. People talking about WHO came to the party, 2010 Geneva Convention started giving up, a mandate to all the member nations, 160 plus member nations, to implement gradually over a period of next 20-30 years to implement the patient's principles and practices of patient blood management. That is where the 9-field 3-pillar matrix of patient blood management came into existence. So, if you look at the evolution of PBM outreach, which started a couple of years after WHO gave its mandate to the member nations. So this was in 2012. You can see clearly Australia being the pioneer of everything that we know in terms of principles and practices of patient blood management has been the pioneer. We had a little bit of it in the China side, although I doubt that this is the correct representation of the practices in China. No offense to China, by the way. Yes, a lot of it was also relevant in the North Americas. Primarily because of they wanted to be me first kind of approach there. This is the situation until last year when we have seen it has evolved from pockets to almost the entire globe that we see. You see a lot of countries coming to party. Australia continues to remain in the driver's seat. Latin America came very much ahead. In fact, this was one of the earliest countries to have, after Australia, their own national guideline, which was mandated as a public policy. And then we see in bits and pockets everywhere. We're happy to see India also now doing good in terms of in terms of adapting as well as rightly practicing or implementing the principles and practices of patient blood management. Yes, this is the governing ecosystem today. These are probably the most popular, the most authentic bodies and associations across the globe which manage patient blood management, and I'm happy to be a part of each one of them. I've seen their constitution, I've seen their practices, and they've been really having the mission of implementing it from the basics till the very advanced. Ma'am has already discussed the definition of patient blood management. I don't want to just repeat it again. What I really want to focus is that yes, it has evolved. There is a bit of truth into it that it is evolving more than the pace at which it can be perceived. This is the negative part of it. I'll explain in the next slides why I'm saying those things. Now, this is something which has been discussed by ma'am, but what I really want to focus now, which is now globally adopted, is patient safety and patient empowerment. Patient empowerment is something which we really have to understand that this has to be the key, this has to be the driver. Many people come and ask me, who should be the driver, who should be the the leading person in a particular institution, in a region, in an association to be taking patient blood management forward. It's not the anesthesiology, it's not the transfusion medicine, it's not the hematology, it's not the surgeons, it's not the obstetricians. It is the patient, and everything has to be driven around the patient. And how? I'll tell you in the next slides. So yes, it was adopted nicely, and if you look at the cloverleaf model of patient blood management, now this is not the fourth pillar of patient blood management, but if you look at the cloverleaf model, we're essentially talking about the patient-centered decision making here. So how has WHO played an important role? Yes, we saw in the 2021 the urgent implementation policy brief that came immediately after the COVID. But this probably, again, no offenses to WHO here. This is probably one of the earliest follow-up endeavors, follow-up exercise that WHO has done after declaring something, and that is where they have come out with the in detailed guide of implementation of patient blood management. This is a 200-page document. I don't want all of you to go through this 200 pages. But yes, the first 14-15 pages are really important. I would say that at least these 14-15 pages is something which everybody who aspires to either follow or to preach patient blood management must go through. Although I'm not really happy with one of the definition points here, but we'll discuss that later. So where do we stand today? Yes, what we see is a lot of sound on patient bed management all around. You see how not only the number of publications or literature has increased on patient blood management over the years. What we also see is number of CMEs, conferences, webinars, courses have really increased to a phenomenal extent in the last few years. And I think that was the original intent. Yes, that is the mantra, that the more the education goes, the more awareness goes, the better is the outreach, and more will be the implementation. But if you try to extract, or if you try to really judge or analyze what is the music and what is the noise part of the sound, that is where we did a capacious survey for more than almost 432 participants from the Southwestern Asia. What we discovered is that almost 75% of participants do believe that it's more of noise. They really need to understand what has to be done, how has to be done, and what are the initial gradual steps that should be done. There is a lot of information available, but to filter out the exact steps that they need is something which is still missing in most of these awareness campaigns that we see. Of course, the effectiveness of awareness channels is also important, particularly considering that, particularly what I'm really against is that it is still not a part of our basic, which is the undergraduate medical education curriculum. We do not have anything on patient bed management till date. I will apologize if it has started, but I'm not really aware of any education, any medical education, undergraduate medical education curriculum, which is MBBS, which has incorporated teachings on patient bed management. It's usually still considered a postgraduate kind of subject matter. So what are the distractors? I don't want to sound very fancy here, but yes, there are distractors. It's not just distractors. Distractors would be a wrong word. I did not have a chance to change the title here. Not call it distractors as such, but yes, deviators in terms of focusing our energy. Where do we have to focus? We start with the transfusion medicine. We talk about the optimal use of blood. We start about the rational use of blood and blood components. We talk about a lot of projects governing around optimal use, governing around blood donor adverse reactions. This is one part. Then there are now available literature and guidance and thought processes which clearly say that it's not entirely the transfusion medicine, it's also PBM, which is a holistic concept. It doesn't belong to a specialty. The more I go to these conferences and congresses where we're talking about patient bed management, it's rather disheartening to find a diverse group of specialty coming in together. Today we have mostly people from transfusion medicine segment. At least 50% should be beyond transfusion medicine. That is where we can really think about, or aspire at least, to have a proper implementation of universal and standardized implementation of patient bed management into our daily practice. Then we have something called as bloodless medicine and surgery. Now this is something which is a concept not really related to patient bed management, but yes, an inherent part of patient bed management for a dedicated group of believers, for example, the Jehovah's Witness, or those patients who do not demand or do not want an external blood coming into their veins. This is what we stand today in 2025, blood health. Now you see the WHO implementation guide that we saw, it was blood health. I think this is the biggest misnomer that has ever been created. Now we are talking about holistic blood concept. We have seen a couple of sessions already now this morning. We're talking about holistic concept. We're talking about patient. We're talking about multidisciplinary approach. We go back one step. We start talking about an organ system again, blood health. Now this is something which is arguable. I'm sure 50% of you may not agree with it, but yes, I have my points to counter that this is a step back. We cannot just be focusing upon blood health. We have to be focusing upon patient wellness, or I would say just wellness. Anyways, talking about challenges, which is probably the second part of my discussion today. I was not given an outline, I was just given time and the topic, so I'm just trying to do justice to the 15-20 minutes that you've allocated. This is essentially the biggest challenge that we have. And the challenge is essentially of, again, two worlds, the developed part and the developing part. Again, I would not say it is to do with the resource abundance or the resource constraints. I'm not sure how many of you have heard of okay, I'll tell about that later. It's about the optimal utilization of resources. Even the most resource-rich countries, if they are not utilizing their resources well, they are resource-poor countries. They are the underdeveloped countries. And that is what we have to understand. It's not about the presence or absence of resources. It's about their appropriate and adequate utilization. Another biggest challenge that we have still in our country, despite the WHO implementation guide coming in, we have no mandate. There is no government policy which says that this is a timeline, this is the people responsible, this is the course which must be taken in order to implement universally and in a standardized way the patient bed management. Again, we tried to do it several years back. It's almost 7 years now. We tried to talk about that this is a standard of care, this is dealing with patient safety, this is responsibility and duty. But again, there's a long way that we have to go. Another thing is the mindset. What is the mindset talking about? Again, this is something which is talking about patient blood management is a concept which is above and beyond the optimal use of blood. This is again from the survey that we published in this particular article. Again, is PBM same as PBM optimal use of blood? Most of the respondents, they still say yes, it's mostly the optimal use of blood. I'm not saying that yes, now since this is 1.5 years old, I know the education has increased a lot and that now we believe it's not about the optimal use of blood, but still it continues to reflect in the matrices of measurement of the success or whatever efforts we are making towards patient blood management. We still keep it one of the most common indicators that yes, the blood component utilization has been made more optimal. Most of it arguable. What we must be focusing upon is the patient, and it is everything that we saw in Dr. Gopal's session last. It's about the outcomes. That is the most realistic and that is the most effective, I would say, end result that we should be looking at when we are implementing patient blood management as a practice, as a concept within our healthcare ecosystem. Another thing is about the means and the modes that we adopt. We saw a couple of very interesting studies that Dr. Ravneet ma'am had shown on utilization and management of anemia. Similarly, again, this was something on dealing with, on understanding from the perspective of practices and perceptions in the low middle income countries. Still, most of the institutions continue to adopt the blood, particularly PRBC transfusion in the management of anemia. This is not just India. This is the entire South Asia put together. This is the reflection of the analysis of practices in this system. Not just first pillar. If you look at the second pillar, we're talking about absence of local protocols as well as resources. Fine, resources could be an issue, but even if you have resources, we still do not have protocols which could be adopted as an institutional policy so that there is a universal implementation of PBM. Then, talking about irrational transfusion, which is talking primarily on the third pillar, we have a mixed bag, lab-based tests, lab test-based transfusion, which I call as empirical transfusions. Poor triggers, we talked about it earlier, non-compliance as well as no consensus. Everybody who's managing a patient has his or her own beliefs upon which a particular patient is managed. Another thing is talking about manpower. We have a lot of PBM enthusiasts today. We have been seeing a lot of PBM enthusiasts in the last few years. But again, we as PBM, ambassadors, as PBM champions, we must realize that we have to make sure we have to devise plans and strategy to continue to engage those champions, to continue to keep them motivated, if possible incentivizing them, and of course to make some efforts to have a more long-term sustainable practice rather than one-time activity which will start and they will end in a couple of years or maybe in a couple of months. Again, wherever and whenever possible, we have to scale it up. We just don't have to establish it at a particular status. We have to continuously improve it, that this is the benchmark which we have achieved. We create another benchmark now. Last part is on opportunities that we have on patient blood management as such. I think the ultimate beneficiary of everything that we do in patient blood management is the patient itself. How? First thing is empowerment of the patient. Again, inclusivity. I'm sorry, but there is still no inclusivity of the patient in decision making anywhere. Not even in the choice of hospital, not in the choice of procedures, not in the choice of specialist he or she is getting managed by. It's purely and purely one, commercial, two, hearsay, word of mouth, whatever you call it. Again, there is still no inclusion of patient into decision making. Yes, it's about personalized approach. We cannot have, empirical or ratio-based or, generalized generic protocols which could be, just given to every patient in terms of management. Improve outcomes, I already talked about it. Yes, that should be one of the key things which should be able to attract more and more patients in choosing what they have to choose. Healthcare we talked about, we saw a couple of studies from Dr. Gopal. This is what we presented at NATA Congress last year in Germany. We were talking about, this is the data from 7.6 million patients. We're talking about even if the blood product acquisition cost goes zero, every blood which is available in the world is free. Even then, we end up saving 50% more in terms of preventing the potential complications we could have inflicted upon the patient if we were not following the standard of care called patient blood management. For the providers, I'm not sure if we have administrators here, but yes, when you adopt patient blood management, we're talking about adopting this ethics and evidence which is related to the standard of care. We talk about precision medicine. This is the era of goal-directed management. This is the era of precision management. And that is the reason why this becomes a kind of USP for a particular provider who has adopted the patient blood management. Accreditation, yes, there is still no government regulation that says, or even insurance agencies are not focusing more upon institutions and hospitals who are adopting patient blood management as a policy. No, there is nothing like that. Community, this is important. Why this is important? We saw a glimpse of it from Dr. Avneet Kaur's presentation, and this is exactly what I want to elaborate here. When we make decisions, when we take actions for a community as a whole, the best work is done when we have the maximum impact that can be made and at the minimum cost. And that is where we talk about preventable actions, or I would say proactive actions. And that's where patient blood management essentially gets its definition from. This is something which is more, if it is better, if adopted early in the stages. My last 2 cents on talking about the mantra for PBM implementation. First, it is not an additional cost. It is something which reduces cost, and it is better we realize it. It is better we devise our own metrics to understand if it is working or not working. But yes, we will eventually discover that this is in long term saving more and more costs. Second most important, it's not a different thing you're doing. I want to start PBM. I want to start adopting PBM within the culture of work that we have in my institution. It's not a separate concept, it's not a separate policy, it's not a separate protocol that we are starting. It's something which is very much an inherent part of everything that you're doing in terms of patient care. Of course, talking about education and awareness, of course we didn't start the fair. We have been working a lot on the this is something which you must have been a part of in the last 5 years. Again, this year we start. The flame will continue to go, and we'll continue to do it. Before I end, if you have to recollect, yes, it's all about patient. It's not about blood. Blood is second. Patient is first when you talk about patient blood management. It is the new standard of care. If you're not doing it, you are not doing justice to your patient, to yourself, to your institute, to your community. Transfusion medicine, specialty should be in the navigator's seat. This is very, very important. They are the ones who should be the propellers for it. Again, as regards handling, I would still keep it to the people or to the specialties who are managing patients directly, who are directly dealing with patients. But yes, they should be in the navigator's seat, they should be in the propeller's seat. Again, communication, collaboration, and consensus, we've heard of it a lot in different diversities, so I'm not going to talk much about it. Again, we have to focus more on identifying the gaps. We have resources, we have the awareness. I don't know where do we start with, but we always have to start we always have to target the low-hanging fruit. Find out one thing that you can start with, have short-term realistic goals that can be achieved, and then we move forward. Eventually, improved outcomes is something which we should aspire to have as the ultimate decisive metrics for deciding that if our PBM protocols are working or not working in a particular specialty. Yes, there's nothing permanent except change, but implementation is how we react to it. And that is exactly what I want all of you to have a pledge within yourself that yes, this is what you will be aspiring forward. This is a QR code. If somebody wants to scan it, can scan it. This is something more of a dialogue, which was publicized a couple of last week, I would say. This is a 33-minute dialogue, and this is a little more realistic on how and what to do about patient blood management, more than just the definitions and the studies. Thank you. Yeah, this is the one.
Thank you, Dr. Gandhi. I think you have very well basically covered the overall perspective that how exactly it can be implemented and how at what stage we are. So I fully agree with all the speakers that yes, patient blood management is just not I think restricted to the hospitals, but I think it has to go beyond the hospital, that we have to involve policymakers, decision makers, and especially the commitment of the state, which is very important. And when we look into the WHO definition, the holistic approach, so in that it primarily I think involves that we have to do at the community level also various preventive measures to prevent anemia and all those things. But yes, I think as far as hospital settings are concerned, patient awareness, I think as transfusion medicine specialists, equally the relevance of clinical colleagues, because it is the clinical colleagues who are at the patient bedside and they are interacting with the patients. And yes, one of the important aspects which has come today from the discussions is the cost saving, you see. So if we can somehow or the other convince our administrators or management, okay, look here, like Dr. Gopal was saying that in next 2-3 years he will be able to save 15 to 20 crores. So that will obviously cover his salary and his staff salary. So if we can convince the administration that by implementing such a strategy, is certainly going to help the management, and it has improved whatever, like from Australia where it started, there is a lot of cost saving. So obviously the comments will come forward and the management will certainly be done. So with this I thank all the speakers for their wonderful talks. Maybe if there are any from the organizers, do we have any time for 1 or 2 questions? 2-3 questions, maybe any questions, and then I will hand over the mic to my coach here.
If there are no questions, I just make a comment. The whole concept of transfusion medicine actually started with that we have to be involved in the patient care. So it is not dispensing blood, not operating as a blood center. One has to get involved in the patient care, and patient management is one step further to that. Like it's not only for patients who are undergoing surgery, it is for the medical patients also. How well you can apply your blood component therapy, not only dealing with supplying or dispensing blood, but going beyond that. Looking after the patient so that you can have optimum utilization of blood as well as the optimum health for the patient. So a very good session, and I thank the organizers for this opportunity. Thank you.
Thank you, our respected chairpersons and our speakers. And now, to honor our distinguished speakers, I would like to invite our respected chairpersons, Professor Preeti Alhans ma'am and Professor Ratiram Sharma sir, to kindly come forward and felicitate them as a token of respect.
Name section. So I request chairpersons to felicitate our speakers. First is Professor Ravneet Kaur ma'am.
Dr. Gopal Patidar sir. Dr. Ajay Gandhi sir. Now I would like Dr. Geeta Negi ma'am and Dr. Daljit Kaur ma'am to felicitate our esteemed chairpersons. Dr. Preeti Alhans ma'am. Professor Ratiram Sharma sir. Now I would like to invite Dr. Daljit Kaur ma'am to conduct the further sessions.
So, a surprise entry just before the welcome, the inaugural event. So the team has actually prepared something, a little scene, something to think about. And what I am proposing is that you look at this, it's a tiny, 1 minute or 2 minute scene. So just think about what is happening here and what advice you have, what thoughts come to mind. You have some notepads, you may note down certain things if you feel like. And then at the, in the post-lunch session, we will have a more detailed this kind of scenario, and at that time you can let us know what are your thoughts and what did you think was wrong here, or you thought it was right, whatever you want to say. Definitely one thing I want to say, these things will be exaggerations because we have to connect to the audience. So if it's an exaggeration, please forgive us for that. I have deliberately asked the residents to exaggerate situations and so that they can depict certain principles. So I would like to introduce, so this is a role play which is starting now, it will end post lunch. So this is called Asahai Se Saksham. So just recently we heard about a patient-centric theme. So isme kya hai ki there is a patient who is asahai in the beginning. So we will see what happens in the end. You would have understood by the name. So I would like to introduce to you Mr. Asahai. So this is a patient who has to undergo a surgery, a hip replacement surgery, and the poor fellow is anemic as well. तो ये हमारे हैं मिस्टर असहाय. अब इनकी जो ट्रीटिंग टीम है, सो देयर इज द सर्जन डॉक्टर जी स्कैल्पल. So she is the brilliant surgeon who is going to operate. And then there is the anesthetist, Dr. Keto. So Keto साहब का काफ़ी strong views है about blood, so that's why we invited the anesthetist. And then finally there is a nursing officer, Miss Casual. Because we know no surgery or any medical procedure is complete without the assistance of the nursing officers. So let's see what they have to tell us and talk to us about. So the scenario is of a pre-operative ward round. So in this hospital, the anesthetist also accompanies the surgeon and they're discussing something.
गुड मॉर्निंग मैम।
कैसे हैं आप?
बहुत अच्छा, आप कैसे हैं?
हम भी ठीक हैं। मिस्टर असहाय, आपकी नेक्स्ट वीक सर्जरी प्लान है?
जी मैम।
आपको एनीमिया है, तो हम सोच रहे हैं क्यों ना आपको सर्जरी से पहले खून चढ़ा दिया जाए?
नहीं मैम, मुझे खून चढ़ाने से बहुत डर लगता है। लास्ट टाइम मेरे बेटे की सर्जरी थी, उसको सर्जरी से पहले खून चढ़ाया था। उसको काफ़ी दूर से पेट दर्द हुआ था, उसके पूरे शरीर में चक्कर पड़ गए थे।
आप इतना घबराइए मत, सब ठीक होगा। इतना कोई रिस्क नहीं है खून चढ़ाने का। हाँ सर, हमने आपके कुछ प्री ऑप टेस्ट भी लिखे हैं, जिससे आपका हीमोग्लोबिन पता चल गया है।
थैंक यू।
देखो, मुझे कुछ नहीं पता। आई वांट सॉलिड 12 हीमोग्लोबिन, तभी पेशेंट ओटी में शिफ्ट होगा, वरना पेशेंट तो नहीं जा रहा है। और अगर आपसे खून अरेंज नहीं हो रहा है तो बताओ, ब्लड बैंक में मेरे दोस्त हैं डॉक्टर रक्त से, उनको मैं बोल देता हूँ, वो खून की नदियाँ बहा देंगे।
हाँ सर, हम अरेंज करते हैं।
ओके। नहीं यार, मुझे खून चढ़ाने से बहुत डर लगता है। कोई और तरीका नहीं जिससे मुझे खून ना चढ़ाना पड़े और मेरी सर्जरी भी हो जाए?
अरे मिस्टर असहाय, आप इतना घबरा क्यों रहे हैं? यहाँ देखिए वार्ड में कितने मरीज हैं, इन सभी को कभी ना कभी खून चढ़ा है। वो देखिए गुप्ता जी बैठे हैं, गुप्ता जी को आपके सामने अभी एक बोतल खून चढ़ाया गया है और वो कैसे खुशमिजाज हैं, कितना हंस रहे हैं। क्या पता आपको भी खून चढ़ाने की बात अच्छा लगे, क्या पता आप यहाँ से हंसते खेलते बाहर जाए।
ठीक है मैम, सब कुछ आप लोग के।
So just think about the scenario, keep some things in your mind if something very pressing that you definitely want to speak up about. So you can note that down. And since there is a slight delay in the administration director ma'am and dean ma'am arriving, we can have a few points if you want to discuss what was happening here. What would you have liked to happen differently? Anybody? There are mics. Anybody wants to, or you think it is okay? Yes, yes. So a mic भी ये चाहिए। नवनीत, ये पीछे सर को माइक दीजिए। नवनीत इधर इधर सर।
Hi, I am Dr. Ashwin. I am here and I am currently working in AIIMS Rishikesh. So in the scenario, what I felt me was the patient. Like he was verbally not giving the consent itself. Like the thing I felt like they could have mentioned other treatment modalities. Like we always mentioned, like he could have given other choices. Maybe at least he had the right to know about other choices what he have. So that thing, like the patient is like as little patient blood management. So he himself didn't want the blood to be transfused. So that was the thing which touched me most actually.
Okay, so Dr. Sanjay, it seems, is getting ready to rebuttal. Dr. Sanjay is the HOD of the Anesthesia Department.
Ma'am, seeing this case scenario, there are two things that comes into my mind. One is, in this scenario, there is a patient, he was not assessed. There was some investigations which was asked for, there was some report which was there. We don't know what is his physical condition, firstly.
Yes.
Secondly, you said this patient is about to go in a THR or a hepatoplasty, something like that. That is never an emergency surgery. So that is another thing that will have a bearing of the blood transfusion that this patient will have. Thirdly, Mr. Keto, I think, was...
Dr. Keto?
Yes, I agree. As an anesthesiologist, he was a bit... but there are many times what happens for us is what patients that we get out here, we don't know what is their physical status before coming down for surgery. So we always see the patient for the first time during their PAC clinic or whenever they are there in the round. So we don't have, and many times the surgeons are very insisting they want to do the surgery. But like this sort of a surgery, we could have optimized this patient by other means rather than just going in for a blood transfusion. That is what is my take from.
Definitely. A large round of applause for both the responses actually. This is something that we so desire. So over to Dr. Diljit. Actually, there is an administrative delay. Okay. There is no delay. So we'll start with the welcome inaugural event. Welcome, ma'am. We just had a role play on this topic on patient blood management. So we were just having a discussion on what people feel about how it was done in the role play. So the residents have acted out this scenario that a lot of blood is needed and how the doctors are acting and all that. So it was a very interesting role play. So now over to Dr. Diljit to conduct the inaugural event.
Radiant joys everywhere, spirits in tune to the spicy air. Thrill in the glory of city of Parmesh. Let's enjoy this scientific day at AIIMS Rishikesh. Distinguished guests, respected Professor Meenu Singh ma'am. She is Executive Director at AIIMS Rishikesh. Respected Professor Jaya Chaturvedi ma'am, Dean Academics, AIIMS Rishikesh. Professor Preeti Ellens ma'am, who is Head Department of Transfusion Medicine, SDPJ Lucknow. Professor Ratiram Sharma sir from PJMR Chandigarh, Professor Avneet Kaur, GMCH Chandigarh, respected senior faculty from all over India and AIIMS Rishikesh, all faculty colleagues, dear residents, delegates, friends, ladies and gentlemen, a very good morning to all of you. And we welcome you all to this holy city, the yoga capital of the world, Rishikesh, besides the Ganges. On behalf of Department of Transfusion Medicine, I am thrilled to welcome you all to our CME, that is themed Patient Blood Management, Advancing from Product to Patient. This CME is supported by International Society of Blood Transfusion, Amsterdam, the Netherlands. And this is the first CME, ISBT CME of the Uttarakhand region, and we look forward to have many more in future as well. Since 1935, ISBT, the Global Knowledge Network for Transfusion Medicine, has brought together transfusion specialists to enhance transfusion safety globally. Through conferences, webinars, live JCs, seminars, publications, and e-learning, this ISBT through ISBT Academy offers transfusion medicine education. So an ignited mind is the most powerful weapon on the earth, above the earth and under the earth. And this we can only acquire through continuous education. On this auspicious day, I would like to pay gratitude to our faculty present among us today, who have in many ways played a vital role in shaping the blood transfusion services all over the country. And they have trained hundreds of postgraduates in transfusion medicine who are now practicing well as senior consultants, senior faculty, and senior residents at prestigious institutes and hospitals. Patient blood management, or PBM as we say, has become an essential strategy in modern medicine. This highlights an enormous shift in focus from traditional therapies to novel strategies. And this is meant to optimize a patient's very own blood. PBM, that initially began as a set of alternatives to blood transfusions, it has now grown into a comprehensive approach which places patients' own blood health first. With this, we welcome you all here at AIIMS Rishikesh. And to mark the beginning of this CME, I request our esteemed guests, Director Ma'am, Dean Ma'am, Professor Preeti Ellens Ma'am, R.R. Sharma Sir, Ravneet Ma'am, Dr. Geeta Negi, Dr. Ashish Jain and other dignitaries to please come forward for lamp lighting, a symbol of knowledge and wisdom. I request Ms. Chanchal Miss Akanksha, Miss Gitanjali to please assist for lamp lighting. I invite Meenu ma'am, Meenu Bajpai ma'am, Sanjay sir, Pyal sir, Vandana ma'am to please join us for lamp lighting.
Oh my god, email courageous.
Thank you, everyone. So going in sync with the healthier move towards scientific ceremonies, now I would request our organizing team to kindly welcome the dignitaries with the symbol of prosperity and growth, a chakra tree symbolizing stability and long-term growth, manifesting abundance and success. And we know we all medicos certainly need all these energies and positive vibes round the clock for better patient care and self-care. I request Dr. Geeta Negi ma'am to welcome our esteemed Honorable Director ma'am, Professor Meenu Singh. I request Dr. Ashish to welcome our respected Dean ma'am, Professor Jaya Chaturvedi ma'am. I request Dr. Ashish to welcome our respected Dean ma'am, Professor Jaya Chaturvedi ma'am. I request Dr. Geeta Negi ma'am and Dr. Ashish Jain to welcome our renowned senior faculty from the prestigious institutions of India. I invite Professor Preeti Ellens ma'am, who is Head Department of Transfusion Medicine, SGPGI, Lucknow. Very much admired. Professor R.R. Sharma sir. A big round of applause, yes, for all our senior teachers who are very much admired. Professor R.R. Sharma sir, who is Head Transfusion Medicine, PGIMER, Chandigarh. Head Transfusion Medicine, PGIMER, Chandigarh. Professor Ravneet Kaur ma'am, Head Transfusion Medicine, GMCH, Chandigarh. Chandigarh. Professor Meenu Bajpai ma'am, Head Transfusion Medicine, ILBS, New Delhi. Professor Meenu Bajpai ma'am, Head Transfusion Medicine, ILBS, New Delhi. It's a matter of immense pride for us to have such admired and distinguished teachers who are with us today. Immense pride for us to have such admired and distinguished teachers who are with us today. Thank you all. We welcome each and everyone. I would now request Professor Geeta Negi, our guiding light, the organizing chairperson for this CME, Head of Department of Transfusion Medicine, AIIMS Rishikesh, to welcome the August gathering. Her indefatigable efforts and nothing is impossible philosophy have made this show happen and fulfilled our long desired dream of hosting this educational event. She has been the most zestful person behind the scenes. Ma'am, please.
So, 2 days before today, so I promised all the delegates, all the guests, beautiful weather at Rishikesh. I even sent you all a video which they are trying to put, yes, they put it also. I sent you all, this is an actual video which we took from just next to AIIMS. So I promised you this weather and we lived up to that promise. So I was really glad the weather was with us and everybody was so happy yesterday. All those people who reached in the evening, they all went to the barrage. So with those words, respected ED ma'am, Professor Meenu Singh, Dean ma'am, Professor Jaya Chaturvedi, Dr. R.R. Sharma sir, HOD of Transfusion Medicine at PGI Chandigarh, Dr. Satya Maruda, who is faculty at PGICH Noida, and also the regional director of the International Society of Blood Transfusion, who are the main official sponsors for today's events. Everything here is because of them today. And some of the chief guests could not arrive from the state. So Dr. Preeti Helens madam, Dr. Ravneet Kaur, Dr. Meenu, my very good friends, all eminent transfusion medicine specialists, all the delegates who have traveled from so far, despite the thoughts that there is this covered season, the weather is bad, there could be, some people were asking us if there would be landslides. So really, really grateful to all of you for having reached here despite all these tensions in your mind which were not needed. And a huge thanks to all our alumni students. It was so wonderful yesterday when the alumni were reaching one by one. Approximately 70% of them are here with us and they have planned some great things today. I really welcome everybody who is here in the hall to this lovely city of Rishikesh, and just as I lived up to the promise of that good weather, that slide, I hope we will also be able to fulfill the promise that I'm going to make today. Now, this promises of totally interactive and interesting sessions with eminent faculty, with very enthusiastic young minds. We have, I'm really happy to see residents from Anesthesia, CTVS, Pediatrics, so many different disciplines. It is really a great thing that you all believed in us and thought of attending. This makes our endeavor, this topic of PBM successful when we have people coming in from different specialities as well and attending the CME. And the thing about PBM is that nowadays everybody has started agreeing that patient blood management is needed. But then with that comes the dialogue that, it is only talked about, it is not being actually done. That dialogue comes often, only 1 or 2 institutes doing it. But here today we are trying to remove that second dialogue. We accept PBM, but today we are going to prove that people are doing it. For that purpose, we have eminent senior transfusionists who are telling us, evidence and the things that people have done. And then there are a lot of youngsters who in the morning, in the poster sessions, everybody made presentations, fantastic presentations. I really congratulate you all. And it was wonderful to see people, coming up with diverse things, even the disposal of a blood bag. So that was another wonderful thing. It was by one of our alumni. She is currently in Guwahati. And things like people from, some posters were from pediatrics, there were posters from hemato-oncology, anesthesia, all these departments. So all these students, the younger minds, they are proving that yes, patient blood management is being practiced. So today we are here to dispel that second thought, that this is just a fad, people are just talking about it, it will go away. But no, it is here to stay and it will definitely be in major publications. I agree with what Dr. Ajay Gandhi said when he said that there is no national mandate, there is no institutional mandate. So here at AIIMS Rishikesh, we are taking small steps. We have introduced patient blood management in a couple of departments. We are doing it stepwise. And once we are more confident, we intend to approach the management to permit us to implement it, make it a mandate for all the departments. As very rightly Dr. Sanjay also pointed out some of the things which are very nicely happening in the anesthesia department. So hoping to have extensive, lovely interactions with all of you. Please take the opportunity when the mic is offered to you. don't shy, take the mic and speak up. So as we are speaking, please speak up. If you want, you may come to the stage. If you want, you may speak from your seat. So with that, I want to welcome you all very heartily to today's CME. Thank you.
Thank you so much, ma'am. So now we move on to the most awaited event of the day, release of the souvenir, which is called PBM Chronicles, and our residents all over India are very fond of it. So they are waiting for the release. So I request all our esteemed guests and dignitaries to please come forward for the release of this souvenir, which is compiled by the alumni of Transfusion Medicine AIIMS Rishikesh with all their hearts and minds. And this was led by Dr. Sarika Agarwal, the first MD Transfusion Medicine resident of our department. Yeah, she's coming. Come on. We would like to show our gems.
मैम आप आ जाइए ना एक नीचे लीजिए
Thank you, everyone, and we hope that everybody would love it. We will have the release of e-souvenir as well on various platforms. Thank you, everyone. Now I would request our respected Dean Ma'am, Professor Jaya Chaturvedi Ma'am, to please come forward and encourage the organizing team and delegates.
ये भी करेगी छोड़ चढ़ ही जाते हैं. So good morning everyone, respected Director Ma'am and all the dignitaries and delegates present in the hall. I welcome you all as Dean Academics in this beautiful CME from the Department of Transfusion Medicine and all other departments who are working with them to make this CME successful. So patient blood management is very, very necessary, and as obstetrician and gynecologist, I know how much blood is to be transfused which will not cause patient any harm. So my department is needing regular supply from the blood transfusion department, and we never face any problem because Dr. Geeta, Dr. Daljit, Dr. Ashish, everybody is so cooperative along with their residents and their technicians, everybody. So all the best. As I had seen the word written as ISBT, International Society. So as we know, ISBT term is used for the bus terminus, international. So to be on the lighter note, from that terminus, everything is arranged and similarly the transfusion department do the job of this terminus. So thank you very much for all the support, and I again welcome all of you here. Have a good day. Thank you.
Thank you, ma'am, for your kind words of wisdom and encouragement. Now I request Professor Ratiram Sharma sir, Secretary, Indian Society of Transfusion Medicine, that is known as ISTM, to share his views and bless the attendees and organizing team.
I think this was a surprise actually. I was thinking that I was invited for the chairing the session. So good morning everyone. Esteemed Madam Meenu Singh, I think it was nice meeting her because as we used to meet in the morning walks in Chandigarh, Sector 24. So thank you ma'am for coming and blessing basically for this transfusion medicine, and I hear all the praises from Dr. Geeta that how you are pushing the department forward and providing them all the support they require. So in addition, I think the theme which she has picked up today is quite relevant in the transfusion, for the transfusion services in the country rather, because as we all know that there are many centers coming up in the country for patient care, and proportionately the demand for blood and blood components is going to rise. As madam is saying that it is a terminus, bus terminus, but I use it as a kitchen, you see. Kitchen, you see, the more the members, family members, more you require the demand. So transfusion service is a lifeline. And especially the word today, patient blood management, I was thinking, hearing from the talks, that I think now the time is that from patient blood management, we need to term it as a community blood management or a public blood management, because this is just not restricted to the hospitals. I think this has to involve policymakers, our leaders, ministries of health, departments of health, as well as secretaries of health, because it is through their, we need a strong commitment of the government to take these ideas forward, because this is just not managing in the hospital setting, but to start various prevention programs. Like we have our Anemia Mukt Bharat program, Janani Seva Suraksha program, because all those are concepts to preserve life. Basically, anemia, as we all know, it's a global problem, and this is one of the most common medical problem which is affecting the the mankind, as per WHO estimates. So I think I must congratulate Dr. Geeta and her team for inviting us and organizing this event especially on this key issue, and thank you for making us here. And we from the Indian Society of Transfusion Medicine also, I especially give our sincere gratitude and greetings to all of you for successfully organizing this. Thank you very much.
So following Guru's footsteps, we have our very own PGI alumnus, Dr. Satyam Arora, who is ISBT's Regional Director for Southeast Asia. He is following the footsteps of his PGI gurus, respected Professor R. Sharma sir and Neela Marwa ma'am. Dr. Satyam, please.
Thank you, ma'am, and good morning, everyone. Respected Director ma'am, Dean ma'am, my senior faculty members and teachers from PGI Chandigarh. It's an honor and privilege for me to join this CME today and on a very pertinent topic of patient blood management. On behalf of the International Society of Blood Transfusion, I extend warm greetings to all faculty, students, clinicians, and policymakers gathered over here. PBM is not just a technical protocol, it is a patient-centric approach to manage patient, especially in our region where the demand is rising and we need to be more focused on treating the patient than only to provide blood unit. I encourage everyone over here to discuss, engage into these discussions and absorb and ask questions and use this platform, which is very well organized by this department, to have more interdisciplinary discussions on this topic of PBM. Thank you, ma'am, for organizing, and your team has done a great job in hospitality, in managing our time at Rishikesh. especially the evenings with the Ganga's bank, and it's an amazing experience. And I think it's a holistic management that your team has been doing. And I really wish this CME a grand success, and you know, I wish all luck. And since yesterday evening that we've been spending time at the banks of Ganga, I thought that where PBM can intersect with the flow of Ganga, and something that I wrote over the evening was, like Ganga, blood is precious. PBM is our commitment to keep it flow pure, purposeful, and preserve it for our future generations. Thank you.
That's wonderful, Dr. Satyam. Thank you so much. So now I would request our Honorable Director, ma'am, to address the gathering and encourage the audience. Ma'am, please.
So thank you, Daljit, for those kind words and conducting this particular session so well. And I was actually looking at the program, but first I must address all the dignitaries who are present here. Our own Dean, Professor Jaya Chaturvedi, Professor R.R. Sharma, the Head of Department of Transfusion Medicine from PGI, Dr. Preeti, Dr. Ravneet, Dr. Meenu, and of course Dr. Geeta, Dr. Ashish, Dr. Satyam, all of the people who are present here, all the guest faculties as well as the students and our own alumni who've come to attend this particular workshop. So when I was looking at the program, so I found things like climbing the mountain, then flowing with the river, then meeting the challenges, strike when the iron is hot. I could imagine, you know, that this is Dr. Geeta Negi behind all these ideas. And of course, Dr. Ashish Jain. You all must be surprised to know. अच्छा दलजीत ने किया ऐसा ना? Okay, so you know, like gets like, they all एक ही थैली के हैं सब लोग. So, as you all know, Dr. Ashish has actually written our anthem, our AIIMS anthem, and you should listen to it sometimes because you are, you know. And they were so quick to write it and execute it, and we were able to play it in our convocation at that time. It's like almost like 1 year old, I think 1 or 2 years old. And so this department is really very, very forthcoming. And today, because I have to speak not like maybe as a pediatrician or as a you know, CEO of this organization, so I have to see how well and how well coordinated they are in their efforts. And they haven't even got all that which they need for, you know, the space-wise, I would say. Because I used to when in Chandigarh, you know, we had this Rotary Club of Chandigarh. They had a big building for a blood bank. And although not many activities were taking place over there, but it was something which they were really proud of. And even PGI did not have too much space. I mean, as far as space is concerned, it's always been a constraint because blood bank, you know, initially it started with blood banks. And that was like one service which was available. But now we know what is transfusion medicine, how many things it covers. Blood is actually the most important and I think the most flowing and the most voluminous organ of the body. And after skin, I think this must be the second one. So this is something which really needs so much attention and care. And I was really impressed with this team of PBM. You know, it really took me time to complete the abbreviation PBM, then I realized, okay, it is patient blood management. It could be several other things because we have all kind of PBMs these days. But since I belong to this field of evidence-based medicine, so we have been connected with this patient blood management theme, and that is having evidence-based strategies for optimizing blood management. This could be domiciliary, this could be pre-operative, this could be operative, this could be post-operative. This could be related to all the situations where blood is being used. And coming to evidence, you know, we as pediatricians, as newborn people, you know, we came out with a strategy of milking the umbilical cord, which is done by the obstetricians. And that, you know, leads to blood being transferred to babies, and those babies then develop less anemia during, you know, because during infancy, otherwise they get anemic. and they need iron. So many of these strategies are actually evidence-based. People did randomized controlled trials on these strategies and they found that yes, this is what is done. Then is, there's auto-transfusion. Like you have been saying that, people can donate their own blood. If you're going in for surgery, you donate your own blood 2-3 months before you start off. And then use the same blood if it is required. Similarly, during massive trauma, people lose so much blood and you can use that blood. Maybe you can clean it and fractionate it and then use those blood products for the same patient. So many new strategies, new technologies. We know that technology has really changed the world and medicine, and in blood transfusion, I think in transfusion medicine, I would say, it is something which has really made a lot of changes. So I think the road is ahead and there's no stopping. I know that Dr. Geeta and the team will not stop and they will become the best. They are already actually regional center for training for various medical colleges, which they are accomplishing. The AIIMS Rishikesh blood bank is very well stocked, and we are on the on the web, and people are making use of the whole of the state, and other states are making use of these blood transfusions. We also tried our drone service for delivery of blood products, and that is something which is always in the offing, and we can help our trauma victims with those kind of services. So many new things, new avenues are there. I'm sure you will keep getting ideas. Dr. Geeta also belongs to the medical humanities stream because she has been heading that center which we have put together. And I know all these teaching strategies, interactions, they all come about because of all these new thinking, I think new way of thinking, which is always there in this department. So congratulations for this wonderful CME that you have organized, and thank you very much for associating me with this. Thank you very much. Jai Hind, Jai Bharat.
Thank you so much, ma'am, for your influential message and words of wisdom. You have very aptly talked about evidence-based medicine. We will be talking about it in the subsequent sessions throughout the day. Thank you, ma'am. Thank you, everyone. Now I invite Dr. Ashish Jain to kindly propose vote of thanks.
Yes, ma'am. अभी करते हैं. So, good morning, everyone. On behalf of the organizing committee, it's my honor and privilege to deliver the vote of thanks at the inauguration ceremony of the CME on patient blood management, advancing from product to patient, organized here at AIIMS Rishikesh. First and foremost, I express our sincere gratitude to Honorable Director, ma'am, for gracing the occasion with your presence. We are thankful, ma'am, to have you as our leader, and in your leadership, the institute has grown new heights. Your insightful words and continued support had added great value to this academic event. We are deeply grateful to our respected Dean, ma'am, for your encouragement and unwavering support in promotion, continuous medical education. Your vision enables platforms like us this to thrive. We are extremely thankful to ISBT for not only providing financial support but also for collaborating with us and guiding us step by step for our organization of this CME. A heartfelt thank to our renowned speakers and teachers and all resource persons whose expertise in engaging presentations will help to deepen our understanding of patient-centered approach to transfusion. Your contribution will not only update us on the evidence-based practices but also emphasize the importance of shifting our focus from blood products to holistic patient approach. To the organizing team, residents and support staff, thank you for your meticulous planning, coordination and hard work. Although our organizing chairperson, Professor Geeta Negi ma'am, and organizing secretary, Dr. Daljit ma'am are the main organizer, but I could not resist to mention their hard work and passion. Geeta ma'am, of course, is well known for organizing events in her unique way, and Daljit ma'am is known for her stylish way. So we all are witness here for their combo of unique and stylish presentation. We all seen this is, so these are just one kind of example. Even all the planning and decoration, even that, all those ideas were thoroughly discussed, and how they are executed, only our team can understand this. So very thankful to you, both you, ma'am. Special thank to technical staff, audiovisual team, photographers, housekeeping staff, security staff and other staff for their support, and our caterers, designers and all the companies who have installed stalls. And last but not the least, a big thank to all the delegates who were motivated from the beginning of registration and also keep on motivating us. So whenever we are some dip in our motivation, we see the number of registration is increasing. हम कहते थे कि 2 बढ़ गए, 3 बढ़ गए, तो suddenly there is a spike in the motivation of organization of event. And lastly जब हमने देखा कि registration number is huge, so that अब तो मजा आ जाएगा भाई, बहुत अच्छे से हमें करना है. So the morning we have seen the enthusiastic mini oral presentation of the participants, and the president has come with their posters. It looks like there's some educational events is happening and everybody is seeing, even guards understand कि आज कुछ बड़ा होने वाला है. So it's about the delegates and the residents who are the main thriving force for this event. Your active engagement and enthusiasm will reflect the growing commitment to evidence-based and patient-centric transfusion practices. We hope the CME will not only broaden knowledge but also spark new ideas and practice in clinical work. Thank you all the persons for this inauguration and for the CME. And in the evening, I think a lot of collaboration with your knowledge and our knowledge we will share, and we will learn a lot about this patient blood management. Thanking you.
थैंक यू डॉक्टर आशीष. आपने इंग्लिश में बहुत ही बेहतरीन धन्यवाद किया सबका, बट दिल में अभी भी कसक बाकी है आपकी कविता की, तो इसीलिए वी आर गोइंग टू प्ले आवर इंस्टीट्यूट्स एंथम, सो विच वाज प्लान वेरी वेल प्लान बाय डॉक्टर आशीष एंड डायरेक्टर मैम.
परचम को बुलंदियों पर पहुंचाए हम हैं एम्स ऋषिकेश, हम हैं एम्स ऋषिकेश. विश्वरोग्यं हि धर्मुणः, विश्वरोग्यं हि धर्मुणः, विश्वरोग्यं हि धर्मुणः, विश्वरोग्यं हि धर्मुणः.
Now I request everyone to kindly rise for national anthem.
जनगणमन अधिनायक जय हे भारत भाग्य विधाता. पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा. विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा. तव शुभ नामे जागे, तव शुभ आशीष मांगे. गाहे तव जय गाथा. जन गण मन जय हे जय हे जय हे जय 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 हे.
Thank you all. So before we break for tea, I request everyone to join us in the amphitheater, our newly built amphitheater, for a group picture. It's solarium. Outside the auditorium. So after this photo shoot, we'll have a coffee break, and that's at the dining area at level 2. We'll resume for next session in half an hour.
Second broad category is the blood loss, and third is the coagulopathies. Though there are so many classification and of these anemia, I'm not going into the detail that we all know. Iron deficiency anemia may sometimes be iron deficiency occurs without anemia, with anemia, and there are a lot of things that can be put into these broad categories. So, and another thing, that is the blood loss that ultimately leading to the anemia, that may be a chronic blood loss, acute blood loss, surgical blood loss, and other causes as well. Third thing, this is the broad category. One more broad category that we are more concerned, that is coagulopathy, that can be acquired congenital and iatrogenic. These are the things that can become under the broad category coagulopathies. So when we are considering the anemia, preoperative diagnosis is mandatory. Diagnosis also is a broad list of batteries that can be used to detect the anemia, to diagnose the anemia nature. I am just concerned about the surgical way of diagnosing this. For we need a CBC, serum ferritin, and transferring saturation, sometimes CRP, if the inflammation is suspected. This anemia, I think it is better, and it's a good practice, evidence-based practice. It is better to correct this anemia before you take your patient into the operation theater. And the treatment also depend upon the time availability for this in your hand. So it is better if you are considering these patients in a perioperative evaluation, at least more than 4 weeks is required for their conservative management. Primary thing to manage these patients' anemia is getting into a causating way of treating these patients. Find the cause and treat the cause, that is the dictum. Otherwise, the patient most common cause, that is iron deficiency anemia, that lead to anemia, iron supplementation, erythropoiesis stimulating agent can be given, or a folate of vitamin B12. And if required, then blood transfusion, appropriate blood transfusion may be given accordingly. Now, how to decide the blood transfusion? Even the WHO criteria for blood transfusion, they mention there is a trigger point at which you have to transfuse the blood at any cost. Anyhow. So they have given 2-3 approaches. There are so many other approaches as well. They have given the restrictive approach, where the hemoglobin level of 7 gram per deciliter is considered to be in patient, those who are stable, non-bleeding, and critically ill hospitalized patient. However, in such patients, those who are having acting coronary syndromes, the hemoglobin level of less than 8 gram per deciliter is considered to be a trigger point where you have to transfuse the blood. Otherwise, one more, that liberal approach, where for some patients like cardiovascular disease and acute coronary syndrome, even in if you are going with the liberal approach, the 10 gram of per deciliter can be considered as per your but these are the things that can be considered for transfusion, considering all the other facts into account. So my question is, what is the timing and why? Striking while the iron is hot, that is the hot topic that Dr. Geeta has given to this portion of that talk. We all know that the importance is, the earlier the intervention, good will be the result. And evidence-based benefit is also there, that correcting anemia before surgery will have a good result in terms of morbidity and mortality. The improperly blood conservation, now coming to the main point, the principle behind is, number one, what is your goal? Our goal is to minimize the blood loss and reduce the necessity of the transfusions. And the primary three pillars for these intraoperative blood conservation is, number one is the hemostasis optimization. There are several surgical techniques can be modified accordingly, and the pharmacological and the mechanical measure need to be taken into account while you are considering the intraoperative, to prevent the blood loss and to conserve the blood in that situation. Hemostasis optimization, that in a pre-operative evaluation, if you are screening a patient for this coagulopathy and later on correcting them appropriately in pre and intraoperatively, will definitely give you a better result or the good outcome. And while you are giving these therapy coagulation screening and the therapy for this correction of these coagulopathy, your monitoring for this therapy must be there by using these certain tools like thromboelastography or rotational thromboelastometry. Surgical technique, definitely it will help in preserving the blood or conserving the blood intraoperatively by choosing some surgical technique which is less invasive and the minimal invasive. You can apply the tourniquet so that blood loss can be prevented. Anesthesia point of view, normovolumic hemodilation can be done. I will take this particular point later on. What is normovolumic hemodilation? And the controlled hypotension, that can be another strategy used by the anesthesiologist to conserve the blood intraoperatively. And intraoperatively, the temperature is one factor that can lead to excessive blood. If you are controlling your patient and a temperature is maintained, then intraoperative loss can be prevented. Pharmacological measures to conserve the blood intraoperatively can be used while the patient is operated by the surgeons. They can use these fibrin sealants and the topical hemostatic agent like Surgicel. They are colloid based or gelatin based, and they usually help in maintaining the mesh so that platelet and coagulation cascade can help into the making a plug and hemostasis. Surgicel and gel foam, these are the, and there are so many other ways of doing this, come into this very broad category, that is fibrin sealant. Other agent, the pharmacological agent like antifibrinolytic agent, that tranexamic acid, there are evidence-based practice, and there are different level of evidence for these using these fibrinolytic agent. They are having a result that whenever we are using these fibrinolytic agent, loss is less as compared to when we are not using these agent. They are tranexamic acid, aminocaproic acid and aprotinine. They are being used pre-operative and then continue it to the intraoperative period. Now coming to the autologous blood technique, that is what Dr. Geeta was telling me. Earlier we used to give the patient, giving the patient own blood to him. That can be done in 2-3 ways. First is the preoperative autologous donation, when patient is giving his own blood to the bank and it is being kept there and it can be used later on when it is required, but in a certain period of time it must be used by the patient himself. And second method is the intraoperative cell salvage, and third one is the acute normovolumic hemodilution. Now first one, the preoperative autologous blood technique. That preoperative autologous donation, that is PAD, is involved when a patient is donating their own blood before surgery for the potential transfusion during and after the procedure. So that may be used in such kind of patient where they don't want any other blood. There is one group of patients that GR witness group of patients, they don't allow any blood product to be used in their body. So, and another thing, there are so many other indications for using the preoperative autologous donation. Indication is different that I have not discussed here, but definitely that one method, that preoperative autologous donation, can be used to preserve or to conserve the blood intraoperative. Blood is a very important organ that Madam has already discussed after skin. And the aim of this preoperative autologous donation is to minimize the exposure to allogenic donor blood and its associated risk, and beneficial for the patient, those who are undergoing surgery with anticipated high blood loss, like in orthopedic surgery or the vascular or the cardiothoracic procedure. Second is the intraoperative cell salvage. In this cell salvage, the intraoperative cell salvage is the method that harvests the red cell which is shed during surgery and the procedure and preparing them for safe return to the patient's own circulation as the autologous blood transfusion during immediate after surgery. This is the flow diagram, schematic diagram of how the blood is being taken. The blood which is being shed from the patient is being collected into a bag, and that bag is being goes to the, after mixing it with the heparinized saline, and it goes to the cell salvage machine where it is segregated, centrifuged and washed thoroughly and returned back to the patient. That is how we can conserve the blood. That is a one method which is very important for the blood conservation. And third one is the acute normovolumic hemodilution, and the amount of blood that is withdrawn in varies right from 3 unit 450 ml to 500 ml each. We can take the blood from the patient pre-operatively, and this has been retransfused to the patient. This is in a peri-operative period. We take the blood from the patient and we'll keep it there only, and once and then same amount is being replaced with the saline or the colloid or crystalloid, whatever solution it is based on choice of anesthesiologist, and it can be discussed with the surgeon as well. So that amount, the blood which is we are using that time of surgical procedure is a little bit of diluted blood, and patient will, there are certain criteria for making the patient on, putting the patient on acute normovolumic ANH. Patient must have fulfilled these criteria, and after that we can go with this ANH. And later on, when the reverse order, the blood is being taken out from the patient 1 unit, 2 unit, can be retransfused after when the surgery is completed and hemostasis is being achieved. How to calculate this blood amount, how much to take out from the patient, that is totally based, volume based, formula based. That is volume what we are taking from the patient is being calculated by the formula that is already been said there. Estimated blood volume E, and where the BV is the blood volume, and rest of the things they are already mentioned in the initial hemoglobin plus final hemoglobin. That can be achieved. So this is the way how we can calculate how much blood is being withdrawn from the patient and later on will be transfused back to the patient. So there are some references from where I had to prepare these slides. Basically there are so many references. One of them is the WHO guideline for referencing the blood transfusion and the PBM and other references that are there. So this is all about the basics of this one. Thank you.
Thank you. Thank you very much, Dr. Payal, for such an informative lecture. I think since there is a brainstorming session, so all questions can be dealt in that way. Thank you.
This is basically very basic to start with our journey. I am not gone into
brainstorming later.
Thank you, ma'am.
This is the basis.
Thank you.
So I will now invite our second speaker, Dr. Latika Chavla, who is the additional professor in the Department of Obstetrics and Gynecology. And the topic she will be talking about is PBM through an obstetrician eye. A very important topic because there seems to be always a conflict between obstetrician and anesthesiologist and a blood bank for blood and blood products in the perioperative period. So she will be putting her own points, her own views from the obstetrician. Dr. Latika.
So the Taj Mahal stands today as a grand tombstone to a queen who died of postpartum hemorrhage. And while centuries have passed, we still have not been able to stanch this tide. PPH is still responsible for nearly 70% of the maternal deaths in our country. A very good afternoon, respected chairpersons, ladies and gentlemen. I will be talking about patient blood management through an obstetrician's eye. So we've had a morning discussion about what PBM is, so I'm not dwelling on that. However, one point I would like to begin my presentation with is that PBM is not only about transfusions, it's about avoiding unnecessary transfusions. So the key principles as an obstetrician that I have understood for patient blood management are that we need to optimize the red cell mass of our patients antenatally, we need to minimize the blood loss during surgery, and then the postpartum care which is required for these women. So if you look at the data that has been given by the Government of India, more than half of the pregnant women in India are anemic. But if you want to take a stroll through our labor room in the evening and you pick up the patient's files, you might find that this number is slightly lower. And anywhere between 70 to 80% of the patients who are admitted at any given point of time in the labor room are anemic by the standards that have been explained. And as the first and the foremost component of PBM, optimization of red cell mass will include detection and early treatment of anemia during the antenatal period. And interestingly, our patients will give us 8 to 9 months for this. So the government has been doing its bit with the various national health programs, the most prominent one being the Anemia Book Bharat. And then at the clinical level, we try and counsel our patients, our pregnant patients, about iron-rich diet, try to cook in iron utensils when you're pregnant, and this should be done each time when they are visiting us in the antenatal OPDs. And not just prescribing them the 100 tablets of oral iron, but also ensuring that they are actually consuming those tablets, and if they're taking it, they are able to tolerate it. Because if they can't tolerate it, they'll just dispose them, and then once they come to you the next time, they're too scared to say, no, I'm not taking those tablets. So, while IV iron has its definite set of indications, and if I probably show this slide to one of my very, very senior faculty, I'd probably be scolded for this. But in the context of the poor and nutritionally deficient pregnant women in our country, we must maintain a lower threshold for its use. Relying solely on diet and oral supplements is often too optimistic. IV iron, especially FCM, and if not FCM, maybe sucrose, offers definitive correction when it's needed the most. Cost, however, may pose a challenge sometimes, so maybe we'll be having a discussion later on during the day for this. So the second component of PBM in obstetrics is managing blood loss during surgery and delivery. So the protocols of management of obstetric hemorrhage are constantly evolving. And the latest revolution in the management of obstetrics has been the E-motive bundle, which is now being endorsed by all bodies, including the WHO. And if we all remember our MBBS days when we read Datta, and it said that 500 ml of blood loss is absolutely okay in a patient of vaginal delivery, and 1000 ml of blood loss, okay, that's not a problem in a cesarean section. But long are those days, we need to unlearn that concept. And according to this E-motive bundle, even a 300 ml of blood loss is significant enough. We must consider it sinister. And then the moment we realize that this blood loss has happened, we need to trigger our bundle. And all these approaches have to be done simultaneously for the prevention and simultaneous treatment of a patient of PPH. And that includes early detection. You start the bimanual massage of the uterus, give the oxytocin, give misoprostol simultaneously, and never forget tranexamic acid, because it's been found to be life-saving in a patient of massive hemorrhage if a single dose is given within 3 hours. Then IV fluids have to be given. 1 liter can be given safely, crystalloids. Beyond that, if you require some amount of blood, if you still require fluid, it should be replaced with blood or blood products. And E is early examine your patient. If you find some abnormalities, you escalate, you call for help, and call for help in a patient of PPH should not be taken as that you have lost. So in obstetrics, we say, in fact, the first thing should have been you call for help, or shout for help for that matter. You call your senior if you think that the patient is having PPH. And then the scariest patients today for us is patients of placenta agrita spectrum. So we plan our intraoperative steps well in advance. We map the placenta. We try and give our incision behind the uterus to deliver the baby. Seniors are usually operating in this case. We take the help of intervention radiologists to embolize the internal iliac or to embolize the uterines to prevent bleeding. But these patients have the potential to bleed massively. And this sort of a bloody scene where there is blood everywhere in the OT is oft encountered. So the residents will be running to and fro from the blood bank, carrying bags of PRBCs and FFPs. And so it's usually the little ones, the first years, the ones who have just joined. So then they ask us what to bring, kya lana hai. So using the ATLS principles, we're trying to change the management in our department as well. So if the patient is requiring more than 1 liter of fluid, which can be safely given in a patient of massive hemorrhage, beyond a liter of crystalloid is best. So we tell them blood needs to be replaced by blood. And then they'll ask us, kaun sa wala lana hai and kitna wala lana hai. So what blood products, how much blood products is to be given? So we've made an ABG machine available in the maternity OT for the benefit of the anesthesia residents and also for our own residents. And we're trying to change the concepts, trying to help them understand the physiology. So it's a beautiful test, can be done very quickly. It gives you a serial monitoring of the fall in hemoglobin levels during the course of the surgery. You can keep doing it serially. If the patient continues to bleed, you'll get an assessment of the hemoglobin, you can get an assessment of the lactate levels, and a beautiful parameter-based deficit, which tells you whether this patient is going to require blood or not. So if the base excess is 0 to -2, she doesn't really require blood. -2 to -6, she may or may not require blood. Maybe it's just your fluid that can help her. And if it's from -6 to -10, definitely this patient is going to require blood. You ask your blood bank to issue your 2 or 4 PRBCs according to the clinical condition and the parameters. And if this parameter has reached to -10, you intimate your blood bank to kindly activate the massive transfusion protocol. And a thromboelastography, this provides a real-time assessment of blood coagulation dynamics, and it can guide us as to which product is actually required for the particular patient. So I think we're in the process of acquiring this for our institute, and if we get that, the PBM will be even at a better level. So it will actually tell us that, okay, now this patient requires FFP, or she requires platelets, or you have to give a fibrinogen. So that can be a part of PBM in these patients who are having severe or massive hemorrhage. So we are using the ABGs, we're trying to get the TEG, but in a patient, when you're actually in the OT and this patient is bleeding massively, so by massive hemorrhage, I mean 2 to 2.5 liters has already been lost. So in that condition, our protocol is to that of hemostatic resuscitation. We ask for blood and blood products in the ratio of 1:1:1. That is, 1 PRBC should be accompanied by 1 FFP and 1 RDP to prevent coagulation disorder. And otherwise, if it's a non-massive hemorrhage, if the PT-INR is deranged or if the APDT is more than 1.5 times, we can give FFPs in the dose of 15 to 20 ml per kg body weight. This is done in tandem discussion with the anesthetist who's also taking care of the patient simultaneously. If the platelet count has come down to 75,000, we consider RDP transfusion to 5 to 10 ml per kg body weight. And if the fibrinogen level is less than 2, we can consider giving cryo or fibrinogen concentrates can be given. The other thing that we do is, if we have transfused 4 PRBC, 4 FFP and 4 RDPs, the next patient is still requiring resuscitation and she is still bleeding, then we can ask the blood bank directly for cryoprecipitates the next time. So this was about the intraoperative points to take care of. And then the postpartum things that we need to be certain before we discharge our patient, that in the current scenario, we are trying to raise our threshold for transfusing PRBC in the postpartum. So if the patient is stable, hemodynamically she is stable, she is asymptomatic, not having symptoms of anemia, then the cutoff for transfusion, even for us nowadays, is 7g%. But definitely clinical judgment is required, because supposing this patient has bled from 12 gram and now she's come to 6.5 or 7, you may consider her giving a PRBC and then building her up with oral iron or IV iron before you discharge her. But if the patient is supposing 8 gram and she's giving you symptoms of anemia, she's tired, she says, I'm feeling dizzy, even going to the toilet, I'm feeling dizzy, then you may transfuse. And our obstetric management is not complete without optimization of anemia, and most importantly, our iron stores, because if she came to you anemic and you send her off with depleted iron stores, this is not a good clinician. So administration of IV iron to cover an individually calculated iron deficiency in the postpartum women should be a ritual, as we are trying to do that in our labor room. And again, the cost is a challenge. If the patient cannot afford FCM, try and convince her to take the multiple doses of iron sucrose that are there. Interesting, I mean, it's good for us because in our labor room, the Ayushman scheme sometimes covers the FCM. So if during that particular time period, the FCM is available, we ensure that our patients are getting FCM before they're going home. So the take-home messages are, PBM is not about avoiding transfusion, it's about avoiding unnecessary transfusion. You optimize the red cell mass antenatally, control the blood loss proactively, use blood wisely, and before discharging, correct anemia, send her home strong, not just surviving. Thank you.
Thank you, Dr. Lapita, for very nicely covering the topic, which is very important from obstetrics.
So I invite our next speaker, Dr. Satyam Arora. Dr. Satyam is additional professor in the Department of Transfusion Medicine in PGICH Noida. Under his belt, he is a regional director, Southeast Asia for International Society of Blood Transfusion. He is the chair of Pediatric Transfusion Subgroup of ISBT. He is a certified advanced biotherapy professional by AIIMS and he is a member of technical resource group of NBTC and DGHS. He is a member of the panel of experts for the National Donor Vigilance Program of India and he is also a member of special interest group on blood donors management by ISBT. He has been awarded with Director's Medal for Best Teacher Award by PGICH in 2025. He has received Narendra S. Bagaria Award by ISBTI in 2022. He has also received Young Scientist Award by ISTM in 2021 and he is also a recipient of Dr. Harold Ganson Fellowship by ISBT in Mexico 2012. He has over 60 publications and total citations of 1765 with an HLS of 30. And Dr. Satyam will be talking on a very interesting topic, Kick into a High Gear, Contemplating PBM in Neonatal and Pediatric Patients. Dr. Satyam.
Thank you, ma'am. Thank you for kind words, and thank you, the Department of Transfusion Medicine at AIIMS Rishikesh, for planning and executing this wonderful CME. And they've given me a topic of, kicking into high gear, and I think it's advisable as we were driving towards, Uttarakhand, that don't drive too fast. So I'll pace up my speed gradually, and I think by end of my slides, we all will be in high gear to understand PBM in pediatrics. So pediatric transfusion as a whole, if we understand, it's from fetus to a young adult to an adolescent. So one size doesn't fit all. And this is something that I would like to highlight whenever we are talking about transfusion in pediatrics. So this is something that we've been, discussing since morning, that it's an multidisciplinary approach to manage anemia and to manage blood health in a patient. And there are three main pillars. One is managing the pre-operative, then operative and post-operative. But what happens in pediatrics and in non-surgical settings is something that I would like to highlight. So this is how I have outlined my presentation. I will be discussing some unique issues with this patient group. Then something, what are we targeting? Where is the blood going? Do we have that data with us in India? So we'll be briefly touching the incidence of transfusion in pediatrics. Then you're doing a comparative analysis between risk versus benefit. Then some PBM specific, pediatric specific, and just very briefly on pre-operative issues with PBM. So whenever you are transfusing a child, there are many things that goes into a clinician's mind, that, there's a unique physiology, there are, different threshold and policies that people are following. There are various pediatric subspecialties now. You have a pediatric hemonc, you have pediatric gastro, you have trauma and massive transfusion in pediatrics, then you have neonatology, and everybody requires something very different, which is not uniform. And is there one cutoff? And I saw few of my previous speakers were talking about a magic number of 7, but we'll just see whether that 7 can be applicable in this special population. So we know this population is immature, they're continuously developing, they're going under a rapid neurodevelopment, they're very heterogeneous, and they have the longest post-transfusion lifespan. So transfusing somebody at 40 or transfusing somebody at 45 or 65 versus transfusing somebody at day 1 of life has a different long-term consequence. And that is something we need to understand when we are transfusing a pediatric child. There are many issues when we go deep into these patients, like physiology, blood volume, do you need to warm blood? What is with CMV screening, compatibility issues, donor sparing and limiting strategies, and irradiated blood. And we've been trying to study this globally as well as nationally, that what is the variation of practice, where is the place where we can offer some uniformity and some guidelines. So when you see physiology, so there is a concept of when the child is born, there is a drop of hemoglobin. That drop can be significant in a preterm newborn, and that can be one of the reasons why they receive blood. Even clotting factors are not actually working in a level that they should in an adult, and even the platelets can be non-functional or less functional in a low birth weight child, and the immune system is under development. So these are the factors which can interplay when you're transfusing a child. When you see blood volume, full term is 85 ml per kg, whereas a preterm is 100 ml per kg. So providing them aliquots, providing the volume that they need to be transfused can be very different. And even the iatrogenic blood loss, that can be very significant. Your sampling, your multiple samplings that go to various labs, that can in fact can be one of the reasons why they need blood. Now coming to warming, so do you actually need to warm blood? This is something that gets regularly discussed with our pediatric counterparts whenever there is a new resident. So hypothermia is a significant risk in neonatal age. It can increase metabolic rate, it can induce in hypoglycemia and apneic spells and metabolic acidosis. However, in a routine top-up transfusion, you don't need to warm blood. However, if there is a massive transfusion, you may consider using an inline warmers which are authorized to provide warm blood. Now coming to CMV screening, whenever we look for guidelines, and there's a very famous British hematology guideline, and all these international guidelines, they talk about CMV screening. And whenever we have a new neonatologist in our NICU, they will always come up to and ask, are we screening this blood for CMV? Do we need to screen for CMV? So this is an ongoing discussion. However, this is important to understand that CMV is not something which is significant for us in our population, as most of our donors are CMV positive. So a transfusion transmitted CMV infection is of significance in a preterm newborn, as it is, it can cause many issues with the newborn, and even as small as 50 ml of a CMV positive blood can induce a CMV positivity in a newborn. How it can present with fever, respiratory distress, hepatosplenomegaly, even viremia up to within 2 months of transfusion. But we don't do it because most of our donors are positive, even our patients, our mothers are positive, the staff which is there in NICU is positive. So the patient ends up receiving this virus from the community. Even leukoreduction has shown to reduce the incidence and transmission of this virus. Pathogen inactivation is something new, but however, it is not yet established. Compatibility testing. Whenever a newborn sample comes, we request the clinicians to send a mother's sample. Why do we need a mother's sample? Since a newborn doesn't develop any antibodies till the age of 4 months. And to do a compatibility testing, we need a newborn sample. We need the mother's sample. And in case there is a mismatch between the blood group of the mother and the child, then there is a compatible red cell that needs to be given to the newborn. Now coming to donor sparing strategies and limiting strategies, I think this has grown into PBM. So there was a continuous discussion of reduction of donor exposure in neonatal transfusion, and the risks were risk of TTI, aluminization, immunomodulation, optimal use of resources and lesser wastage. How do we do it? So there is a concept of delayed cord clamping that can offer more blood from the placenta to the newborn. There is a concept of providing aliquots, use of erythropoietin, autologous donation, in even some directed donation. However, there is a risk of TTI along with that. Then there is a dedicated donor program where you dedicate one whole blood to one newborn, trying to give all components. And then there is some intraoperative hemodilution which was discussed by the anesthesia team before me. So these strategies can also be used to reduce donor exposure as well as transfusion requirement. Talking about irradiation, this is needed when you have a newborn who is prone to develop, who's immunocompromised, and you need to reduce the activity of WBCs that you're giving through your blood. It is clearly indicated when you're giving an intrauterine transfusion in a case of premature infants, congenital immunodeficiency, and in an exchange transfusion. However, in a young child with congenital immunodeficiency, recipient of a familial blood or a recipient of an HLA matched unit, these are the indication. However, there are newer indication of potential indication with using it even in a term blood. Now, moving gears, going to something which is routine, which gets discussed with our pediatrician is whether you can use an old blood versus stored blood. So now we can store blood up to 42 days of life. And this unit in blood bank, we follow a concept of FIFO, where we want to use first in, first out. The older unit gets issued first. However, there have been many studies that have shown that there is no significant harm in using a stored blood. But still, there is a catch when you go deep into these studies. Even the stored blood was of an age of 14 to 18 days. So even in these studies, they were not using blood which was very old. Coming to threshold, so there is a continuous debate of going into lower threshold or restrictive threshold of transfusion, and this is something that I tried to compile, for all the major studies and guidelines that were published since 1984, when there's a concept of restrictive use of blood had started. And if you see from 1980s to 90s, the cutoffs were used were lower, and they were only hemoglobin. However, when you come to Iowa trial in 2006, and then there's a Pine trial in 2006, apart from the hemoglobin, they wanted to see the whole cardiopulmonary status of the child, the oxygen support, or what is the need of oxygen and the respiratory support apart from the hemoglobin. So now we know that it's not only one number or a hemoglobin value that can influence the need of transfusion, it's the holistic status of this child. And this is the most recent guideline which is there by the British Society of Hematology. And if you see, it is not only the hemoglobin value, it's the age of the child as well as what is the pulmonary status, whether ventilated or oxygen or even off oxygen. So you can go more lower if there is a lesser pulmonary support that the patient is receiving. Now this is something comparison of different countries' guidelines, British versus American versus Australian versus Canadian. And if you see, there is still no consensus. Every country, every institute, although they are very close to the values that they're using, but still there is no consensus. Now coming to second phase of my presentation, that is, incidence, that how much blood is being used in pediatric population and where are we using it in pediatric population. So if you see, it is one of the most common procedure in an institute in US, and PBM introduction has significantly reduced the requirement of blood. And there is, apart from the overall reduction of blood requirement in the United States, the use of blood in pediatrics is constant and at some places even increasing. So if you see, this is the trend from 1993 to 2014. There is a gradual rise of need of blood, and then there is a significant drop. Now this significant drop is because of introduction of PBM, and that is where the success story of PBM is. And it's there with plasma. However, for platelet, the need has been plateaued. But if you see different age group, now if you see pediatric age group, the need it's from 2.3 to 2.4. It's actually constant. So, even with the success of use of PBM in Western countries, implementation of PBM in pediatric age group, even in Western countries, is being a challenge. Now, what is happening in India? So there is no exact data of pediatric transfusion in India. Dr. Joy had done a very extensive work in need of blood in one of his studies, which used a Delphi method of analysis, and they showed that roughly around 8% of blood that gets required for the pediatric use. So this was actually an hypothesis for us to start a multi-centric work, and this was something that got started 3-4 years back, where we were able to enroll 23 medical institutes across country who received nearly 4 lakh blood requests. Out of them, 52,000 were pediatric blood requests, and I'm happy to share that AIIMS Rishikesh was part of this study along with PGI Chandigarh and Sector 32 Government Medical College in Chandigarh. And we found that overall need of blood is around 65% is for medical indication. However, 30% is for surgical indication. Now, we are talking about PBM in this area. However, majority of pediatric blood gets utilized for the medical indication. If we see what is the demography of patients, so majority of patients that needs in pediatric age group that gets blood is from the age group of 5 to 12, which receives nearly 25% of blood that is collected and provided to our kids. And if you see the history of transfusion, so nearly 60% of these recipients are multiply transfused. So they are receiving not just one, but multiple units of blood. So is there some area where we can actually focus? So this is more detailed analysis, this is for, surgical and medical indication based on age. And this dark color represents anemia. So you see that in all age group, majority of indication of blood transfusion is still anemia. However, if you see this color, that represents hemoglobinopathy, which gradually builds up from young age and starts dominating from the age group of 5 years, and that shows that hemoglobinopathy, that is thalassemia, is still one of our major need of blood in this age group of patient. If we see neonatology, again, majority is for anemia, which is followed by, for component therapy, it is need for surgical interventions like cardiac surgery and delayed coagulogram, which is often associated with, with sepsis. Now, going further deep into, comparing hematology versus oncology. So if you see, red cell need in hematology is dominated by the hemoglobinopathies, whereas in oncology it is majorly anemia, which is requiring red cell apart from the other blood components. Coming to the surgical need of blood in pediatric age group, if you see cardiac surgery, it dominates with majority of blood components, which include platelet, plasma and cryoprecipitate. However, in gastric surgery, which is the second most common indication of a surgical need of transfusion in pediatric age group, is majorly for red cells and FFP. So as we see, even in India, one of the major indication of transfusion is anemia, and this is the most recent PBM document that was released by WHO, and even they show that in Southeast Asia and in South Asia, one of the most common need is for anemia, which is followed by the hemoglobinopathies, and that's the major burden that we are looking. So can we actually implement PBM in hemoglobinopathy? Let's see, I'll try to answer that as well. Coming to next stage of, or next part of my presentation is benefits versus risk. So what is the need of transfusion? So it gives you an oxygen carrying capacity, it increases the red cell mass, treats an acute, chronic anemia. However, the majority of low birth weight infants receive 1 unit at least when they are admitted in an ICU, mostly to replace the phlebotomy losses. 10 to 20% of critically ill children admitted to PICU receive at least 1 transfusion. And the red cell transfusion in PICU are associated with 30% of mortality in 8% of the admissions. So not only they are receiving more blood, even receiving more blood is making them more prone to have an adverse outcome. So what is happening globally as far as the adverse outcome is concerned? So a multicentric study in US showed that 3.23 transfusion events are there with 1,000 children that gets transfused. However, if you compare with adults, it is significantly lower in adult. And allergic transfusion is something which is the most common type of transfusion reaction. What has been reported to hemovigilance? So this is the shots data which reports around 7.4% of all reactions that get reported to shots. That is the UK hemovigilance data is pediatric. What is happening in India? So up to 10%, that's as per our national hemovigilance program, up to 10% of all our hemovigilance transfusion reaction reports that gets reported to the national program is in pediatrics. So pediatrics patients do have transfusion reactions, and they can be a significant number. So this is something that we also wanted to study, and we did a prospective active hemovigilance with our pediatric team, and this is something that we found, and this is an accepted publication now in Vox, should be out maybe by next week. We found that the incidence of transfusion reaction was as high as 6.6% in overall pediatric population. But there was a very interesting finding that in the first time transfusion reaction, the incidence was significantly lower. That means 1.7% as far as compared to people who are getting multiple transfusion. So a multiple transfused child has 7 times more risk of having a transfusion reaction. And when we saw the national data that up to 60% of the kids that are getting transfused in our country are receiving multiple transfusion. So there is a significant amount of risk with transfusion with these kids. This is a further analysis that majority of our transfusion reactions were from the age group of 5 to 12. Again, synchronizing with the maximum amount of blood that gets used. and the majority of transfusion reactions were reported with the platelet transfusion, which is again concurrence with the Western data. This is the national data on pediatric transfusion, in fact international. All the countries and all the places that have published a significant amount of number, and if you see the reports, there is a significant number from 1.6 to 1.7, and there is a difference in type of component and type of study that they have done. So there is still a lot of disparity the way transfusion reactions are reported in pediatrics, and often they are missed and not gets highlighted to the clinical side. Coming to one of the main parts of my presentation is PBM specific guidelines. So do we have a cutoff, do we have a number at which we can transfuse? So I'm happy to actually recommend all the residents to go through these two trials. So this is a top trial, an ethno trial, which enrolled nearly 2,500 newborns across US and Europe to study what is the correct cutoff to transfuse. And surprisingly and very interestingly, both were independent clinical trials done in US and done in Europe, and both reported same numbers that you can go deep. That means for a critically ill child requiring significant support, a higher threshold of 13 or a lower threshold of 11. However, a stable older infant not critically ill, a lower threshold of 7 and a higher threshold of 10 that can be used. So 2,500 kids were randomized across two major continents, and they were able to say a lower threshold can be safely used. It reduces transfusion and donor exposure, reduces transfusion associated risks, and conserve blood. So this is something that I would highly recommend for people who are interested in neonatal transfusion to go through these studies. Now, can we replicate this in a pediatric population? So this was a very interesting work that was done by a group called Taxi Cab, where they went deep into each type of indication in pediatrics and see what is the cutoff. And they started with a number of 5, depending whether there's a massive transfusion or hemodynamically unstable child versus a stable child. And they actually saw that, transfusing at 5 versus between 5 and 7 and going above 7. And I'm not going deep into detail because of the time and the topic that I'm covering, but I just want to show that, for each indication, they were able to precisely say that what should be the cutoff that can be used for journal critical illness, post-operative respiratory failure, sepsis, non-life threatening acute brain injury, alloimmune hemolytic anemia, and further ECMO and further critical illnesses. And this is a very interesting work, and I am happy to working with this group again to develop one guideline dedicatedly for LMICs. Now, coming to the last part of my presentation, some PBM rules, which I'm sure has been discussed. I intentionally didn't discuss them in detail because I know pre-operative optimization and intraoperative stuff was to be discussed. So this is PBM. As we know, it's a patient-centric systemic evidence-based approach to improve patient outcome by managing and preserving patients' own blood while promoting patient safety and empowerment. However, I still doubt patients' own blood when most of my blood is going to thalassemia. How can I preserve the own blood? So this is something that we need to see. These concepts are majorly for surgical scenarios. However, majority of our blood in pediatrics is going for a medical illness. How can we adapt that? Again, this was also presented by Dr. Gopal on the famous 3 E's that WHO also highlighted, that there needs to be ethics with the stakeholders. There needs to be economics, which he discussed very well, that we can save some crores. And then what is the evidence? How deep can we go? How low can we go? And these are some studies which can help us do that. Just as a customary, I just want to walk you through again these 3 pillars as far as pediatric is concerned. So for pillar 1, when we are optimizing the red cell mass, we need to identify nutritional anemia, and we still have anemia as one of the major causes of major need of transfusion. We need to avoid iatrogenic need of blood. We need to pick up high risk group in pediatrics, and then even consider use of erythropoietin. For minimizing blood loss, for an intraoperative work, you can use pediatric size vials. Better surgical techniques can be used, antifibrinolytics, and some point of care testing which requires minimal sampling can be adopted. Then for post operative or physiological treatment or tolerance of anemia, you need to have evidence-based thresholds, and as we saw, threshold varies significantly in pediatric age. Restrictive is something that has been proven that it is better. However, I have not discussed restrictive in platelets and plasma transfusion. Again, use of irradiated, CMV safe and leukoreduced blood, and considering single transfusion or aliquot transfusion in this patient. Just briefly discussing tranexamic acid, it was also discussed by the speaker before me. Even the use of tranexamic acid has been shown to be safe in pediatrics, and it has been now recommended to be used in massive transfusion protocols used for pediatric transfusion, and various organizations have actually recommended the use of tranexamic acid in pediatrics. Finally, as I was discussing, can we use PBM in thalassemia? This is a very new topic. Recent TIF guidelines, which was released in January this year, actually had a small paragraph, and I had an opportunity to discuss with the author that what they actually meant by using PBM. So they actually meant that they want to offer a personalized transfusion protocol to each thalassemic patient, informed consent and discussion, because these kids end up receiving many transfusions, is taxing for patients. Starting phenotype match blood since beginning, because we know this is a high risk patient for having multiple alloimmunization and newer drug trials. As part of our consent, who's initiating a transfusion in thalasssemic child, now it's our responsibility to inform them the availability of drugs, and even if they have a chance to enroll in one of these clinical trials, to see whether these drugs can be helpful for them. And there are many drugs which, even in our center, we have started with 2 of them, and they're showing a significantly better response. Just to summarize, in neonatology, using tiny vials, lesser volume, avoiding unnecessary transfusion, hemoglobinopathy, regular transfusion therapy, alloimmunization prevention and iron monitoring, oncology and BMT, monitoring transfusion reactions, cytopenia, and giving irradiated unit whenever indicated. For critical care, balanced restrictive guidelines for oxygen delivery and perfusion goals, and for surgery, anticipate high blood loss, use of cell salvage, tranexamic acid, and preoperative optimization. I think this is the gist of PBM in pediatrics. We've been trying to work, I work in a pediatric center, and if you scan this QR code, that will take you to a website where it's a dedicated pediatric transfusion medicine website, which is developed by our department since last year, and we try to develop an online resource for education, for guidelines, for various material that you may need to read and to know more about pediatric transfusion. And thank you for your time, and I'll be happy to take some questions.
Thank you so much, Dr. Satyam. You have really justified to the title of your topic, and you have provided us with a plethora of information. And I am sure there will be a lot of questions, and the house is now open for brainstorming session.
Thank you.
Thank you to all our distinguished speakers for that insightful and enriching session. I would now like to invite all our speakers and chairpersons to the dais for the next segment, which is the synergetic brainstorming session. To moderate this session, I am pleased to invite Dr. Kshitija Mittal, who is Assistant Professor, Transfusion Medicine, GMCH Chandigarh. Ma'am is a member of Editorial Board of AGTS, Assistant Editor of 3rd edition 2023 of Transfusion Medicine Technical Manual, NBTC, and BTS Division, and she has 40 publications. She is also a member of Special Interest Group Transfusion Transmitted Infection and Nucleic Acid Amplification Testing of Indian Society of Transfusion Medicine, and a member of ISBT Hemovigilance Working Party. She has been awarded Dr. Harold Gunson Fellowship by ISBT at Cancun 2012 and Malaysia 2022, and J.R. Jolly Award at TransCon 2022 46th National Conference of ISBTI Bangalore. Welcome, ma'am. I would also like to invite Dr. Vijay Kumawat sir, who is Additional Professor Transfusion Medicine, NIMHANS, Bangalore. Sir is MD Transfusion Medicine from PGIMR, Chandigarh, PGD MLS Symbiosis International University, Diploma in Tissue Banking, National University Hospital, Singapore. Sir has a total work experience of 15 years and has international and national publications, NABH Assessor for Blood Centers and Transfusion Services, and Quality Manager for NIMHANS Hospital. Welcome, sir.
So, I would like to invite all the speakers to the dais, please. And the chairpersons.
Opportunity to be a part of this CME. Since morning we have been discussing about patient blood management, how it is about, now it is a systematic, which is a patient-centered approach based on evidence-based. So as we have been learning about it since morning. So now first of all, the first question is to the anesthesia team. So I would like, as it has been already stressed, that minimizing minimizing patient's blood loss. It is an important pillar of patient blood management. And sir has already, Dr. Yashwant has taken up in his presentation about the various measures how we can conserve blood. So just an extension to it, sir. How do you decide when to use intra-op blood conservation strategies, and in what type of surgeries it is most beneficial?
Very right question, ma'am. How to decide when to go for the blood conservation strategy? There are so many things. This is number one. The first is the patient and the nature of surgery, type of surgery. When we are anticipating a large amount of blood loss will be occurring in the surgical procedure, there are so many surgeries in which there is lots of blood is shed while the procedure is being going on. Specifically the cardiothoracic surgery and the orthopedic surgeries, especially spine surgeries, scoliosis correction surgeries, where we are anticipating a lot of brush. That is the first thing. Second thing, the patient is having a blood group which is rare blood group, and when we talk about this rare blood group and availability is the issue, then we can go with this blood conservation strategies in these patients. And third thing, not only the surgical procedure on which our decision will be based on, type of surgery, nature of surgery, and our anesthesia technique, we apply accordingly into that one. That is all what we can consider before we starting our blood conservation strategy.
So furthering to what Dr. Payal has said, I just want to say one thing. There are certain surgeries that in my institute what we are doing, we are going in very frequently for a cardiothoracic surgery where the blood consumption is much more higher. But apart from the non-cardiac surgeries, the other very common surgeries that we are doing is scoliosis surgery, where there is a lot of blood loss. Facial-maxillary surgeries and neurosurgical procedures are other surgical procedures where we do require a lot of blood. And traditionally, what we have been taught and what we have followed is any time whenever the blood loss of more than 10% occurs in the blood of the total blood volume, you have to replace in a pediatric patients with blood. That is the traditional teaching which has come up. But now what we are doing is, like the formula what was shown by Dr. Payal, the lower limit, we have not fixed it to around 10 or 9. We do fix it to around 8. So many times the expected blood loss or the allowable blood loss that we usually calculate is slightly more than the 10% of the body weight. So plus especially in scoliosis surgeries and facial maxillary surgeries, we use a lot of tranexamic acid. So that is there, so that has really brought down our need of blood in the perioperative period. So these are a few things that we regularly do in our place.
Thank you, sir. So next question again to Dr. Yashwant and Dr. Sanjay.
So though we know that it has been extensively covered by the speakers, but still, so we may add on some few more things. So the question original was that how does anemia management and blood conservation impact hospital cost and perioperative outcome? So cost, I think Gopal has covered extensively. He has shown that crores can be shown. So, but definitely blood conservation impact hospital cost and perioperative outcome. So cost, I think Gopal has covered extensively. He has shown that crores can be shown. So, but definitely how to implement that we have seen the figures that okay, it save cost to the patient, it save cost to the institute, it save cost ultimately to the nation. But what are, like, if as a UG or PG, I want to start this cost saving measure, how to start, how to go about that. And second, I would definitely like to add on that the perioperative red cell salvage and ANH, though it is from PG days we are reading, but still I don't see much adaptation in our country. So what are the challenges for that? Like acute normovolumic hemodilution or this perioperative red cell salvages. So over to you both, can answer.
Regarding your first question, that is cost effectiveness. So we are working in a public sector situation, so we that point. Second thing, the cost effectiveness should be going to the last one when we are considering the safety of the patient. Third thing, what you are saying that acute normovolumic hemodilution. Again, while we are applying this strategy for blood conservation for a particular patient, we need to think of so many other factors as well, whether the patient, selection of the patient, and depending on so many other indications in that one. The procedure, how we do it, I already explained in that talk. Yes. We remove the blood from the patient and again transfuse back to the patient. But how much blood will be taken from the patient, that is already been decided after calculating the volume. We take into account the hematocrit values, but we don't allow any patient inside the operation theatre to allow blood loss more than 25% or maybe 20%, depending on the case scenario in a normal healthy ASA grade 1 patient. And we can cut off this limit to a lower side if the patient is having other comorbidity and cannot sustain blood loss at that particular point. So that time we have to transfuse the patient with the blood on the PRBC only. So coughs, that is all what your question. And I am trying to address your question next.
Yes, sir.
Can I add something?
Yes, sir.
You are talking about self-salvage.
Yes,
very good technique. But self-salvage has a very limited indications. Firstly, it can be used in any place where there is no contamination with GI contents. Majority of the surgery, the pediatric surgery that is being done is in those conditions where a bowel is being, so there is always a chance of contamination. First. Secondly, the problem which comes is the equipment is costly. The surgeon should be ready to do that procedure. And the last thing which comes is you collect the blood, you wash, and what you give to the patient is only a washed PRBC. That will only be responsible for increasing the oxygen carrying capacity. Apart from that, all the clotting factors and all is not there in the washed PRBC which is transfused back. So that is the problem with the self-salvage technique. And as far as ANH is concerned, me and Dr. Geeta in initial days, we did try for ANH. ANH again has certain limitations. It's a very good technique. Minimum you should have a hemoglobin of more than around 12 to 14 is what is recommended in the books. You take out the acutely, you give colloid to that, you replace, and then you have to replace back. So suppose I am able to collect 2 or 3 units. The collection is 1, 2, 3, but the donation, the transfusion back is 3 to 1. So what happens is, suppose the patient, I am only able to transfuse 2 units. So that 1 unit which I have taken out of the patient may not be used. That is one problem. Second is, many times again a cost factor is
associated with that because back collection and all those things is there. A support from the transfusion medicine is required so that they can come down to the OT. And this procedure itself takes some time. Many a times a longer surgical procedure, we may not have time or the surgeon may not be ready for us to give that half an hour, 45 minutes or an hour. And the most common problem which occurs is even if we transfuse with colloid, so as to maintain the blood volume, there are always a chance of hypotension immediately after infusion. Because all the blood volume compensation takes time for the body. So these are the hemodynamic changes are very common. If you are going in for advanced surgeries where you don't want hemodynamic changes to this. So we have to be very cautious whenever we are dealing with this sort of a case. So it can be done in a planned condition. You have to give us time, both to the transfusion medicine, anesthesia and the surgeons. It has to be a triangle which should have a very good communication with them. And then we have to think of all these factors before we go in for an So we tried, but initially this was not possible because number of case lists are more, they want to do more cases, bags availability was not there. So then the things slowly and slowly went off. Yes, sir. Thank you so much, sir.
One more thing I just want to add here, use of self-surveys intraoperatively in a pediatric, specifically neonatal surgery, is practically very difficult, and it is not easy to use that machine for a pediatric patient. The total volume of that patient might be around 200, 300 ml. And if you see that machine, the tubings and dead space of that tubings of that machine is too much. So most of the blood will be keep on circulating in the tubing only, and it will be practically it is very difficult to give this in an attempt to conserve 15 or 100 ml, 200 ml of blood, which will be there in that machine only. So that is one practical ability of this machine need to be look into.
Yes.
Yes. So, thank you so much. Now my next question is to Dr. Lalika. AIIMS being there is a high pressure and it's a high demanding brand. So just another question, do you think there are any specific challenges in managing both clinical care and administrative expectations which are related to this PBM? And does this PBM implementation create an undue burden for the clinician to deliver patient care?
I wouldn't consider this PBM as a burden. In fact, if you're a good clinician, you have to incorporate this in your clinical practice. So like I said, your patient is giving you 8 to 9 months for an antenatal, threats advanced to be optimized. So if you don't use that opportunity, if you think it's a burden for you, so you fail as, your duty as a clinician is you're failing in life. Certain challenges are there, probably logistic issues, because we are prescribing oral iron, we're not sure if the ladies are taking it, because we do have questions to, understand whether they're actually consuming it and tolerating it. But then, like I mentioned in my talk, if you can supplement that by IV iron, that would be a fantastic way of incorporating PBM antenatally. And some challenges are there because it's expensive. A single vial of 1 gram which costs around 6,000 to 6,500 rupees. In the government setup, getting that for our poor patients, we have to admit them and then administer. So that is one administrative issue that we have to go through, but not much of a problem in government setups. But sometimes the AIIMS doesn't cover it. So they're trying to convince that lady, see, either you take FCM or you come back for multiple repeated injections to prove because it's much cheaper. But then she has to visit the hospital at least 7 to 8 times for entire dose to be completed. So there your counseling works. So if you know that you have to correct anemia, so it is how you counsel her, it is how you counsel her husband and maybe mother-in-law, very importantly, because they are, I think, a driving force in the management of an antenatal. So it's how you counsel the family, that's also there, but we don't consider it as a burden, it's a part of our job.
Yeah, thank you so much. So that's what the WHO has come up with, that primordial prevention where the social factor also need to address. So that optimally sets in, like classical example in OBG care, where the family, particularly mother-in-law, has to come in and decide.
So in continuation with the same theme, though you have covered extensively in your presentation. So your second question, are current obstetric training programs adequately preparing future clinicians to implement PBM, and what improvement would you suggest further?
At the moment, our programs do not cover the PBM as a part of our curriculum. We are very grateful because Geeta ma'am and the entire team of Transfusion Medicine has been trying to tell us about PBM, and that's how we picked up the concept. However, the Federation of International Society of Obs and Gynae, the FIGO, it has adopted and it has recently brought out the guidelines for PBM. And those similar guidelines for management of obstetric injuries are also endorsed by the NETA and also by the European Society of Anesthesia. So those things ideally should be brought into our curriculum. They are not there in our books as of now. So I think seminars like this would be helpful for that. So the curriculum needs to be slightly more revised to incorporate these methods of blood management.
Thank you.
Thank you. So now we move on to the pediatric team. So as now my next question is to Dr. Satya. So as you've already stressed upon in your presentation that iatrogenic blood loss is not being very much tolerated by the pediatric population. So how can we safely minimize this blood loss in pediatric and neonatal ICUs, particularly in extremely low birth weight infants?
Yeah, so this iatrogenic blood loss is one of the main causes of transfusion in this group of patients. So obviously using microtainers or small vials, avoiding unnecessary investigation, going for a lower threshold where you know you can wait. Sharing of samples, this is very important. I need a sample just for a blood grouping, which can even come from pathology after they have done a CBC. So the concept of sharing of sample is very important when you are dealing with a preterm newborn, where you don't need to send independent samples to all the lab, and if all the labs can sit together and maybe work on a protocol where they know how, in which sequence can they share one sample and can give you all the results. And then obviously using this point of care testing equipments or even non-invasive equipments for estimation of bilirubin or maybe for hemoglobin. So I think these ways, apart from the cord blood, the delayed cord clamping and cord milking.
So anything, madam, to yes.
One thing I would like to talk on Dr. Satya being a neonatologist. Actually, we maintain a strict chart that is very essential. Residents have to be sensitized that for a 600 grammer, the total blood volume is only 60 ml. So even if taking 1 ml of blood is amounts to almost 10% of total blood volume. So this is very very helpful to tell them and decide what is the need. One more thing, there is again a way of losses by putting different kinds of tubes. Like you need central lines, otherwise it's very difficult to manage these neonates. Like you need umbilical, venous line, arterial line, invasive blood pressure monitoring, you need peripherally inserted central lines for providing PPM. Each time you put these lines, there is at least 2 to 3 ml of blood loss. You can't help that. So ultimately, each extremely low birth weight neonates, they will land in having multiple transfusions. And sharing of samples is a very good idea, but maybe it is difficult, administratively it is difficult. And most of the time we do micro sampling, like it is from capillaries and just drops of bloods. But again, doing blood culture and all require at least 1 ml of blood. So the main problem is blood loss.
So, thank you, ma'am. So again, next question to you. So our current blood center protocol and as well as pediatric clinical pathways aligned to support PBM principles, and what educational resources or training models have proven effective in improving PBM adoption in pediatric and neonatal care?
Like we have our own NICU protocol. I am not in pediatrics, so I've left pediatrics for a long time, so I can't say much. But in our NICU, we have our own unit protocol, and we revise that as the standard guidelines like TOP and ETNO that Dr. Satyam has said. Earlier it used to be the liberal guideline, and nowadays everybody is switching to restrictive guideline because there are different forms of injury. There are different dangerous terminologies, try. So, and really these reactions occur. It's not that they are written only in books, they happen really in actual practical life. So, we use restrictive guidelines, and most importantly, we keep a Google datasheet so that no resident can fudge in that to have actual patient care data.
Yes, Satyam, you would like to add something?
Yeah, something just to add beyond pediatrics. I think if you go, one of the most common cause of or need of transfusion in pediatric is in United States. Can anybody guess that? What can be the number one need of blood in pediatric age group in United States?
Anyone from the audience?
Who's looking into articles recently? So, no, in pediatric age group. I am sure my answer is going to surprise everyone. So it's gunshot injury. So you see the difference of what is causing a transfusion in the Western world versus in India. There is still transfusion for thalassemia because we are not able to control it. So there are different policies, different ways of strategies which they are working on because of their demographic need. And it's high time that we realize what is our need and where are we investing our energy into. We often will get international guidelines which are based on something which they are facing and they're least bothered what is happening in India. So I think for pediatric it is important that it is now proven to go for a lower threshold. It is now important as we saw that the most common cause of indication is still anemia, and most common cause of anemia in India is still nutrition. So for example, for a cyanotic heart disease going into surgery, will have a pre-surgery hemoglobin of maybe 21. He doesn't need a hemoglobin optimization, but what he needs is better nutrition for him to get into surgery. So this is what we realized when we work with the cardiothoracic team, that they are often working on nutrition of the child so that the child can sustain. I'm sure our anesthesia team may agree with me, so that they can sustain a cardiopulmonary bypass and surgery. So in India, our needs, our requirements are different. I really like the presentation that Dr. Gopal presented, nearly 50 articles and none of them were from India. So there is a high time that we publish whatever we are doing, even if it is less or for more, one institution, multiple institutions. Let's have our own data to decide upon our own guidelines.
Thank you so much. So do we have time to take questions from audience? Okay. So I thank our panelists for joining us for this synergistic brainstorming session. So thank you so much. Over to yes, sir.
Thank you. I think first of all I would like to congratulate Geeta for roping in our clinical colleagues, and I must thank all the clinical colleagues sitting there till lunch and giving their valuable inputs. And I think this is the time. I think this is the beginning, and I think this would be in a long run an example to all of us that our clinical colleagues are enthusiastic. There were one or two questions which you asked about anesthesia colleagues, that ANH and all those blood loss regarding those things. But you see, now I have seen over the trend had shifted, because previously for bypass they used to require 5, 6, 7, 8 units because there was long circuitry and they have to basically grind those circuits. But now the technology has advanced in such a manner, and that the requirements have drastically gone on. Similarly for knee replacement, for arthroplasty, the techniques, the surgical techniques have evolved that you hardly require blood now. And moreover, regarding cell salvage and all, sterility is also a big concern actually, because blood is a very good culture medium, and then of course when you transfer it back, you never know that it may get contaminated because it's in more or less Sometimes it gets contaminated from the OT operative side or when handling that blood bag and the storage conditions. And another thing is for the neonates, which was being discussed is yes, that idea of centralized testing, because I think all of us as clinicians or transfusion experts or the laboratory people, because now in our All-India Institute Delhi, they have only one centralized lab medicine, I guess Gopal is area. They have only one centralized, one sample goes and all the tests get done. So I think we need to develop those kind of facilities. That way I think we can reduce the sample handling and errors also, because sometimes what happens, I think that thing has not been brought out here, the most common cause of incorrect or adverse transfusion events still in world over is incorrect identification of the patient with the bedside. So that way we, I think all those things can be minimized, because repeated sampling and all those things can be minimized, and of course the workload, that in turn will decrease the workload also, the resident side also. We have calculated that even when we try to convince our colleagues that by sending repeat requisitions you are unnecessarily wasting the time of your own time, which can be utilized in effective clinical management. So I think with this I thank again and thank you all for joining us. Thank you very much.
A big thank you to all our wonderful speakers and chairpersons for this engaging and insightful session. We will now proceed with the felicitation ceremony of our esteemed faculty for this session. I request our esteemed chairpersons, Dr. Sriparna Basu ma'am and Dr. Sanjay Agarwal sir, to felicitate our speakers. Dr. Yashwant Singh Payal sir, Dr. Latika Chawla ma'am, Dr. Latika Chawla ma'am, Dr. Satyam Arora sir, I would now like to invite Dr. Atiram Sharma sir and Preeti Helens ma'am to felicitate our chairpersons.
मैडम ऑर्डर कि आप जो बैठते हैं
एक मिनट में एक मिनट आप चेंज
I I would now request Dr. Geeta Negi ma'am and Dr. Daljit Kaur ma'am to felicitate our moderators, Dr. Kshitija Mittal ma'am and Dr. Vijay Kumawat sir.
एक मिनट हो रहा हाँ हाँ सही है हाँ अब ठीक है हाँ बोलिए हाँ हेलो हाँ अभी ठीक है ना कर दिया हाँ
Thank you all. I now hand over the proceedings to Dr. Amit Chatterjee, PTCC resident, Department of Transfusion Medicine, AIIMS Rishikesh.
Thank you, Dr. Megha. Namaskar and good afternoon once again, ladies and gentlemen. We now have something truly special. Stories straight from the frontliners of patient blood management. This session is delving into experience sharing where we shift gears from guidelines to ground level action, from protocols to practical pearls. We all know PBM looks great on paper, but bringing it into daily practice is where the real story begins. And today, we are going to hear just that. Real insights, challenges, innovations, and wins from across the country. So sit back and let's absorb some lessons that are not found in any textbook. To guide us through this meaningful session, we are honored to welcome two exceptional names in the field of transfusion medicine. First, Dr. Anupam Verma sir. First, Dr. Anupam Verma sir, professor at SGPGI Lucknow. He has served as Chief Medical Superintendent at Kalyan Singh Super Speciality Cancer Institute, was the first state nodal officer for hemophilia in Uttar Pradesh, and currently holds national academic leadership roles as Joint Secretary of ISTM and Vice President of ATOM. His area of passion include clinical transfusion, patient blood management, hemostasis, and quality control. Joining him is Dr. Sushant Kumar Minia sir, Assistant Professor at AIIMS Jammu, a dedicated academician with over 10 years of teaching experience. He has previously led department at AIIMS Bathinda and played a key role in establishing transfusion services both at Bathinda and Jammu. A recipient of advanced certification in PBM and transfusion medicine, Dr. Minia sir is an active member of major national and international bodies. I now invite our respected chairpersons to kindly take over and lead us into this inspiring stories that we are calling Exchanging PBM Vows, Experience Sharing Through Original Work. Over to you, sir. Thank you.
And moving to session 3, now I invite Dr. Ashish Jain. Dr. Ashish Jain is very dynamic, the boy, and he has been a regular staff member at PGI now, our student also, and he has done MD and postgraduate diploma in medical law and ethics from Bengaluru. He is General Secretary North of ISBT, He has more than 35 plus publications and recipient of Young Scientist Award and Professor V.L. Award in 12th Annual Conference of ISTM in Mahabalipuram. He is also a recipient of NPTEL, Student Government of India Star Award. Very nice CV you have, and he's credited with, as we are told, that
He was instrumental in designing and writing the lyrics of anthem of AIIMS Rishikesh also. So over to Dr. Ashish Jain, and I really must thank Dr. Geeta and Dr. Ashish, Dr. Daljit for this very nice CME. I'm very surprised by the use of these words like exchanging PM balls. I just thought that hopefully there is no ring ceremony and all that. So I'm really nice. First time I'm saying this. So Dr. Ashish, please go ahead with your presentation.
So thank you, sir. So as a transfusion medicine specialist, actually when I joined MD in 2012, and sir, ma'am is both here, and I recall my first experience when I was in MBBS second year and starting the clinical posting, and the first day of posting, experienced surgeon came with the patient who will be operated next day, that you will not need any transfusion, I will handle it, don't worry. And the same patient in the previous night in the posting, I assessed the pallor. This is the first pallor case I assessed. My senior resident shown me in the posting that, though, look, this is the pallor, you have to see that how you can see the pallor. The next day the patient is being operated and surgeon is saying you will not need the blood. So I was amazed that how the surgeon can say that the patient is need blood or not. So even the routine in the practices, I can see that most of the calls, even the patient and camp organizer and patient attendant कहते हैं कि बस डॉक्टर साहब ब्लड रिजर्व के लिए चाहिए, ज़रूरत नहीं पड़ेगी. So I used to think that what are the predictors? How can you say that the blood will be needed, and how can you say that this patient will need the blood? So I had a question that who will need the transfusion? Who can tell that the patient will need a transfusion at elective operation? Mahadev. Bhagwan to batai denge. The God will tell that this patient has what is the outcome, but unfortunately we cannot assess God directly. Experienced surgeon, experienced doctor. What is unique about this doctor? White hairs, wrinkles. This all can tell. Even the one shadow or maybe that one look of this surgeon can say that he is very experienced. He can tell by his or her experience, any surgeon can tell the patient will need a transfusion or not. So these have a lot of predictors. He has experience of a lot of variables in his life that this patient will need a transfusion or not. And important thing about the statistical analysis. By mathematics, we can say that this patient will need a transfusion. Right now, the AI, I think AI has introduced in class 3rd recently and by NCRT. So that artificial intelligence era, we can, without any investigation, without any even that analysis of the real analysis, we can have the past analysis and the prediction by artificial intelligence, we can say that this patient will need a transfusion. So currently there is a variation among the institution and surgeons. A patient of a simple operation, even at a hospital, even the government setup, in the private setup of the corporate, the patient, we cannot say that this patient will be transfused in this hospital, this institute. The transfusion decision may vary in real practice. Inadequate prediction of intraoperative needs, because the patient may require the bleeding, the kind of surgery, the extensiveness of the surgery. It's depend on the surgeon skills, even that the lot of comorbidity, a lot of factors that can decide that the patient may need a blood intraoperatively or not. And mostly, just I have told initially that I have seen the pallor in the patient. So I have the estimate this patient has the pallor, he will definitely need blood during the operation. So over reliance on the hemoglobin threshold. A lot of predictive factors are identified. Hemoglobin level, no doubt. Age, more the age, the higher chances of transfusion. Female gender, low BMI. American Society of Anesthesia score of comorbidity, Charlson score, a lot of scores are there. The patient have the comorbidity, have more chances of transfusion. Surgical factor, type and duration of the surgery. Lambi surgery, long surgery, 12-hour, 13-hour, 16-hour surgery. The surgeon anesthetic told that kindly keep reserve the blood. We are extending the duration of the surgery. That will hint that the more blood is required during the surgery. Anticipation of the blood loss, surgical approach, open or minimal invasive. So a lot of predictive factors that can predict, or maybe that variables among the patients that can tell about that the patient will need a transfusion or not. So statistical method I will tell about that. How can we say by statistics that this patient, what is the difference between the patient who is going to be transfused, who is not going to be transfused, and what is the different values of different parameters in these two category of patients. So simple statistical test like simple t-test, even that ANOVA test, independent t-test, even the non-parametric test, Friedman test, Wilcoxon-Sandeng test, a lot of tests we can do, and we can demarcate in two categories, transfused and non-transfused. And we can say the different variables in these two categories. Odds ratio, we have all know about the odds ratio, the presence of the risk factor. So something is present in the transfused category, more or less. Odd 1 means none, nothing, there is nothing significant. 2 means more than 1 is the risk factor is definitely present in this category. Regression analysis, we have seen a lot of regression curve, in even all the articles having the regression curve, regression coefficient value. So this key all can tell that this patient, this risk factor or variable is more associated with the transfusion, or this factor is less associated with the transfusion. So now it is an automatic linear modeling is a recent regression, the SPSS software and R software who can know that there is a recent addition of the linear modeling, then can tell about the accuracy of that risk factor associated with the transfusion. Not going to the detail of the statistics, but even that the ROC curve, that is the ROC curve is highly associated with the sensitivity of any risk factor that is associated with the outcome. Machine learning algorithms, random forest, a lot of neural networks, a lot of computer softwares are coming that can tell about that the patient will need a transfusion. So outcome is any patient that need more than 1 unit of RBC or 1 unit of RBC perioperatively, maybe during operation or after the operation. So I took some predictive factors from the studies like hemoglobin less than 10 is associated with the odds ratio of 5.2, means around 5 times more in the transfused category. Older age, female sex, low BMI, comorbidity 2.1 means more in the transfused category. Major surgeries, odds ratio 4.5. So it depends on this risk factor major surgery in the transfused category is 4 times more associated with as compared to the non-transfused category. So some data I have collected because I love statistics and I love to play the data. The more data, it's a kind of addiction that the more analysis you will do, will find more models to analyze. So some data I have collected retrospectively from a neurosurgery department. So 224 patients and the 6 type of surgeries and 3 different surgeons were compared. The predictors were taken baseline hemoglobin difference, that is the post-operative versus pre-operative hemoglobin. Ideally the blood loss should be taken, but it is difficult to take the blood loss because for that the OT note should be reviewed. But this all data is available in the e-hospital so that I can easily take. Surgical indication, surgeon, age, gender and presence of comorbidity in the discharge note. In the transfused category, the mean hemoglobin was 10.34 and in the non-transfused category, mean hemoglobin was 11.71. So there was no statistical difference, but the difference in hemoglobin was more in the transfused category. Okay, and age, generally neurosurgery has the trauma, so that the having a less age, but in rest of in the literature is found that the higher the age, the more chances of the transfusion. So this is the cross tabulation. I think you can see that by the diagnosis you can say that it depends on the diagnosis also. Like traumatic trauma cases, aneurysm, they have the more in the transfused category. Brain tumors, spinal surgery, they have the more in the non-transfused category. So depend on the type of the surgery. We can do this analysis anytime. It's a long, more the data you can have the more number of diagnosis, more subcategory of diagnosis, and even the different classification of a diagnosis. So this it can be analyzed easily. And about the surgeon, जो बात आई ना शुरुआत में, वो surgeon say that कि patient, even that it's common on the patient कि blood less surgery is done by this surgeon. So this surgeon is very less blood is transfused. So it depends on the surgeon also that some surgeons may prefer to take a higher threshold, some prefer to take lower threshold. So it depends on the surgeon also. In odds ratio in this category, that hemoglobin was of less than 10 is 3.62, so that around 3.62 times that the transfused category, hemoglobin less than 10, comorbidity 2.6, age greater than 6'5", because for that I have excluded trauma cases, so 2.1, and female gender is 1.2 times. So I have also done the regression analysis by Linear modeling and show that what is the accuracy of preoperative hemoglobin. So I think anybody can tell what is the probability, transfusion probability when we say this is significant. I think nobody want to answer. More than 50% is when we say that this is actually the accuracy, or maybe say that the transfusion probability is greater than 50%, then we can say that the patient will need maybe the land up more chances of transfusion. So only the preoperative hemoglobin having the accuracy of 23%, and hemoglobin difference post-op versus pre-op is 35.9%. But when we take both preoperative hemoglobin and hemoglobin difference, the accuracy land up to 60.7%. So this statistical analysis can say that the patient having the low hemoglobin and the more hemoglobin difference or more chances of the bleeding, that is the more probability of getting transfused. And when we compile with the gender, its accuracy is increasing, or more factors like presence of comorbidity, 75%. So this kind of analysis, the purpose is showing that the by statistical analysis, maybe महादेव से कहने से पूछने से हम बच सकते हैं, भगवान से कहने से, or maybe that the experience observer, maybe subjective difference can be avoided if we are doing some mathematical calculation or statistical analysis. So we can predict that this type of patient will need transfusion, this type of patient will need not transfusion. So what is the application of this? The PBM. It was even the most of the literature, even that is that to categorize the patient. The patient category that will need the real PBM implementation, because a wider implementation or generalized implementation is real time a difficult task. So if we find out a category of patient that is highly beneficial and maybe have the more probability of transfusion, that if we target this population, that the PBM concept can be more justified. Even the counseling and the type and screen and type and cross match policy can be used by if we are doing the good probability analysis, and importantly resources optimization. So limitation and challenges is that this data analysis is complex. Actually we have to take a lot of patience in entering the data, analyzing the data and selecting the data. Okay, and the population difference may be there because it depends on that. Even in my center, we can say that this patient may be like a craniotomy, leave a less probability, but maybe in some other center, they have a different approach or different technique. So this patient will need a different kind of transfusion probability. And surgeon variability intraoperate events are unpredictable in real time. So future direction is incorporate real-time intraoperative data, artificial intelligence. So what is AI? I think AI is to actually even yes. So next is coming. So okay, AI is very important. So I just want to tell that this is the last route. That the more the data, so that even the filler in the vacancy of the data can be filled by AI. So okay, so multi-central collaboration is needed for that further analysis. Or patient-specific PBM dashboard can be implemented if we are having the good probability of patients who are requiring the transfusion. So these are the references. Thank you.
अब वारी है एक बहुत ज़रूरी इम्प्लीमेंटेशन का, लंच ब्रेक. सो विल मीट आफ्टर 1 hour, 3:15 sharp. Thank you.
AIIMS Rishikesh, and I had the privilege to be his co-wife also during his residency. So Dr. Daud is working as assistant professor in Department of Transfusion Medicine at AIIMS Rishikesh. He has done his MD transfusion medicine from AIIMS Rishikesh. He has been member of working parties leading transfusion social media, education, life-threatening hemorrhage subgroup ISBT. He has been joint secretary Transfusion Medicine Academic Society, that is the MAS, ex-editor Transfusion Medicine Academic Society. core organizing member for various national and international CME conferences, co-guide of multiple post-study thesis projects and PhD project, trained in competency-based medical education for faculty, transfusion medicine, Transcomed 2023, Jaipur, Pondicherry. Now I would like to invite Dr. Daud for further proceedings.
Respected dignitaries, faculty members and my dear colleagues. First of all, I would like to thank Geeta ma'am, Daljit ma'am, Ashish sir for providing me a wonderful opportunity to share my insights on a topic which is novel and very much of coming of age. It's about a development of an AI chatbot using large language model for patient blood management, a simulation-based prototype evaluation. So first of all, my team members, even though the idea is mine, the technical expertise and everything was provided by Arun Vijay, Assistant Professor, Malabar Medical College, Calicut, Kerala, and my HOD, Arun Rajendran, HOD AIIMS Bibinagar, Hyderabad, and Dr. Ashwin K. Mohan, Senior Resident in my own department, AIIMS Bibinagar, Hyderabad. So I would start with about patient blood management and like what it is, like what are the 3 pillars of PBM and all. Whole day like we were explaining in detail, so I'm not boring you with my 2 cents on that. So coming to the challenges, various challenges in patient blood management, we know that like we are using a lot of guidelines which are like very complex, very nuanced from the like international guidelines. So, and like there will be some decision fatigue among the clinicians whenever they will be meeting with a lot of decision set points that will lead to a deviation from the standard or current practice, like the ideal practice. And you know that like there are knowledge gap among the clinicians, because we all know that like in the UG curriculum, we have not been taught transfusion medicine extensively. So those like people who are still in clinical departments may not be aware of a lot of things which is coming new to your branch, like regarding like patient blood management and things. And resource constraints, we have to talk about resource constraints in a country like India, a developing country like India. So still we don't have a unified patient blood management guidelines. So coming to my topic, artificial intelligence as a solution for PBM challenges. If not for all, at least for some of it, like we can, the artificial intelligence has emerged as a solution. So why artificial intelligence? Because its ability to process complex guidelines and present contextualized recommendations. Just like if in Google, if we have to search, like you have to put some search terms. According to that, they will provide closest information. But in a artificial intelligence era, if you provide a scenario, it will be giving directions based on the context. And 24/7 availability if there is a good network, and consistent application of evidence-based practices. Whatever data we provide, like the latest guidelines, if we give, it will work fine. So it will be, they will be answering according to the guidelines or data set we provide. Just like instead of, if we go to ChatGPT or Grok or any other chatbot models, artificial intelligence tool models, they will be taking data from all over the internet. So they will be giving some nonsensical data, they will be giving non-existent references. So we may get confused and like it will lead to a lot of chaos. So if it is very concentrated, very focused on the topic provided, if we have a PBM bot only which will take data only from the guidelines we provide, then it would be a better alternative. And potential to learn from and adapt to new evidence. This is also a very important point, because if you ask the AI tools, chatbot, today one question, and if you repeat the same question after 30 days, the responses you get will be different. because the AI chatbot, it will learn from us. It will learn from the feedback the humans provided. So, and standardization of care across different clinical settings. If we implement this chatbot in a uniform manner, it can lead to standardization of care. So our aim was to develop and evaluate an AI-powered chatbot trained in internationally accepted PBM guidelines to assist clinicians and transfusion physicians alike. So like it involves development, simulation, like we will be testing with some 10 diverse clinical scenarios related to PBM, and that we have taken from the textbook of AIBB, transfusion, hemostasis and apheresis. And then evaluation, assessment of this chatbot responses through objective evaluation, because we took this book because it is giving multiple choice questions, and so like there will be an objective evaluation possible rather than subjective variation in the assessment. So coming to the chatbot development, first step was like data collection that we have taken from majorly from 4 guidelines. That is first one AIBB guidelines, then from Australian Blood Authority, and then from National Blood Authority Australia and BCSH guidelines and NICE guidelines. These are the 4 guidelines we used, and we have uploaded to our database. And second step was AI model selection and training. We have used a large language model which is Claude Haiku 3. That is like not an advanced version. It is still a like very basic version, but still we have a like potential of developing into higher models and higher versions. So still we have done a lot of fine tuning in the domain specific content, like whatever we have scenarios we have provided, like based on that, like we have done a lot of fine tuning, because whatever we have to do this restrictions which we place on the chatbot, because if we allow it to freely act, it may tell you some nonsensical things and all. So we have to put some certain restrictions. So for that, like we have to do a lot of fine tuning. Then interface development. The interface should be very smooth between the clinicians and the chatbot. So these are the like major 10 clinical scenarios which we have taken from AIBB textbook. And that is that I think like we have almost covered almost all parts of PBM, pre-operative anemia management, massive hemorrhage protocol, pediatric management, and transfusion considerations in hemoglobinopathies, management of transfusion reactions. Almost wide variety of segments we have covered. So like this is how it looks like. So this is an example, like we have put, like this is about a 67-year-old woman with rheumatoid arthritis. We were asking, like we were giving hemoglobin, ferritin and all those things. Finally we were asking like she needs 2 units of PRBC transfusion. Should blood be released or not? So the chatbot will be giving bullet points that quoting different guidelines which we have provided, AIBB guidelines, NICE guidelines and all. Finally, in summary, it will give one suggestion like this. I'm not telling you to blindly follow the chatbot, but it will be acting as a support tool. You can only take it as a support tool, not as a decision maker. So this is another example. Like this is a case of BMT and about the platelet transfusion. So what is the appropriate step? So they are also same, like the pattern will be similar. They will start with AIBB guidelines and adequate references, like you can cross-reference the guideline. That also like it will be providing. Finally, as a summary, like it will tell you whether to proceed it or not. So like that, like we have, like I have quoted some 2-3 examples only. So coming to the discussion, implications of practice. What are the strengths? Like if we do use this artificial intelligence tool, what are the benefits which we can get? Because we can get a holistic idea of what all guidelines are available at this particular scenario. For this particular scenario, what can be the plan of action? So they will be quoting all these guidelines, and there will be consistent application of evidence-based recommendations and potential for 24/7 decision support. As I said, like if good network is there, it can continue. And detailed citation of guideline sources. It will be quoting, the references will be there, you can cross-reference always. And limitations, you know that it can never replace humans, at least at this point of time, we cannot. So whatever scenarios we have tested, we can say that almost 60 to 70% accuracy we have found, and we are still fine-tuning it. like it is not in a final version. It is still in elementary stage. So we can do a lot of things. And now also, like, we will go on with the expert evaluation and notes. Now we have not done that. Just 10 clinical scenarios we have taken, and we have taken the responses from the textbook and we have compared the responses, whether it is giving the right answers to the multiple choice questions or not. So still, like, if AIBB guidelines say something and NICE guidelines say something which is different, like the chatbot can be getting confused. And like, and again, patient preferences, that also, like, it has least concern, because it will still suggest blood transfusion to a HAVA witness patient. So these things only clinician can do. Even with the support of this clinical tool, it cannot replace. That is the bottom line. So it represents a promising clinical decision support tool, but cannot replace clinical judgment and human expertise. But you are as good as your tool. So if you have this tool, like, you can perform better. That is something like we can say with certainty. So the biggest takeaway from this point is it can still effectively support clinical decision making, but it cannot replace humans. And next step, what we will be doing, now we have just analyzed the multiple choice questions early. So we will be using a lot of other questions. We will be using statistical methods to analyze. We will be giving it to the transfusion medicine experts, and we will be comparing our chatbot responses with the transfusion medicine experts' opinion, or like their answers, responses. And we will be fine-tuning on basis of that. So this is our plan. Like, I wanted to, like, present it just as an idea, but I think it is still in primitive stage that I have to tell again and again with a disclaimer. But still, I would like that this is not, I'm not just bluffing. So I just wanted to show, like, if it is possible, I can show a live demo, but it is still a, like, infant, not even infant, it's a neonate. So please don't harass my neonate. So but still I will just show you that, like, it works. It's not that, like, I'm not bluffing, it's work. So.
Very good afternoon to all. Myself, Dr. Vaidehi Prashant. I would like to take this opportunity to thank all my teachers for giving this wonderful opportunity. So, from morning we are hearing about what is patient blood management, what are the benefits, how do we implement the challenges, the risk associated, etc. Our faculties also shared their experience. Now, I would like to share our experience as a team in Rishikesh, where we implemented patient blood management program for platelet therapy among hemato-oncology patients. So you will be thinking, why platelet therapy? Why for particularly hemato-oncology patients? So as we all know, when we see the transfusion population among the patients, it will be most commonly hemato-oncology, and they will be mostly receiving RDP or SDPs. So when we see our guidelines as well as RCTs, we could easily see that platelet transfusion triggers randomized control trials are very rare, mostly 2 or 3. But when compared to RBCs, it will be more than 8. So I would like to share our experience right now. So we all know what is the need of implementation of PBM. We have already discussed that there is only prudent use of transfusion only when required. So ultimately, we are reducing the transfusion load over the patients and thereby the risk associated with this. Mainly the allogenic component and thereby platelet refractoriness. So the patient safety is the main key here. And is there any need for a regular audit here? So we will be doing transfusion to all the patients whenever it is required, and we will be continuing our own practices, but we are not checking whether we are doing it right or not. So in order to reduce any unnecessary transfusions, we should do regular audit, and thereby we can understand whether we are following evidence-based guidelines, and we can actually evaluate the effectiveness of the practices. So what is the main challenge? The main challenge is the lack of awareness, especially among the medical professionals as well as the patients. So what we can do for this? We can do combine all the stakeholders, especially the doctors, nursing officers, technical officers, the patients, the hospital administrators. Everyone should be aware of the PBM. So how to implement it? As we have already mentioned, gaining knowledge is the most important thing. So through thorough data gathering and effective interaction by the diverse stakeholders will help in implementing. So how will it change it? So there will be an attitude change as well as structural modification and resource allocation for the right patient, for the right transfusion, for the patient safety. And Through this, we can also formulate hospital transfusion committee for the smooth practices of PBM. So the study we conducted was in AIIMS Rishikesh in 2022. So we collaborated with the Department of Hemato-Oncology, and our main aim was to implement an effective PBM program for platelet transfusion therapy. So the primary objective was, first, we made a team. So that team was named as platelet transfusion practitioners. So it comprised of doctors from both the department, the nursing officers, as well as the technical officers. And second thing is, we trained and educated them. And third thing, we studied the appropriateness of platelet transfusion mainly through audit. So coming to the secondary objective, we mainly focused on what is the effect of this platelet transfusion, mainly through CCI calculation, and we also took the feedback from all the clinical end users to analyze. So the methodology was a simple quasi-experimental study. It is not a new term. It is basically, in simple words, it is basically a true experiment without randomization. So this was a one-year study. We divided the phase into three: a pre-intervention, intervention, and a post-intervention phase. So during pre-intervention, we did an audit as well as a component stock assessment, and also we followed each requisition form with bedside transfusion practices and 1 hour CCI count. And also we took a survey of all the stakeholders, whether they know regarding the platelet transfusion practices, especially their self-perception, knowledge and practice. Same thing was done in post-intervention, and during intervention sections, multiple interactive educational sessions were given. So in the end of the post-intervention, we took a feedback. It was basically made of Kirkpatrick's model. That means we asked their reaction, how did they feel, how did they learn, and what was the impact on these sessions and the results. So these were the interactive educational sessions we were given. So that time, now we have ABB guidelines, which is like comprised. So when we were doing this practice, we never had a formulated guidelines. So we made a pocket book out of it, and also we displayed the platelet transfusion practitioners as a poster. So coming to the results, I am first going to the audit results. We received almost 556 requisition form, 254 were
coagulation monitoring is required. Thank you.
Next resolution, we move to next speaker and we take the question about the questions. Our next speaker is Aarti Kumar. She is a resident field technology first year, Department of Transfusion Medicine. Her areas of interest are therapeutic cell salvage, patient blood techniques, clinical techniques in the cardiac surgery, clinical research in cardiothoracic surgery. She has been awarded a university rank holder in BSc Perfusion Technology, Chittor, Pondicherry. We can start with the presentation.
Good afternoon, chairpersons, faculties and delegates. Thank you, ma'am, for this opportunity. And today I am honored to present our original work. Let us see. Intraoperative cell salvage in neurosurgery, a case series. So I hope everyone will be having an idea about what is cell salvage. So for those of you wondering what is cell salvage, it's an autologous transfusion technique where we will be collecting, processing and reinfusing patient's own blood intraoperatively. So it reduces the allogenic blood transfusion.
session on the topic cross-sectional study for blood component utilization and patient blood management practices among obstetric patients with antepartum and postpartum hemorrhage at a tertiary care center in North India. So, antepartum hemorrhage and postpartum hemorrhage are the most common obstetric emergencies leading to significant maternal and fetal mortality. And management of these conditions often require use of blood components such as ISBT, FSC, RDTs, cryophosphatates, and ISBT. And overuse of these blood components can expose patients to various risks such as transfusion-transmitted infection, alloimmunization, allergic and hemolytic reactions. So, application of PBM principles to obstetrics can help healthcare providers make evidence-based transfusion decisions and also reduce the transfusion requirements and improve patient outcomes. So, basically, if you apply patient blood management in obstetrics, the three pillars would be: pillar 1 which consists of predicting and addressing antenatal anemia. Pillar 2 would be minimizing blood loss and correcting coagulopathy, and pillar 3 would be predicting and addressing the antenatal.
blood and we reinfuse the autologous blood back to the patient. So we reduce the allogenic transfusion and he had a very stable recovery. His total hospital duration was 10 days and ICU stay was around 2 days for observation, and he doesn't require any ventilator support. Looking into his HB trend, preoperatively his HB was 13.5 gram per deciliter and intraoperatively dropped to 9.7 gram per deciliter, and later we infused around 464 ml of blood where 240 ml is from the cell saver machine and 224 is allogenic blood. After that post transfusion his HB raised to 12.2 gram per deciliter. So when we compare between the allogenic transfusion and the cell saver autologous transfusion, in cell saver there is no risk of cross-matching error or immune reaction, and we doesn't have any risk of hypercalcemia because we doesn't use citrate for anticoagulant, we use heparin, and the infection risk is minimal because we are using patient's own blood and it is in a closed sterile system. Group typing and cross matchings are not required. It is quickly and readily available in the OT. We can be immediately processing and reinfusing the blood when we encounter major bleeding. And speaking about 2-3 DPG and ATP levels, it is depleted in stored blood which can lead to decreased oxygen delivery, but it is preserved in the cell salvaged blood, where we can provide improved oxygen delivery to the patient, and the cells are less viable in stored blood compared to the cell saver blood. Here the cells are more fresh and we can be reinfused within hours. Speaking about the cost, it is cost effective in nature in case of high blood loss surgeries, and it is more acceptable to JHOS witnesses. My take-home messages are intraoperative cell salvage is safe in neurosurgery for patient blood management. It is cost-effective and quickly available. Complications are rare, but it requires vigilance. Operator training is the key for its maximum application across specialties. We need to watch for rotum and tape in case of dilutional coagulopathy. And I strongly believe that we can maximize its usage across specialties like obstetrics, surgery, orthopedic surgery, etc., where we encounter more bleeding. And to summarize, Cell Saver complements patient blood management. It is a tool which has to be used judicially to reduce unnecessary exposure and conserve precious blood resources. These are my references. Thank you.
Very nice presentation. We should be moving to the next presentation. This is the last time.
हम वहाँ पे ना आगे जाके ना वो होगा।
Our next speaker is Mrs. Aswati here, Senior Nursing Officer, Department of Transfusion Medicine, AIIMS Rishikesh. Her areas of interest are therapeutic warfare, patient blood management techniques. Experience is 14 years of clinical experience, 1 year teaching experience also, and she has done other certified courses like ACLS, BLS, ACTL. So we can start with your presentation.
Good afternoon to everyone. Being a nursing officer, I would like to share my experience in the domain of transfusion medicine. As in recent years, as the brand transfusion medicine is advancing, our nurses' roles also transforming. So here, we can discuss some expanding role of nursing officers in modern blood bank and transfusion medicine. It is a pilot study. Please consider it as a trial run. With rapid advancement in transfusion medicine, the role of nursing officers has evolved beyond routine support to encompass critical decision making and patient care responsibilities. Aim to highlight the evolving and critical role of nursing officers in modern blood banking and transfusion medicine, focusing on patient safety, efficient care, and donor engagement. On to the objectives, to define the key responsibilities of nursing officers in transfusion services, to demonstrate the role in emergency triaging and transfusion safety, to showcase the involvement in donor counseling and education, to underline the contribution to quality assurance and audits, to encourage professional development through training and clinicals. Methodology, focused group discussion. As I told, it's a pilot study. The number of participants were 20, among that 7 nursing officers and 13 doctors in transfusion medicine, AIIMS Rishikesh. The salient points were noted. Most of the participants felt that the expanded roles are triaging emergency versus routine blood issues, counseling patient attended on donation and transfusion queries, maintaining communication with the ward staff, managing adverse transfusion reaction and issuing blood components, and training nursing personnel. Here we can more focused on the practical side so that we can improve the quality of patient care. Not only the quality of patient care, but also it strengthens the safety and sustainability of our blood supply chain. Conducting clinical audits of transfusion practices, operating a nurse-led follow-up clinic for the deferred and repeat donors. After a trial run, we come to the result that improved patient safety through proactive nursing roles, higher satisfaction among the donors due to effective counseling, better documentation and quality chain maintenance, successful care handling of adverse transfusion reactions, greater nurse-led initiative in donor retention. Limitation of this study, less number of participants and statistical analysis not done. The future scope for the study with more participants, we can include the participants of other department also. Let me conclude. The expanded role of nursing officers ensures safer transfusion practices. They provide essential support to both donors and recipients. The training and auditing effort maintaining high standards in care. Their presence in clinical enhances continuing quality of services. Nursing expertise is indispensable in modern transfusion services. We thank to the administrators for encouraging training and training initiatives, appreciation to our faculty, technical staff for continued support, gratitude to all voluntary donors and patient caregivers. Special thanks to the nursing staff of transfusion medicine. Thank you.
Very good. In fact, I'm really happy to see the last two participants, and their role should be acknowledged. They are the transfusion nurses who are there in the ward, and they're actually giving this transfusion to our patients. And all kudos to you, for bringing all the stakeholders on the stage. Very good. So if there are any questions? Okay, I have just one comment. The doctor was talking about chatbot, AI. So if we have, advanced some model of, this chatbot, and if we have artificial blood, I think our branch will not exist in the future. Thank you so much. Thank you. We can wrap up.
So that brings us to the end of session 3. On behalf of the team, we thank all of our speakers for sharing such honest and practical experiences. We now request our respected chairpersons, Dr. Anupam sir and Dr. Susant sir, to kindly felicitate our speakers. First of all, Dr. Ashish Jain sir. Next is Dr. Daud sir. Dr. Baidi. Dr. Priyanka. Ms. Aarti. Ms. Aswati.
नंबर लिखा फोन करो नंबर लिखा हुआ है हाँ ये नंबर उनका ले बराबर हाँ ये 7
And now it's our turn to express gratitude to our chairpersons for leading the session so smoothly. May I request Dr. Meenu Bajpai ma'am and Dr. Lalit Tantole sir to kindly come forward and felicitate our chairpersons. Dr. Anupam Verma sir and Dr. Sushant Kumar Menia sir on behalf of the organizer. So thank you all once again, speakers, chairs and our wonderful audience. So now Dr. Priyanka Rathod, final year PG resident of Department of Transfusion Medicine of AIIMS Rishikesh will take over here onwards. Thank you.
Thank you, sir. Good afternoon, everyone. So let's get up for a highly interactive session. And as we move on from theory to practice in our discussion of patient blood management, this session is dedicated to real-world implementation and translating guidelines into action and teamwork into outcomes. Let's begin our session 4, stepping into the real world of PBM implementation in the hospital. To chair this session, it's my privilege to welcome respected chairs for this session, Dr. Manish Raturi sir, Professor Transfusion Medicine, Himalayan Institute of Sciences, Uttarakhand, Dr. Nidhi Keli, Additional Professor Emergency Medicine, AIIMS Rishikesh. Dr. Manish Raturi sir is a Professor in Department of Immunohematology, Swami Rama Himalayan University, Dehradun, India. Sir's achievement is 12+ year teaching experience and clinical experience in transfusion medicine. Professor Associate and Assistant Professor roles at SRHU, MAHU, Manipal and AIIMS Rishikesh. 106+ publications, BCHS Travel Scholarship United Kingdom 2024 and 25, Global Investigator Award, Korean Society of Laboratory Medicine 2023, 14+ national and international grants and awards, Gold Medalist in MBBS, Editorial Board Transfusion Clinic of Biology, patent holder, and expert in biosafety, hemovigilance, rare donor registry, apheresis and hematology. Now I'd like to request Dr. Manish Raturi sir to introduce our speaker for the session.
So it's a proud privilege to introduce my mentor in a way and my teacher also, Professor Geeta Negi ma'am. She is Professor in Head Department of Transfusion Medicine and Blood Bank, AIIMS Rishikesh, and Madam has been a FAMA Fellow from 2014. She is a chairperson, mentor, and Medical Humanities Unit also she is headed. She's done vast work in the field of transfusion medicine with lots of achievements and awards. And one of the awards that I would like to highlight would be Best Teachers Award from Chief Minister in 2013. And that was, I think, in Himalayan Institute now, where I'm currently working. And she's also been awarded Best Teachers Award at AIIMS Rishikesh in 2021. And also Him Ratna Award from Governor of Uttarakhand 2020. So it's a proud privilege to welcome ma'am. So can we have a huge round of applause, please?
Good afternoon, good evening to everybody. So coming to the continuation of what we saw in the morning. So how many people remember that role play? Show of hands. Because if you don't remember, then they'll do it again. You all remember? Yeah, then? Okay. So we'll continue. So if there's anybody who was not here in the morning, I'll just quickly revise. So there was a poor patient called मिस्टर असहाय यहाँ बैठे हैं, मिस्टर असहाय, इन्होंने भी हाथ खड़ा किया, तो इनकी सर्जरी होनी थी. एंड व्हाट हैपेंड वाज दैट द एनेस्थेटिस्ट एंड द सर्जन्स दे वर रियली इंसिस्टिंग ऑन ब्लड ट्रांसफ्यूजन्स फॉर हिम एंड ही डिडंट वांट. तो आखिर में वो माने नहीं एंड इन्होंने भगवान भरोसे वाला एक ऐसा जेस्चर किया, अब तो भगवान ही जाने क्या होगा, क्योंकि खून भी चढ़ रहा है, सर्जरी भी हो रही है. सो नाउ आफ्टर दैट व्हाट हैपेंड दैट now I have some more characters to introduce. So Dr. Raktasev, who is from the blood bank. Can I have Dr. Raktasev? So now I am introducing from the Transfusion Medicine Department. Please give him a big round of applause. And now can I request the other doctors to join him? So if you remember from morning, the surgeon, Dr. G. Scalpel, and the anesthetist, Dr. Keto. And we also have our nurse, Miss Casual. Please don't mind the name. But you'll understand why I'm calling her Miss Casual. And then there's one more person behind. Haath khada karo. So please guess who he is and what he is doing. What is he up to? मुझे तो समझ नहीं आया अभी तक. So now let's see what Dr. Raktasev has to do and say.
Team, I would like to present the implement patient blood management for the case of Mr. Asahai. He got anemia and he's planned for elective hip replacement.
But Dr. Raktasev, patient blood management का क्या फायदा? We have been managing fine without it.
Agreed, but बहुत सारे papers publish हुए हैं जिससे हमें पता चलता है कि patient blood management effective है. It can reduce the transfusion reaction and mortality in the patients as well as ये cost effective भी है.
PBM का impact nursing practices पे तो नहीं पड़ेगा ना सर?
Definitely पड़ेगा. इसके लिए आपको patient की hemoglobin की close monitoring करनी पड़ेगी. साथ में अगर excessive blood loss हो रहा है तो you can use tranexamic acid.
बट एज यू सेड कि ये पेशेंट ब्लड मैनेजमेंट ये बस पेपर में तो नहीं है ना, इसको प्रैक्टिकली कैसे करोगे?
वी कैन मेक अ प्रॉपर SOP फॉर इट एंड इसमें हम नर्सेज और डॉक्टर्स का हेल्प ले सकते हैं और साथ ही हम रेगुलर ऑडिट भी करते रहेंगे ताकि चीज़ें प्रॉपरली वर्क कर रही है उसका फॉलोअप भी ले सके.
बिगनिंग टू सी द वैल्यू, लेकिन इम्प्लीमेंटेशन पेशेंट ब्लड मैनेजमेंट का करेगा कौन?
We will make a proper patient blood management team जिसमें हम regularly review और data analysis and training करते रहेंगे.
पर ट्रेनिंग कैसे करेंगे सबकी? सबका काम भी बहुत बढ़ जाएगा. काफ़ी लोगों से तो हमें रेजिस्टेंस भी मिलेगा. लेकिन स्टार्ट करते हैं. We'll start with hands-on sessions and workshops. Basic patient blood management का principle समझना भी तो ज़रूरी है.
Agreed. But इसके पहले whole blood transfusion का भी concept आया था. फिर हमने blood component transfusion भी start किया था जिसमें काफ़ी रेजिस्टेंस आई थी. उसी तरीके से हमें पेशेंट ब्लड मैनेजमेंट इंप्लीमेंट करने में भी काफ़ी रेजिस्टेंस आने वाली है.
एग्जैक्टली. टाइम टू टाइम हम आपको इम्प्लीमेंटेशन का प्रोग्रेस भी बताते रहेंगे, लेकिन पेशेंट्स को कैसे एजुकेट करेंगे?
पेशेंट को हम सर्जरी से पहले लीफलेट्स, फ्रीक्वेंटली आस्क्ड क्वेश्चंस, ब्लड ट्रांसफ्यूजन के बारे में इंफॉर्मेशंस ये सब दे सकते हैं जिनसे उनका भी नॉलेज बढ़ेगा.
सही है, बट इसके लिए हमें एनेस्थीसिया और क्लिनिशियंस का रेगुलर कोलैबोरेशन चाहिए होगा.
वो देखिए, क्लिनिशियंस और इन सब की तरफ से तो हमको थोड़ा रेजिस्टेंस आएगा ही. एडमिनिस्ट्रेशन में भी कल्चर चेंज करने में टाइम लगेगा, लेकिन रिजल्ट्स और ट्रेनिंग से हम सबका माइंडसेट चेंज कर सकते हैं.
क्लिनिशियन का तो रेजिस्टेंस आना ही है, साथ में हॉस्पिटल एडमिन का भी रेजिस्टेंस आएगा.
और एक आइडिया आया, हम अपने कोलीग्स के बीच में से पेशेंट ब्लड मैनेजमेंट सुपरस्टार्स भी चुन सकते हैं जिनसे बाकी लोगों को भी काफ़ी मोटिवेशन मिलेगा.
ट्रू, सबके कंबाइंड एफर्ट्स से अडॉप्शन और भी अच्छे हो जाते हैं.
So as you all saw that this was a case discussion meeting where the transfusion specialist was trying to convince the clinicians, and the end was that everybody was making plans with him. However, they did discuss the obstacles because that is something which is very, very expected. So they enumerated some of the obstacles like getting the confidence of the clinician, which I hope you all agree is the foremost problem that the blood bankers think that, people will think it's just new things that transfusion people keep on saying. So getting their confidence, and then also what they enumerated was getting support of the management. It is so difficult. So which is what they said, getting आपने clinicians को भी अगर convince कर लिया, but then getting management support. And morning में you would have noticed in one of the session, Dr. Ajay Gandhi, he said that in some countries it is a national mandate, and then country का mandate है, institute का भी हो सकता है mandate. It is difficult. So these were some of the obstacles that were pointed out in this session. इसके अलावा what they discussed was training issues. People are not trained. अभी हमारे blood, even transfusion people are not trained. So you're having to train the nurses, having to train your own colleagues. It is not so easy, training your own colleagues, telling people that what you're doing, you need to do it a little bit differently. So even that is a thing that came up in this session. So all these obstacles and some tentative solutions were discussed in that. And then what happened? So some things were done and some meetings were undertaken by Dr. Raktasev because he wanted to implement. So the team will now show you some of the things that they did. So here you can see a meeting in progress. The medical superintendent is there and a faculty member is discussing.
गुड मॉर्निंग सर.
गुड मॉर्निंग
सर ये देखिए हमने हमारे डिपार्टमेंट में पेशेंट ब्लड मैनेजमेंट जो है इम्प्लीमेंट किया था और उसके काफ़ी सेटिस्फैक्ट्री रिजल्ट आए हैं.
गुड, आप इसको ऐसे ही कंटिन्यू करते रहिए.
हमें मैनेजमेंट की तरफ से थोड़ी और हेल्प चाहिएगी, जैसे कॉस्ट में और स्टाफ में, इन सब चीज़ों में हेल्प चाहिएगी मैनेजमेंट से.
बिल्कुल, आपको जिस किसी भी चीज़ की ज़रूरत है, जैसे स्टाफ से लेकर या हमारे इंस्ट्रूमेंट से लेकर, जो भी आपको चाहिए होगा मैनेजमेंट आपकी पूरी सहायता करेगा.
ठीक है, थैंक यू वेरी मच सर. ये पेशेंट ब्लड मैनेजमेंट सक्सेसफुल रहा.
CME Symposium Workshop.
So these were some of the other things that after that meeting they implemented in the hospital.
Award.
Somebody also suggested that awards can be given.
Hello, I'm Dr. Arushi, Faculty of Obs Gynae, and I practice patient blood management in my department, and results were really great, and I got an award for it. Thank you so much.
So faculty feel good if you give them small awards. So this is something which these people wanted to highlight, that there are some very easy things to do. You can easily conduct regular, but you'll have to, invest your time, your energy, and very creatively address this without a hint of saying that, we are teaching you or something. We can have meetings, we can discuss with them, brainstorming, ask them for ideas. All that can be done. So all these things were done by Dr. Raktasev. Now, 2 months later, so Dr. Raktasev called another meeting.
Okay team, time to implement patient blood management. कौन-कौन है on board?
मैं तो पिछले 2 महीने से पेशेंट ब्लड मैनेजमेंट को प्रैक्टिस कर रहा हूँ. वन मैन निंजा आर्मी.
Hold on, Dr. Kito. This patient blood management thing even legit, or it's just a new fad?
नहीं. Patient blood management is the game changer. ये blood transfusion medicine का future है.
और सोचो हम कितना ब्लड भी बचा पाएंगे. We will be the blood saving avengers.
Come on, Dr. Scalpel. We will give you right algorithm. And इसमें काफी obstacles आने वाले हैं.
हाँ, I understand. Maybe clinicians are resisting, like good old practices. But ठीक है, हमारे continuous effort से वो भी समझ जाएंगे.
We will show them the right data. और वो खुद बोलेंगे कि patient blood management तो होना ही चाहिए.
So now there is another patient. So another few months later, so there is a surgery which has happened. The same surgery as that first case of Mr. Asahai. वो तो चले गए हैं घर, but now there's the same surgery, same scenario. He is also anemic. There is the same surgeon, the same anesthetist. So now let us see what is happening. Saksham ji को लाया जाए. The difference is that this is a post-operative scenario. This patient was also pretty apprehensive for blood transfusions.
Good morning, Mr. Saksham. Good morning, ma'am. आपकी कल सर्जरी बहुत अच्छी रही. अभी आप बेटर फील कर रहे हैं?
हाँ मैम अभी ठीक है।
मिस्टर सक्षम, आपको एनीमिया था। उस समय हमें लगा कि आपको ब्लड ट्रांसफ्यूज करना पड़ेगा, लेकिन हमने कुछ ऐसे प्रैक्टिसेस किए जिससे आपको ब्लड नहीं चढ़ाया गया सर्जरी के दौरान।
अच्छा जी।
आपका हीमोग्लोबिन चेक करके आपको आयरन सप्लीमेंट दिए थे ताकि सर्जरी से पहले आपका हीमोग्लोबिन ऑप्टिमाइज हो जाए।
अच्छा, मन तो बहुत डर लग रहा था, मगर पता नहीं कितना ब्लड चढ़ाऊंगे मेरे को।
मैंने सर्जरी के दौरान कंट्रोल्ड हाइपोटेंशन और डॉक्टर साहब ने तो पेडिकुलर सर्जरी भी किया, जिसकी वजह से आपको ब्लड की जरूरत ही नहीं पड़ी।
अच्छा, ये तो बहुत अच्छी चीज़ है जो आपने मेरा ब्लड मेरे को ही चढ़ाया। मैं तो सर कल छुट्टी करा के यहाँ से जब अपने गांव जाऊँगा तो ये जो मेडिकल एजुकेशन है इसको वहाँ पर जाकर कंटिन्यू करूँगा, अपने गांव में सभी को बताऊँगा कि आपने इतनी अच्छी टेक्निक यहाँ पर जो उपलब्ध कराई है, इसके लिए बहुत बहुत धन्यवाद। राम राम जी।
So the patient is happy now this time because he didn't have to be transfused and he seemed happy also. वो पहले वाले मरीज थोड़ा दुखी दिख भी रहे थे, ये वाले मरीज खुश हैं, खुशी खुशी गए हैं because his anemia is also balanced now. इनको आदत पड़ गई थी उस anemia में रहने की, but अभी now this patient is no more anemic. So I asked you all to notice that young fellow जो इधर उधर झांक रहे थे. I hope some of you noticed. कौन थे वो? Who was he? He was an intern. So let us see what that intern is up to now. So Dr. Raktasev के पास वो आए हैं. This is another 2 months later and it seems like it is his blood bank posting.
गुड मॉर्निंग सर।
गुड मॉर्निंग
सर, आज से मेरी ब्लड बैंक में ड्यूटी 2 वीक्स की पोस्टिंग जो है वो शुरू हो रही है।
तो फिर एक्साइटेड हो पोस्टिंग को लेके?
हाँ सर, मैं बहुत एक्साइटेड हूँ मेरी पोस्टिंग्स को लेके।
तो इसके पहले कहाँ पोस्टिंग थी तुम्हारी?
सर, इससे पहले मेरी पोस्टिंग सर्जरी डिपार्टमेंट और उससे पहले एनेस्थीसिया डिपार्टमेंट में थी।
तो तुमने वहाँ क्या देखा?
मैंने देखा सर कि आप अपने कोलीग्स सर्जरी और एनेस्थीसिया कोलीग्स के साथ आप डिस्कस कर रहे थे एक केस के बारे में जिसका मेजर ऑपरेशन होना था, लेकिन उसमें पेशेंट ब्लड मैनेजमेंट इम्प्लीमेंट करके आप लोगों ने उसे बिना ब्लड ट्रांसफ्यूज किए एक मेजर ऑपरेशन को ईजिली हैंडल कर लिया विद द यूज ऑफ न्यू टेक्निक्स लाइक हीमोडाइल्यूशन एंड ऑटोलोगस डोनेशन की मदद से।
तो तुमसे क्या सीख लेते हो?
I learned from this case that I took vows to implement patient blood management throughout my life, and I also encourage my colleagues to implement patient blood management throughout the life, and I will not transfuse a single unit of blood without any proper indication because every blood drop matters.
Good.
Thank you, sir. So apart from being fun, the role play in the first meeting, you all saw some obstacles which everybody pointed out. So we all agree with those obstacles, and there are some more also. And then in the second meeting, they suggested ways how to overcome and how they have overcome some of them. And as I've been also noting down since morning, some of those things were also here. For example, they said we will review some data, we will look at evidence-based management. So some of the trials have been mentioned in the morning by Dr. Satyam. He talked about the ETNO trial. So all these things, there are solutions to everything, which is what I mean to say. And then Dr. Gandhi also gave us a very detailed thing when he said that things have to be patient-centric. So I hope you all have noticed here, the stress was on patient centricity, rather than doctor centricity. उनके OT schedule के हिसाब से नहीं. It is based on, of course the doctors understand the patient's needs, but they also listen to what the patient wants. It's his body. Whether he wants a transfusion, if he wants less transfusion, PBM helps. So some of these things were also referred to in this role play, and I think the residents have very successfully pointed out those things, and I was actually pretty apprehensive that instead of taking a lecture, a PPT thing, I am handing it over to the residents. Will all the points come out? But I think they've done a pretty good job. And the reason for having the doctor, the intern, उसका एक लास्ट में एक्स्ट्रा सीन भी ऐड किया गया. So my aim here was that everybody has to understand that these young minds have to be influenced. जो senior हो गए, they have to work on these young minds. So this intern is going out with the thing. Now whether he joins transfusion or pathology or microbiology or whatever branch he joins, he may become a CTVS surgeon, he may become a neurosurgeon, a hemato-oncologist. He at least has something in his mind कि ऐसा कुछ मैंने देखा था. He may or may not remember it fully, but he will have those things and he will here or there कहीं ना कहीं उसके दिमाग में रहेगा कि I have seen these things and I should implement them. So So here this was an exaggeration. He said, I'm taking a vow, all that. So we are exaggerating everything. But then the point is that using such things, we talk about training your doctors. So you can use this kind of small, silly, maybe sometimes role plays and all. So the message reaches the heart. खाली PPT से message नहीं जाता. So if you want soul in your trainings, try to go for some of these techniques. Just wanted to demonstrate कि कोई भी चीज़ का message if you have to pass on, so it can be done with things like this. PPTs are just to help us, but so I hope the message got regarding obstacles and potential solutions. Thank you.
Further, I would like to invite Dr. Daljit Kaur ma'am to felicitate Dr. Manish Raturi sir.
The whole team can come for the picture. Doctors, Dr. Rakt Sev, aa jaiye. All of you. Thank you. All the actors, please come. Dr. Ashish, Assistant Director, aa jaiye. He was the Assistant Director for this role play.
Thank you, ma'am. We now begin an exciting panel discussion titled Blue Sky Thinking, Establishing Patient Blood Management Strategies in a Multidisciplinary Approach, where our expert will share the futuristic strategies for implementing patient blood management in a multidisciplinary hospital setting. To moderate the session, I would like to invite Dr. Daljit Kaur ma'am, Associate Professor, Department of Transfusion Medicine, AIIMS Rishikesh. Ma'am is an Associate Professor of Transfusion Medicine in AIIMS Rishikesh. Ma'am has done MBBS from Government Medical College and Hospital, Chandigarh, MD Transfusion Medicine, PGI MER, Chandigarh, Fellowship in Medical Education, FEMR 2020. Achievements include member of ISTM, Special Interest Group for Patient Blood Management, NABH Assessor for NABH Blood Bank Accreditation Program, Harold Gunson Fellowship for MD Transfusion Medicine, Thesis Student 2024, awarded for paper presentation at AIIM Muscat 2024, Science and Engineering Board International Travel Grant 2019, publication in national and international journals, membership of professionals.
Thank you so much, Priyanka. So, good afternoon all. After a stunning high energy session, let's move on enthusiastically to the finale round, panel discussion. How is the Josh? Intact? Chalo, happy to see you all. So, one of the most enticing concepts behind PBM is that it is one of the few areas in medicine where risk can be reduced, outcomes can be improved, and money can be, saved. We have been hearing this since morning that we can save a lot of money. So, and all this is happening at the same time. So, it's natural that we are going to discuss it and implement it, in the best possible way. So, through this session, that's Blue Sky Thinking, establishing a PBM strategy in a hospital setting, let's get going towards developing a successful program in a hospital setting through a panel of multidisciplinary experts. I would like to humbly invite and introduce our experts for this session, and I would request them to, all of them to take position on dais. First, I invite Professor Meenu Bajpai, ma'am. Can I have the CV? Dr. Priyanka, can I have the CV? Professor Meenu Bajpai, ma'am. She is heading the Department of Transfusion Medicine at ILBS, New Delhi. She's a chairperson of SIG group on therapeutic apheresis by ISTM. She's member committee for national policy on hemoglobinopathy. She's faculty in charge for PDCC courses at ILBS. For apheresis technology, immunohematology and blood banking, and transplant immunology. Her areas of interest and passion are apheresis and immunohematology. We welcome you, ma'am. So next I invite Professor Uttam Kumar Nath. He is professor and head of medical oncology hematology, AIIMS Rishikesh. He's MD Internal Medicine and DM Clinical Hematology, and he has vast experience of 16 years in teaching DM course. So big round of applause. We have great teacher with us. Principal investigator of 4 extramural research grants. 15 years of experience as PI and co-PI of phase 1, 2, 3, 4 global multi-centric clinical trials. So, and fellowship and of Indo-American Cancer Association and International CML Foundation. His mentor, Ramalingam Swami Fellowship, DBT, Government of India. His member, Subject Expert Committee, CDSCO and DCGI. We welcome you, sir. Next, I invite Dr. Lalit Dhantole. Dr. Lalit, he is MD Transfusion from SGPGI Lucknow. He is now consultant and head transfusion medicine, Fortis Hospitals, Mulund, Mumbai. And his achievements include implementation of therapeutic apheresis and stem cell cryopreservation program at Fortis Hospital. He has performed more than 250 procedures with the span of 2 years, including cascade filtration. And he has received PG Fellowship Award in 2012 by ISTM. He's an active member of Federation of Bombay Blood Banks. He's a certified cellular therapy specialist by AABB and George Washington University. Thank you. We welcome Dr. Lalit. Thank you for coming over all the way from Mumbai. And next, I invite Dr. Anish Gupta, who is Associate Professor, CTVS at AIIMS Rishikesh. He has done his MCH from AIIMS. His achievements include, he has pioneered pediatric cardiac surgery and aortic surgery program at AIIMS Rishikesh. He has performed over 300 congenital heart surgeries, and he has over 50 index national and international publications. He has been delivering a lot of lectures, and we often see him delivering lectures and trainings through social media as well. He is really a tech-savvy person. So we welcome you, Dr. Anish. Next, I invite Mr. Elvin. So Mr. Elvin, he is working with us at AIIMS Rishikesh. He is a nursing officer, registered nurse, and he has over 13 years of experience in critical care units. And he has worked in hospitals who has accreditation, JCI, NABH, and NAC accredited hospitals. He is currently working as ward in charge CCU at AIIMS Rishikesh, and he has also worked as quality nurse and infection control nurse. He is certified with ATCN and ACLS, and his achievements include, he has achieved Best Nursing Officer Award at institute level at AIIMS Rishikesh, and he has research publication as well. We are privileged to have you, Mr. Alvin. Welcome. So since morning, we have heard that PBM is the quality practice of medicine with regard to preventing and managing anemia and optimizing coagulation to prevent or reduce bleeding, promoting optimal blood conservation and achieving all of these goals with an evidence-based patient-centered focus in order to improve outcome. Now let's dive deeper into several other essential aspects related to this which we might not have covered earlier, and let's deliberate on those aspects for PBM program. So we have 5 speakers and we'll stick to time. We don't want you all to, waiting for Ganga Aarti. We know we have a lot of, people coming over from all over India. So myself and my panelists, we will try our best. So maybe we can stick to 5 to 6 minutes per speaker. So first of all, I'll ask Meenu ma'am. Ma'am, we know that you have vast experience at ILBS, I think over 1.5 decade. So I would like to know how does point of care testing influence the PBM program? And since seeing your experience, what PBM strategies are being applied at your centers while they are performing liver surgeries? Please could you enlighten us?
Come to this. For liver transplant, I just want to give a small background. I have a hematology expert beside me. That a liver disease patient is a patient with rebalanced hemostasis. So over here, what happens, he has very low levels of coagulation factors, procoagulant factors as well as anticoagulant factors. The balance is very fragile. And whenever you're transfusing this patient, you tilt that balance. So he may either go into hemorrhage or he may go into a thrombosis. So it's very important not to transfuse unless required in this patient category. The other thing is the laboratory tests will not always, the routine laboratory tests, the routine laboratory tests will not reflect the patient's true hemostasis position. That can only be taken by two ways. Either the patient is bleeding and you're giving a therapeutic support in terms of blood components, and the second is point of care testing. So the point of care testing is very critical in these patients, and we have been having it since 2014. We have been having initially TAG and then Zotam. Rotam is even better than TAG. You have FIPTEM and XTEM. So pre-op, intra-op and post-op, all the support we give is based on the Rotam, the point of care test, which is there in the liver transplant OT side. It is available over there, and it improves the outcomes vastly. When we started the program and we were doing routine tests and it was not so well thought out, we were preparing around 20 units of RBCs, 20 FFP, 20 cryo, and 4 units of single dose and apheresis. And now over 1.5 decades, now we are using point of care test, and we constantly follow the patient, and we are giving patients based on point of care testing, and now our preparation for the surgery has decreased drastically. From what we started with. Now we only prepare 10 units maybe of RBCs, and we have the rest of the components in place, and not much, maybe 1 or 2 SDA, single donor apheresis platelets. That's all we prepare these days. Now another point I want to point out, that if fibrinogen is affordable to the patient, it should be given. And there is a very important reason for this in liver disease patients. The reason being that von Willebrand's factor and factor VIII are acute phase reactants. They are already high in the recipient. Because of liver disease and because of all the inflammation, they are high. So when you're giving the patient fibrinogen in the terms of cryoprecipitate, you're also adding more von Willebrand's factor and factor VIII in the patient who already has a large amount of that. So that's problematic in these patients. So one of the things is give fibrinogen. Another is whenever we transfuse the FFP to these patients, FFP has a large volume, and it is going to, a single unit may only raise the percentage of coagulation factors by 1 to 2%. So over here you are very likely, if you're able to correct the coagulation factors, the patient will go into volume overload. And there will also be an increased risk of bleeding. Because of the increased portal pressure, portal hypertension, there's an increased risk of bleeding. So in these are ideal patients to give the current day PCC, which also has protein C and protein S, to decrease the risk of this, and to give fibrinogen. So wherever cost is not a constraint, it is better to give PCC and fibrinogen rather than giving this, what you call it, the cryoprecipitate and FFP, which lead to volume overload ever this. And so most of the GI bleeds, we don't transfuse any, we don't correct coagulation, we try to correct the bleeding spot, try to treat the bleeding in surgical methods in these patients. So there's a lot of things which have to be kept in mind when we are talking about what you call it, patient blood management in the liver disease setting and in the transplant setting in these patients.
That's amazing, ma'am. So rightly put. And since our institute is also heading towards, liver transplantation in future, so I would request Geeta ma'am also, and we can discuss that we should start in the right way only. So your experiences are like amazing, they're marvelous. So we should, rather than focusing on 6 SDAPs and 4 SDAPs, we should be, switching over to PBM and utilize 1 SDP, and we should advocate PCCs and fibrogen concentrate as well. So thank you, ma'am. You have very well addressed the points where clinicians can avoid arbitrary administration of blood components and can rely on point-of-care testing for timely diagnosis of anemia, bleeding, and coagulopathy. And point-of-care coagulation testing is most desirable in emergency and surgical settings where clinical diagnosis and interventions are time-sensitive. That's true. Thank you, ma'am. So let's move on to our next panelist, Professor Uttam, sir. Sir, I would ask you to, elaborate on the PBM strategies that can be employed for managing your subset of population, that is hemato-onc patients, for management of anemia as well as thrombocytopenia.
So there are 2 aspects. Like one is a patient who has a hematological malignancy or bone marrow transplant setting. And the other group of patients is any anemia patient with anemia walking to your OPD or being admitted with severe anemia. Now, if the diagnosis is known, it's possibly a nutritional anemia or you're suspecting nutritional anemia, then even at very low hemoglobin, your patient tolerates the anemia. Why? Because the hemoglobin has dropped maybe from 10, 11 to levels of 4 gram or 3 gram per DL over a period of time. So it is better tolerated by the patient, but the patient has hemodilution. So in this patient, if you are suspecting a nutritional anemia, then we should focus on correcting the nutritional deficiency rather than transfusing. But saying that if the patient has any cardiac comorbidity, or if the patient is in gross failure, or if the patient is symptomatic, like it is interfering with the activities of daily living, then very cautious transfusion strategy with packed red blood cells, maybe 1 unit or 2 unit, and not more than 1 unit in a day, with supervision to avoid volume overload, maybe with some amount of diuretics, maybe indicated and necessary initially. So it depends on the symptomatology of the patient. But often young patients with hemoglobin of 3, even lower, we prefer not to transfuse. So depends on your patient's comorbidities, the age, how much the severity of anemia is affected. And if the anemia is of acute duration, like hemoglobin has dropped from say 13 to 8 or even 9 rapidly in 2 weeks, 3 weeks, the patient becomes symptomatic even at hemoglobin of 8. So there you need to know the causes, like whether it's acute hemolysis, whether it's acute blood loss. There, if the patient has cardiovascular disease or ischemic heart disease, even you have to target a hemoglobin close to 9. In the critical care, in the CCU or ICU patients, we prefer a restrictive transfusion strategy, hemoglobin of 7 maybe. But again, if the patient has severe thrombocytopenia, say a patient with platelet count of 10,000, 15,000, the hematocrit has to be targeted close to 30. So you have to transfuse RBCs so that at the low platelet count level, your patient's risk of bleeding decreases. We all know the mechanism of increased risk of bleeding at low hematocrit because the platelets do not tend to interact with the endothelium.
Yeah.
Regarding thrombocytopenia, again, whether it's a prophylactic platelet transfusion or therapeutic platelet transfusion. Therapeutic means patient is having bleeding. You have to control the bleeding. And prophylactic means you don't want your patient to bleed. Suppose a patient on chemotherapy or a critical care unit patients with sepsis, you have to see whether the patient is having bleeding or not. If there is bleeding, even at platelet count of 20, 25,000, if there is coagulopathy like DIC, you may have to transfuse because there you have to control the bleeding urgently. But if there is no bleeding and patient is stable, not in sepsis, not febrile, there you can target a platelet count of 10,000. So if platelet count is less than 10,000, you transfuse.
So,
Okay,
so
because
you
that is
mean
the
so we
critical.
should not stick to absolute thresholds of platelet count? You were saying it's
No.
based on.
See, suppose a patient of aplastic anemia, his platelet count always remains low. They are being managed in the
Yeah.
OPD, so you don't need to transfuse. But 10,000 is the critical point because often they are having anemia.
Yeah.
They are having repeated infections. So if you don't want your patient to bleed and come with a critical bleeding, may have to transfuse.
So,
for leukemia patients, for
yeah.
critical care patients, 10,000,
Yeah.
if the patient is stable. But sometimes the patient is having infection.
True.
Fever.
So we also wanted to know that for such patients, other than, apart from blood components, what other, maybe pharmacological measures, what other
for
measures,
thrombocytopenic bleeding,
or for anemia,
for
what,
thrombocytopenic bleeding, there is no substitute for platelets. You can use adjunctive therapies, like you use tranexamic acid or EACA, the antifibrinolytics. But if the platelet count is very low, your patient is having fever. So fever and infection increases the consumption significantly.
True.
So even at platelet count of 20,000, there is risk of bleeding. You don't want the patient to have an critical bleed.
Yeah.
Minor bleeding is okay. So tranexamic acid or EACA
True.
Then again, I told you about the correction of anemia.
Yeah.
You increase the hematocrit to close to 30. If the patient is having lab parameters of DIC, you may have to target the platelet higher, 30,000. But in other settings, like even in the CCU or in the general wards, if the platelet count is say 10, 15,000, look for the cause. You have to do the workup urgently.
Thank you.
And another adjunctive policy
Yeah.
and strategy is to avoid drugs which increase the platelet consumption, like amphotericin B, vancomycin.
Absolutely, absolutely, sir. So you have touched the same theme which we were discussing in the morning. We have to look into the root cause first and then, start asking about blood components. It is as simple as that. And sir, you have...
About ITP.
Yeah.
Often we have ITP patients, platelet count 1,000, 2,000.
Yeah.
So whether to transfuse platelets or not. Earlier we were told, don't transfuse.
Absolutely.
Now the thing is, even the guidelines mention, if there is presence of major bleeding, then along with the ITP-directed therapy like intravenous immunoglobulin, steroids, or say rituximab, you have to transfuse platelets just to tide over the crisis. If a lady is having severe menorrhagia, if a patient is having GI bleed, then if a patient is hypertensive and with bleeding, with say retinal bleeding, you may have to transfuse initially till the time your drugs work. Because it's not all patients are not the same.
True.
So higher age, hypertension, these are risk factors for bleeding.
Yeah. And so since you mentioned that...
To add one thing over here, when you are transfusing in these conditions, don't monitor the platelet count.
Yeah.
Hemostasis is going to happen, but the platelet count won't rise.
True.
So you're just supporting the hemostasis.
True.
The platelets are going to get consumed at a very high
True,
speed.
true.
So you can't monitor by platelet count.
Yeah.
And bleeding is a vicious cycle. Bleeding causes anemia.
Anemia, that's what.
Patients tend to bleed more and the patient is at risk of critical bleed.
Yeah.
Target is to prevent critical bleed,
Critical
like intracranial
bleed.
bleed.
Rather than looking for 4, 6, 8 units of components, we have to target that. We have to prevent bleeding, we have to treat anemia. So thank you so much, Uttam sir, for enlightening the hall about this pertinent topic and how well we can plan our care for the oncology patients using PBM strategies. Thank you very much. So moving on to our next panelist, Dr. Lalit. So I would like to ask you, how does preoperative optimization of coagulation function aid in PBM implementation? And do you consider topical hemostatics and fibrin sealants a good adjunct in PBM implementation in surgical patients?
Okay. So good evening all. So the first question is basically for all routine surgeries, apart from the liver surgeries, the routine investigations, that is coagulation factors, PTA, PTT, INR, then fibrinogen levels, the platelet counts, will basically be, we can actually predict whether the patient will be bleeding or not. There are basic set targets for each and every surgery. Say, for example, neurosurgeries, the target will be on a higher side, but for all routine surgeries, the platelet counts and the coagulation factors will be all fine. What we need to see that preoperatively, if we manage all these coagulation factors and platelet counts, it is the intraoperative management, the loss will be on a lower side. So we are actually targeting the second pillar of the patient blood management.
Yes,
great. And suppose even if we have any sort of coagulation defects or platelet abnormalities, preoperatively we can actually manage it with biomedications. Say, for example, most of the coagulation factors like vitamin K, supplementation can be given, desmopressin can be given for platelet increment. So these will actually increase the coagulation system, stabilize the coagulation system, and it will help in intraoperative management. The second question is
topical hemostatics or fibrin sealants.
So the topical, the fibrin glue, it's basically a combination of thrombin and fibrin. So it's derived from human source. So that reactions which are associated with blood transfusion will be on a similar side. But what the thing is, it can be used for to control localized hemostasis. It can achieve localized hemostasis, not for arterial bleed or a prompt venous bleed, but localized capillary, and it can also be used in an areas which has difficult to access site. So, and it has been observed that these are as potent as the other surgical techniques like compression or Surgicel, even these kind of therapies, the fibrin glue is quite stable and can be used in these kind of scenarios.
True, true. Thank you so much. Thanks, Dr. Lalit. So aptly stated how topical hemostatic agents are used when surgical hemostasis is inadequate or impractical. For example, different areas as peritoneal or pleural bleeds or cut surfaces of solid organs, bones, bleeding near vital structures or nerves where your cautery might result in injury to such structures. So in those areas, which are, quite a good number of cases, there we can use this topical hemostasis. So Cochrane database review performed a meta-analysis of 7 quality trials of fibrin sealants, where this fibrin sealant was used to minimize perioperative bleed, perioperative blood transfusion, and they found a reduced rate of exposure to allogenic blood transfusion by 54%, which was coinciding with average reduced blood loss of 134 ml per patient. So that is quite significant, massive. So that means, undoubtedly this is a PBM strategy. So thank you, Dr. Lalit. So moving on to Dr. Anish, who is a CTV surgeon. I would like to ask what special perioperative measure you consider while performing your routine cardiac surgeries, which can actually help in avoiding allogenic blood transfusion, perioperatively.
Good evening, everyone. Ma'am, actually, we follow a multidisciplinary approach for patient blood management during our cardiac surgeries. So it starts right from the pre-admission phase. We take a history for any bleeding tendency, the drug therapy. Many of our patients suffering from coronary artery disease are on aspirin or ticagrelor, prazogel, these kind of drugs. And we look for any coagulopathy, and we have various scoring systems like will bleed score or maybe should not bleed score for CABGs, and there are many other ones. If the patient is in atrial fibrillation, valve patients, rheumatic heart disease, they will be on acetrom or other NOACs. So we optimize right from there. We have aspirin. These days we continue aspirin during surgery. We don't stop it. But clopidogrel will stop 5 days before surgery unless it is an emergency. And then we should optimize anemia, as already pointed out by in the morning. So then during surgery, we have a lot of different measures, which from anesthesia side and perfusionist side. Like from anesthesia side, sometimes we take autologous blood from the patient and we transfuse it after the surgery. From perfusionist side, there are things like ANVH. ANVH stands for acute normovolemic hemodilution. So basically they will take some blood from the patient before the operation and will maintain the normovolemia by giving some crystalloids, and will bring down the hemoglobin. Then during perfusion, when the patient is on a heart-lung machine, we do ultrafiltration. So there are basically 3 types of ultrafiltration. One is conventional ultrafiltration, which is like hemodialysis, sort of. And then we have zero balance ultrafiltration, where we do not make the patient negative. And but these things, they remove the inflammatory mediators, and all these things help in decreasing postoperative bleeding. And they bring up hemoglobin also. Then we have modified ultrafiltration. MUF is done once the cardiopulmonary bypass is weaned off. So that is by the aortic pressure. And we will remove some water and bring up the hemoglobin. And we have a study going on, MUF in adult patients, and it already has proven benefits in neonates and infants. Then we do something called as priming, autologous priming. So there are 2 kinds of autologous priming. One is antegrade, one is retrograde. So if the patient hemoglobin is good, maybe 13, 14, then once we do aortic cannulation, we put a cannula in the aorta and we attach it to a heart-lung machine. Then the perfusionist will take some blood back from the aorta into the heart-lung machine, and he has added some priming volume in the circuit, which will be like crystalloid. Maybe sometimes we add FFP also into it. So when he takes the patient's own blood into the tubing, the water in the tubing he will take out. There are different ways to do that. So that is a retrograde autologous priming. And then he can also do antegrade autologous priming. He can take there is another line in the venous system SVC, IVC, or maybe in a right atrium. So we'll take blood from there and we'll take out water from some other place. So by these things, we can remove the dilution that is happening by the heart-lung machine, and the hemoglobin will be optimized and will prevent the post-operative allogenic blood transfusion. We need good hemoglobin for this, and the hemodynamics should be okay. Patient's BP should be fine while we do all these things. Then there are other things in the post-operative period. We can use cell saver. Cell saver, I think cell saver is a very good device. We already Aarti gave a presentation on it. We used in non-cardiac surgeries also. And by using cell saver, we can, there are many Cochrane review there, around 40 RCTs, which has shown that it decreases the allogenic blood transfusion.
So, on an average, how many ABTs, how many PRBCs maybe you have avoided per patient, when you are performing, utilizing these strategies? So can you share your experience? So supposedly you were asking 6 or 8 units per patient. So how many have you actually reduced?
Sometimes if the perfusionist, it also depends on the perfusionist. If the pump is run in a good way and the hemostasis is good, then many times routine cases like ASD closure, mitral valve replacements, even CABGs, we have done without transfusion also.
Yeah, that's really amazing. So kudos. Yeah, sure. So happy to see that most of the PBM strategies are already there with cardiac surgeries.
Usually the platelet counts fall, even up to 20%. So what is your baseline platelet count where you are comfortable doing cardiac surgeries? We sometimes get referrals, the platelet count is 80,000, 90,000, patient is planned for some cardiac surgery. Because particularly for cardiac surgery, because of the pump, platelet count falls within 24 hours.
If it is not an emergency surgery, elective surgery, 1.5 lakhs we will try. If it is an emergency surgery, then at least 50,000. 50,000 for any 50,000 for emergency surgery and 1.5 lakhs for elective.
Bypass pump जब आप use कर रहे हैं उसमें ही तो ज़्यादा platelet कम होता है ना.
But if sometimes there are emergency surgeries, like patient is in heart failure, needs an urgent mitral valve replacement. So if the platelets are more than 50,000, we have done surgery and we can anyway replace them. Transfusion requirement will be high, but we have to do these emergency cases. I have refused patients with less than 50,000, but 50,000 above I am okay to go. Elective 1.5 lakhs.
No, but suppose if the count is around 1 lakh and it is an elective surgery, so you'll...
I will take a hematology opinion. Why it is 1 lakh? There must be some reason.
Because see, even for neurosurgery it's 1 lakh. Even for neurosurgery it's 1 lakh. So...
Sir, our CTVA surgeon, Dr. Anish, is motivated like Dr. Rohan, who was an intern. He is AIIMS Rishikesh student. So he's motivated enough that he will operate at lower threshold also.
So it depends on the urgency.
Because platelet transfusion, if you ask us, our opinion, if you have to do the surgery, platelet count is 80,000, 90,000, transfuse platelets. Okay. That is our, and target 1 lakh. That is what.
That was there.
What is the average loss of platelets on using the extracorporeal circulation?
After any surgery done on cardiopulmonary bypass, platelet count would be around 1.2, 1.2.
No. How many thousand? What is the decrease?
Difference.
What is the consumption by the pump?
Pre and post.
Almost 50%.
50% or no? It is. I think for just if it is around 40,000. There can be a dip of up to 40,000 by count. If it's 1.5, it might end up at 1.1.
I see, we send a CBC on day 0 of every patient, and I always see the platelet count something around 1 lakh, 1.2 lakhs after surgery. And before surgery, they are normal only.
Okay. That could be 1.8 or anything.
Maybe 2
till
lakhs,
4 lakhs,
1.8,
maybe.
2 lakhs.
Yeah, that could be. So thank you so much. That's great indeed. As I said, that happy to see that all the strategies have been already implemented for cardiac surgeries. And I would also like to share that several examples exist that document the benefit of these energetic PBM interventions during cardiac surgeries. Various studies from US report that implementation led to reductions in blood utilization, reduced transfusion-related adverse outcomes that significantly reduced cost, morbidity, and improved patient outcomes. So isn't it what we actually wanted? So we have evidence also. So next, I would like to ask Mr. Elvin. As a nursing representative, could you please share your role in implementation of patient blood management at ward side? And how can we involve patients in the decision-making process for anemia management in the pre-operative period as regards your PBM implementation in your area of posting?
Okay, ma'am, thank you. Good evening all, first of all. The NACE are the pillar bone system in the management because nowadays we are treating the patient as a multidisciplinary management. So in that, the nurse have to help, first of all, the team, like that. First of all, identify the cause. Cause means sometimes the anemia due to lots of administration of the infusions. So we have to maintain the adequate and accurate IO chart properly. Same way, the nurse have to identify the cause. Sometimes after the surgery, there are bleeding spots in the patients. So the nurse have to accurately and promptly identify these spots. So it's also helpful to identify the cause of anemia. Sometimes some drugs also will be reduce the count. So by taking the vitals also, that means some nosocomial infections also lead to reduced counts and also lead to anemia. So by assessing the patient in a proper way and in 24/7 times, we have to identify the cause, and it's easy for the team to identify the cause of the anemia. With the adjuvants or any therapeutic way we can manage, then it's better. Otherwise, we have to transfuse the safe way and effective way blood transfusion and blood clots. For that, the same in that time also they have to maintain the sterility, and also they have to proper sampling techniques and proper infusions, and avoid the contamination of the blood, and they have to maintain the temperature, and same way they have to preserve the blood also, because sometimes in the practical sections the requisition form and slips, all the things will be sent to with the patient relative. Then they will be taking the blood samples, and they will be went to tea shop and take a break, and after that they will be come to the departments. Then in that time the potency of the blood is also lost. So we have to educate the patient and team that the importance of the accuracy administration and the time importance also. We have to educate the patient and patient relatives also. So same way, we also check whether the patient have any adequate or need is there in the scenario. Same. So we have to check whether the importance. So in that time, we also document the things adequately. Sometimes the patient need only few volume of the blood for the transfusion, but in the PRBC, large of the volume will be received in the ICU sections. So we have to notify whether how much volume is patient needed. So based on that, the blood bank will be issue the adequate volume also. So like that, we have also preserved the blood and blood products also. Same time, in the decision-making time, we have to encourage the patient to take other adjuvants and other supplements for developing the counts. Sometimes in elective surgeries, the empowerment and mental strength itself will develop the blood count in adequate positions. So we have to educate the techniques that we have to use before the surgeries. And same way, in post-operative period, we have to tell the patients regarding the process or the steps which will be involved in the treatment. It's also helpful to improve the blood loss and also improve the blood count level also. So, and take appropriate decision because most of the patients doesn't know aware regarding the education, what they have to do while reducing the count, what they have to take, how they have to take, what route they have to take, like that. So the main nurse's role is that promptly identify the root cause and inform the team, and with the team they have to make a plan, and based on that the team have to intervene the patient to deliver the proper treatment for the patient to improve the count of the patient.
That's fantastic, Mr. Elvin. So team transfusion, our job is half done already. So Mr. Elvin, very well put. So nurses educate patients about PBM principles, the importance of minimizing blood loss, and the risks and benefits of blood transfusion. They advocate for appropriate blood conservation strategies and ensure that patients understand their treatment options. This patient-centered decision-making forms an integral part of PBM program. So with that, we are happy that we have a lot of PBM-trained officers in our hospital. So this is a good beginning. So summarizing the whole discussion, since the end goal of PBM is to achieve and maintain blood health, where patients receive proper care for their blood like other organs, it is imperative that we integrate it with health promotion or disease prevention model. This highlights the shift of care from eminence-based, that is transfusion and replacement oriented, to evidence-based care, which is PBM methodology, and integrating it with unique prevention levels. As Ravneet ma'am had mentioned in the morning, 5 unique levels, primordial and primary to quaternary, which will address the social determinants of health along with all other treatment factors that we discussed since morning. So the inputs which all of the panelists gave, that was icing on the cake. So we were enjoying our session since morning. Everybody added immensely to all the sessions. Hence, education plays a key role in the development of PBM program, which was well highlighted in the previous session as well. And all of you, our worthy panelists, also added a lot. I thank each and everyone for joining us and for your amazing inputs. Thank you so much.
A big thank you to all our panelists for such a vibrant and meaningful exchange of ideas. Your insights have emphasized the strength of interdepartmental collaboration and achieving the effective blood management. Now I'd like to request Dr. Geeta Negi ma'am, Dr. Daljit ma'am, and Dr. Ashish sir to felicitate our panelists. Dr. Vibham, would you like to join? Please request you to join us for the felicitation of our guests, please. Dr. Anupam sir, we request you to join to felicitate our guests. First of all, I'd like to request ma'am to felicitate Professor Meenu Bajpai ma'am, Head of Transfusion Medicine, ILBS, New Delhi. I'll request ma'am to felicitate Professor Uttam Kumar Nath, Head of Medical Oncology and Hematology, AIIMS Rishikesh. Further, Dr. Lalit Dhantole, Consultant, TM Fortis, Mumbai. Dr. Ashish Gupta, Associate Professor, Critical Care, AIIMS Rishikesh. Mr. Elvin, Nursing Team Representative. Further, I would like to request Professor Meenu Bajpai ma'am to felicitate our moderator, Dr. Daljit Kaur ma'am.
So, good evening to all. Now we are in the valedictory session. It is both an honor and privilege to stand before you today as we draw the curtain on what has been a highly enriching and thought-provoking CME program. Over the past one day, we have dived deep into the theme patient blood management, a topic of immense relevance in today's healthcare landscape. We have witnessed expert deliberations, cutting-edge presentations, and meaningful discussion that have enhanced our understanding and challenged our perspective. For this, actually, I have written a poem, so for PBM, and actually in the valedictory, I want to add what is actually from a patient point of view. एक पेशेंट क्या सोचता है PBM के बारे में, तो वो अपनी एक्सपेक्टेशन को एक मैं कविता के माध्यम से आपको बताना चाहूँगा। तो एक पेशेंट कहता है, एक बार कोशिश तो कर लो, एक बार कोशिश तो कर लो, ब्लड के अलावा और कोई रास्ता तो खोज लो। एक बार कोशिश तो कर लो, ब्लड के अलावा और कोई रास्ता तो खोज लो। सोचता है मरीज, सोचता है हर मरीज अपने ऑपरेशन के दौरान, सोचता है हर मरीज अपने ऑपरेशन के दौरान, शायद अपनी ज़िंदगी के पहले डर के दरमियान, शायद अपनी ज़िंदगी के पहले डर के दरमियान। कहता है सहमति देता हूँ मैं आपके हर निर्णय में, सहमति देता हूँ मैं आपके हर निर्णय में, भरोसा रखता हूँ आपके हर हुनर में। ब्लड चढ़ना एक व्यक्ति के लिए सामान्य बात नहीं होती, जोखिम के अलावा किसी और के शरीर के अंग को लेने की हिम्मत नहीं होती, जोखिम के अलावा किसी और के शरीर के अंग को लेने की हिम्मत नहीं होती। जानता हूँ कि आप मेरे भले के लिए ही ये सब कर रहे होगे, जानता हूँ कि आप ये सब मेरे भले के लिए ही कर रहे होगे, ब्लड की कमी से मेरा जीवन ना जाए, बस यही सोच रहे होगे। मुझे पता होता, मुझे पहले पता होता तो मैं अपना खून बढ़ा लेता, प्री ऑपरेटिव, ये मौका आए ऐसी नौबत ना आने देता। खैर, अब जो कुछ भी गूगल अंकल ने बताया है, ऑटोलॉगस या ब्लड सेल्वेज हो जाए तो क्या बात है। ऐसा भी नहीं कि मुझे ब्लड चढ़ने से बहुत कुछ बदल जाएगा, पर ये ब्लड किसी ज़रूरतमंद के काम तो आ जाएगा। एम्स ऋषिकेश में आया हूँ तो इलाज तो अच्छा होगा ही, और PBM इम्प्लीमेंटेशन के वैसे नॉन ट्रांसफ्यूज कहलाऊँगा भी, नॉन ट्रांसफ्यूज कहलाऊँगा भी। तो ये सारा समराइज है PBM को जो हमने सीखा है, मरीज़ ने क्या अपनी एक्सपेक्टेशंस की हैं, और अल्टीमेटली अगर हम प्री ऑप और इंट्रा ऑप को करते हैं तो वो एक खुशी खुशी जाएगा, जैसे रोल प्ले में बताया गया है। सो अब हमारे यहाँ फ्रॉम द सुबह से जो प्रेजेंटेशंस हुए हैं, दैट मिनी ओरल प्रेजेंटेशंस, और हमारे सारे पार्टिसिपेंट वेट भी कर रहे हैं कि भाई क्या रहा हमारा प्रेजेंटेशन का। इट्स एक्चुअली अ डेलिब्रेट curiosity inside in them. So it's time to encourage our delegates who presented their scientific work. And I would like to invite Dr. Sarika Agrawal for felicitation to judges, poster judges, and the presenters.
Thank you, sir. A very good evening to all. As we approach to the conclusion of enriching CME on patient blood management, it is my privilege to stand before you to celebrate the intellectual contributions made through our poster presentations. Before we announce the winners, we take a moment to thank those who made the evaluation process insightful and thorough, our eminent panel of judges.